Che. Che. Hello. Che. Che. hello, che, hello, che, hello, 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 hello,
இதயங்களே, ஜாதி, மதம், இனம்
check, hello, check, hello, check, hello.
Respected dignitaries, delegates, and friends, a very good morning to all. It gives me immense pleasure to welcome you all to Rejumed 2025, a continuing medical education program organized by the Department of General Medicine, Tirunelneli Medical College. Today is a day of learning, celebration, and heartfelt gratitude as we gather here for this special occasion. The name Rejumed embodies the rejuvenation of knowledge in medicine, and the CME promises to deliver just that with a stellar lineup of expert speakers, thought-provoking discussion, and valuable insights into the ever-evolving field of medicine. We are fortunate to have among us some of the finest minds in the medical fraternity who will guide us through today's enriching sessions. Today is a momentous occasion as we honor and celebrate the superannuation of a luminary in the field of medicine, our beloved head of the Department of General Medicine, Dr. Mohamed Rafi. Dr. Rafi sir's illustrious career, marked by unwavering dedication to patient care, inspiring mentorship, and exemplary leadership, has left an indelible mark on this institution and the countless lives he has touched. Dr. Rafi sir's contribution have elevated the standards of our department, making it a beacon of excellence in medical education and clinical care. His legacy will continue to inspire generation of medical professions for years to come.
Good morning to all. On behalf of the Medicine Department, I welcome all the delegates to the wonderful CME Rejumed 25. On behalf of the superannuation of our legend, Dr. Mohamed Rafi sir, Professor and HOD of Medicine, we are conducting this CME to honor him. On this occasion, we have got 5 scientific sessions. The first session will start now.
Without further ado, we welcome you all to the first session of our program. This session delves into the incredibly vital topic, mastering the art of managing metabolic encephalopathy. Metabolic encephalopathy is a complex clinical condition that demands not only medical acumen but also a comprehensive approach to management. Today, we are fortunate to have with us an expert whose depth of knowledge and experience in this field will undoubtedly enrich our understanding. Please join me in welcoming Dr. Allegation Sir, former HOD of Medicine, Tirunelneli Medical College, to lead us through this fascinating session. With a remarkable career in medicine and neurology, Allegation Sir is the perfect person to shed light on this important subject. As chairpersons for this session, I welcome Dr. Balan Sir, Senior Physician Kovalpatti, Dr. Paul Raj Sir, former HOD of Medicine, Tirunelneli Medical College, and Dr. Kandasamy Sir, Professor and Head of Department of Medical Gastroenterology, to the dais.
I welcome Dr. Bhoti sir also to chair this session.
Good morning, ladies and gentlemen. I draw immense pleasure to be here as an alumnus of this college. I'd like to thank the Department of Medicine as well as the organizing team for inviting me to give this nice chance to be the chairperson in this first session. In the name of the Superannuation Head of the Department of Medicine, Dr. Rafi, my close friend. He is very popular in the association, Government Doctor Association. He is very vibrant and has got a name among all doctors for his service. He is a good administrator as well as a nice teacher and good friend all. And view of this CME is being conducted by the Department of Medicine. The first stop being the metabolic encephalopathy. Metabolic encephalopathy is very common condition, but very easy to treat at one end, and the other end it still remains an enigma. For private practitioners, come through a common hypoglycemia and present and will recover within a single day or two. But the other end, it still remains an enigma. Even in tertiary care, will take many days to treat. So we are going to learn whatever we have to know, and we can relearn something from the speaker. And today the speaker here, the retired professor and a popular neurophysician, Dr. Alagation, who is an eminent teacher, an excellent speaker, and a popular neurophysician. He will open the topic and will throw light on this. Mic over to the speaker, please, sir.
The respected chairpersons, HOD of Medicine, Professor Rafi, and all the professors of various departments, assistant professors, and the students. So I am talking this topic on the eve of superannuation of our one of my well-wisher, best friend, Professor Rafi. So today I will discuss something about how to diagnose and how to manage the metabolic encephalopathy. So this is the overview of my talk, introduction, and what are the confounders and confusers in diagnosis of metabolic encephalopathy and clinical signs, and commonly seen metabolic encephalopathy conditions like hypoglycemic, hyponatremic, pulmonary, and hepatic and uremic encephalopathy. So any condition disturbing metabolic process, when it is acute and it is very severe, it may indirectly affect the brain function. So this brain dysfunction is mostly seen in almost all the critical illness following a major organ failure or sometimes following a multiple organ dysfunction. So when the brain fails acutely, it affects the other organs. So there is a reciprocal relationship between the brain and the major organs like kidney, liver, and gastrointestinal tract. They rarely fails from each other. So the sympathetic drive that stresses the heart, lungs, and major organs. And sometimes the multifocal, diffuse involvement of the primary CNS diseases, brain sublesion, in combination with aortic lesion, can produce a picture which is similar to that of metabolic encephalopathy. So a physician should need to rule out all these conditions by asking for an appropriate imaging methods. And there are a lot of confounders, confusers, especially in patients in critical ICUs, which may mimic like a metabolic encephalopathy. Finally, in the resolution of the symptoms, you treat the metabolic cause, the cause will be improved, but brain function takes some time to improve. So the brain disease is called metabolic. The commonly used clinical diagnosis of metabolic encephalopathy needs refinement. So encephalopathy generally explains a catch-all all conditions with some perceptual abnormalities leading to inattention, distraction, and decreased consciousness, and disturbed thought and memory. So when the conditions are clearly called as metabolic, they always do result from the insufficient substrate, oxygen interference, cerebral enzymatic activity, transport of metabolites into the brain. So encephalopathy often correlates with organ failure using some qualifiers like uremic encephalopathy, hepatic encephalopathy, pulmonary encephalopathy, pancreatic encephalopathy, like that. When we accept the common workaholic term as metabolic encephalopathy, is it justified to pair with the adjectives or other adjectives like metabolic or toxic encephalopathy? So we all know that the toxic derangement that occur in metabolic encephalopathy can also occur by externally administered toxin. So it's better to avoid the term using the toxic encephalopathy. The risk of the additional qualifiers that will dilute the issue and specifically discourage the search for the major inciting process. So more often previously suggested that that means the metabolic encephalopathy is functional, there is no structural change in the brain. It's not wrong. We do have a lot of structural changes in the metabolic encephalopathy also. For example, we can have the diffuse cellular edema in uremic encephalopathy and also the white matter edema in hepatic encephalopathy. So what are the confounders? Patients with a critical illness, they always receive polypharmacy, sedatives, and their delayed responsiveness can cause a false neurological assessment, especially in the older age, where the total body water is diminished and body mass is also reduced. Low serum albumin leads to decreased volume of distribution and the increased drug effect. They all prolong the drug effect. It need like an metabolic encephalopathy. One of the common offender is the assessment. In the older age, it's unfriendly. The total body water is neurologist as well as diminished and body mass is also reduced. Low serum albumin leads to decreased volume of receive this as an infusion. Increased drug effect. So this drug has got a short onset of action, but long duration of action, and particularly the half-life decreases. Especially a few days after infusion. It's unfriendly. Third or fourth day ventilator for a neurologist to give the fentanyl. Invariably the patient will be in the altered sensorium. And the clearance is also 10 times lower than in the person without organ dysfunction. Short onset of action. So you be careful, especially when the patient is on ventilator. Particularly the half-life patient can have subtle elevation of the urea, subtle elevation, especially a few days after consumption like that. Third or fourth day as a metabolic encephalopathy. To give the fentanyl. Opioid is the patient to be in the altered sensorium. The clearance is also 10 times lower than in the person confused without organ dysfunction. So frequently, you be careful, especially when the patient is on ventilator. When the patient can have subtle elevation of the urea, subtle elevation of the carbon dioxide, something like that, you may wrongly attribute this as a metabolic encephalopathy. And the opioid is the next confounder, which may mimic like a encephalopathy in IMCU. And next confuser is the antibiotics. So frequently, the ICU patient receive a lot of antibiotics. The described confounder is the cefepime. The cefepime crosses the blood-brain barrier in sepsis, and also in head injury patient, it crosses the blood-brain barrier. And when there is a diminished renal function, there is an increased half-life of the cefepime. We know that cefepime can cause an encephalopathy, consciousness. It can cause seizure, and sometimes it can cause status epilepticus, or so-called non-convulsive status. The another important confounder is the shock. So hypotension alters the consciousness, especially in a critical illness ICUs, when the patient is in a hemodynamically unstable state. The hypotension can cause alteration in the conscious level. The mean arterial pressure with the decreased consciousness of 50 millimeter, the vulnerable areas are the watershed infarcts, the areas between the AC and MCA and the MCA versus PCA. Whereas the MAP threshold, mean arterial pressure threshold for the kidney is slightly higher, 70, and for heart is 70 to 75. So coming to some clinical signs of metabolic encephalopathy, there is an arousal. The arousal is always abnormal in metabolic encephalopathy. The patient may be hypervigilant, may be over alert, or they may be hypoactive. So what do you mean by arousal? So arousal is defined as the degree of the sensory stimulus required to keep the patient attending to the examiner. The next you can see is the attention and alertness. So attention means the ability of the one focus to a particular relevant stimuli in the environment, and he is also able to focus to other environment as they become relevant from the environment. So the attention is reduced. The core delirium is the failure of the attention and alertness. They have a distractibility. Perseveration means inappropriate repetition of your response or your words, or sometimes the failure to focus attention. These are the three cardinal signs: distractibility, perseveration, and failure to focus. These are very common symptoms of early encephalopathy. And disorientation. Invariably, the person with the metabolic encephalopathy they lose orientation to time, followed by distance, and finally or very rarely the person. So whenever you suspect a metabolic encephalopathy, you should specifically ask whether he is oriented to time, place, particularly distance. Disorientation person and place but not time, that is very, very unusual in structural disease. And usually in a psychic patient, the so-called functional encephalopathy, where they have only disorientator for self, that's always pathognomonic, psychogenic. Whereas if the patient suffering from organic disorder like metabolic encephalopathy, first they disorient to person, time first, followed by the distance. Then the cognition is also affected in metabolic encephalopathy. The content and progression of the thought are always disturbed. Memory, especially they have a recent memory loss. They have an inability to retain the memory for more than a few minutes. So this memory loss is proportional to the other loss of other cognitive function. Whereas in the psychiatric patients, the memory loss is there. And they have a perceptual errors, like mistaking hospital staff for their friends or relatives. They have very frequent illusions. They have a hallucination. Usually in a delirious patient or encephalopathy patient, they have both auditory and visual. If it's only auditory hallucination, it may be a feature of a psychiatric disorder like schizophrenia or a major depression. Then coming to the clinical examination, you have to give more importance to the respiration. The metabolic encephalopathy patient, they have either hypoventilation or hyperventilation. So hypoventilation is always a dangerous sign. So what does it indicate? That means the patients are in severe encephalopathy state. That means the brainstem reticular formation is vulnerable to chemical depression. When the patient is in hyperventilation, again it's a danger sign. It may be either due to a metabolic acidosis or it may be a response to primary respiratory stimulation, respiratory alkalosis. And the periodic breathing, Cane-Stokes breathing and post-hyperventilation hyperapnea may be early signs of metabolic encephalopathy. Of course, Kussmaul breathing that you can see in the, classically you can see the shallow deep breathing and DKA. Central neurogenic hyperventilation, that's the respiratory is more than 70, 50, 70, 80 or something like that. It's a classical of midbrain structural lesion. Sometimes it can also occur in metabolic encephalopathies. So the pupil is very, very important. When you see suspected metabolic encephalopathy, the pupil is the single most important criteria that clinically distinguishes from the metabolic versus the structural disease. In early stages, the pupil may be normal and it is equally reacting to light and accommodation. But in moderate and severe encephalopathy, the pupil is always bilateral, small, reacting. So the presence of the preserved pupillary reflex, despite the concomitant respiratory depression, impaired vestibulo-ocular reflex, or sometimes the patient can have a decerebrate decorticate rigidity. But if the pupil is reacting, normally reacting, normal size or bilateral small, that indicates a metabolic encephalopathy. And the previous teaching, olden days teaching that the so-called decorticate, decerebrate rigidity does not occur in metabolic encephalopathy. We do have a lot of decerebrate, decortic rigidity even in hepatic encephalopathy. And sometimes, very rarely, the bilateral small pupil can occur in diencephalic lesion. That is the diencephalic stage of the central herniation. The ocular motility, again, gives an important clue to our metabolic encephalopathy. The roving eye movement, the slow, random, uncoordinated movements of the eye, this is so classical of a metabolic encephalopathy. And that indicates the very severe cortical dysfunction with the preserved brainstem activity. And we have a cold caloric stimulation which give enormous information. And we all know that you would have been taught to in the undergraduates, caloric stimulation, cows, cold water, opposite side nystagmus. You do the cold caloric in a suspected metabolic encephalopathy patient. If there's a conjugate deviation to the irrigated air, that indicates the mild metabolic encephalopathy or lighter coma. And if there is no response, that indicates severe encephalopathy or severe coma. And if there is a nystagmus that can be seen in the normal individual, then probably it is psychogenic. And if eye deviates downward following the lateral deviation, that always indicates a structural lesion. And we do have a lot of motor abnormalities, non-specific, maybe hypotonia, or sometimes you can have hypertonia, or you can have a seizures. We have a tremors. Usually the tremors are the course irregular at the rate of 8 to 10 seconds, and most evident in outstretched hands. And we have asterixis, multifocal myoclonus are the prominent manifestations. The asterix is generally seen in mild encephalopathy. That cannot be seen in the severe encephalopathies. But still, you can elicit asterix in the lower limb also. Normally we do not do in bedside examination, but if we do the asterix in the lower limbs, that can do even in unconscious patient. So that is by passively flexing the both lower limbs and abducting the thigh, and there is a flapping, abduction and adduction movement that indicates that the patient has got a flapping tremor. Yeah, you can see the roving eye movements, random side-to-side movements in mild metabolic encephalopathy. And you can see the multifocal myoclonopathy involving the both hands. Then the second video, the uribic encephalopathy. And in third picture, you can see the how to elicit asterixis in the lower limbs. The lower limbs are flexed at the thigh, and the legs are abducted, and you can see the abducting movement that indicates the asterixis of the lower limbs. And you can see the flapping tremor, multifocal myoclonus in the. Then coming to how to differentiate between the metabolic versus psychogenic unresponsiveness. In the metabolic, they always confuse disorder into time and place. I've already mentioned. Whereas in a psychiatric patient, they are not disoriented, but disoriented only self only. Self-disorientation is hallmark of a psychogenic illness. The abstract thinking is defective and cannot retain new information, whereas the psychogenic patient, they are well cooperative and they retain the new information. Of course, a lot of motor abnormalities can be seen in the metabolic. There is no abnormal motor or response in the psychogenic, and the respiratory changes are seen in the metabolic, whereas only the psychogenic hyperinflation will be there. Of course, most of the time EEG is abnormal in metabolic encephalopathy, whereas normal EEG in the psychogenic. When the organ fails, the specialist, they usually diagnose the organ dysfunction, nephrologist or the urologist or endocrinologist, whatever it is. The clinician or the specialist may ask the neurologist for the detailed assessment of the noted encephalopathy, and they exclude the treatable mimicking neurological disorders. So now we will move on to how to treat some common hypoglycemic encephalopathy. The first one is hypoglycemic encephalopathy. So all episodes of abnormally low plasma glucose concentration that expose the individual to a potential harm. So a single threshold for a plasma glucose concentration that define hypoglycemia in diabetes cannot be assigned. Some patient, the blood sugar may be 40, patient may be normal. And some person blood sugar maybe they have a level 2 hypoglycemic symptoms. That means he is disoriented, the Glasgow Coma scale is less than 7. Or sometimes 40, they have a very severe hypoglycemic symptom. There's a level 3 hypoglycemic symptoms. So management of hypoglycemic encephalopathy, at a level of 30 milligram per liter, the cerebral disorder may take the form of confusional state, and one or more, they can have a seizure. At a level of 10 milligram, individual there will be a very deep coma, and there's a irreparable brain injury if not corrected immediately. As with other metabolic encephalopathies, the rate of decline of blood glucose, that's a very deciding factor deciding about the prognosis. And coming to treatment is very simple, and you give 25% of 100 ml of dextrose, or 50%, 50 ml of bolus should be given, and immediately should be followed by the glucagon. Or if the patient is in house, probably the glucagon may be the first drug of choice. Should be given 1 milligram intramuscular subcutaneously. Glucagon may cause nausea and vomiting, so turn the patient to his side or side during the treatment to avoid aspiration. Check the blood sugar after 15 minutes and retreat until the blood glucose is more than 80. But the recent literature states that you always avoid post-episode high blood sugar level, 200, 300 following the hypoglycemic correction. It may again potentiate the brain injury. If the patient is unconscious, if the patient consciousness improves following with a oral meal or snack within 30 to 60 minutes. Sometimes if you expect a prolonged hypoglycemia, for example, following a massive dose of insulin or a long dose of sulfonylureas, probably you have to maintain the glucose infusion at a rate of 2 milligram per kg, maybe around 100 ml of 5% dextrose solution. And then when the patient regains the consciousness, probably you can switch over to oral drugs. And if it is sulfonylurea induced hypoglycemia, probably you can try with an octreotide, because the octreotide blocks the insulin release from the islet cells of pancreas, 100 micrograms on IV bolus, and followed by the 50 microgram subcutaneously versus severely for 1 or 2 days. The rebound hypoglycemia can occur within 24 hours of stopping the octreotide, so the patient will be monitored during that period. What is the role of the steroid in hypoglycemic encephalopathy? It's not a standard therapy, but it may be useful for a selected patients who are not responding favorably to the usual intervention of the prolonged hypoglycemia or a massive insulin overdose, or particularly when the non-availability of the glucagon. But glucagon is now available. For example, 5 or 6 years ago, it was not available, but now it is available in every hospitals. The rate is also very cheap. Previously it was 6,000, 7,000, now it is available 750 rupees. So when there's severe prolonged hypoglycemia, steroid use may reduce the dose of the dextrose requirement, so which may avoid the central line or the hypokalemia associated with the dextrose infusion and the volume overload. So rapid onset, short duration of steroids like 100 milligram at the cortisone severely may be useful in prolonged hypoglycemic encephalopathy. So coming to the pulmonary encephalopathy, so advanced lung disease can cause encephalopathy, but still we do not know what causes this encephalopathy. So probably the cause of encephalopathy may be the hypoxemia, hypercarbia, and congestive heart failure and systemic infection. So these are the 4 variables which may cause pulmonary encephalopathy. So out of all these variables, the carbon dioxide retention correlates well with the neurological symptoms. And another interesting fact, that is the hypoxia can cause hypotension. I've already mentioned in the second slide, hypotension can cause an altered sensorium. So and the early symptoms of the nervousness, insomnia, headache, confusion, and somnolence. In most severe form, they can have a headache. Papilledema, it can be also present. They have a stupor, and still they can have a decerebrate or decorticate rigidity. So how do you treat the patient? Everybody know that the only treatment is the artificial ventilation is the treatment of choice. But there are 2 important factors one should keep in mind in treating the pulmonary encephalopathy, or so-called carbon dioxide narcosis. The one is hypoxemia, and the next one is the metabolic alkalosis. So this is standard teaching. When we were on MD students, standard teaching that the hypoxia in carbon dioxide narcosis should not be corrected, because the hypoxia only drive to stimulate the respiration. If you abolish this drive by giving oxygen, probably the respiratory failure may worsen, but this is not true. This is proved by the recent studies. The hypoxia can cause severe cardiac depression and the brain depression. So the hypoxia should be treated with an oxygen. And those who are not comatose, they require artificial ventilation. Probably the non-invasive ventilation may be useful. So the hypoxia, you can correct the hypoxia along with the artificial ventilation. The second one is the respiratory alkalosis. So this important complication can occur during the course of the treatment, during the course of the mechanical ventilation. So the correction of the carbon dioxide narcosis by artificial ventilation sometimes induces severe metabolic alkalosis. If the carbon dioxide retention is quickly returned to normal in the face of high serum bicarbonate level. So though metabolic alkalosis is asymptomatic, a lot of case series in which metabolic alkalosis is associated with a serious neurological symptom and death. So those patients recovering from the CO2 narcosis, again they develop a unconsciousness or severe pH value less than 7.5 to 7.6, develop a coma and seizure. So the PCO2 should be lowered gradually during the treatment of respiratory acidosis to allow renal compensation to take place and prevent the severe metabolic acidosis. So coming to the hyponatremic encephalopathy, this we used to see, it's not a common problem, but sometimes you do see case of a severe hyponatremic encephalopathy, one of the common electrolyte disorders. severe hyponatremia associated with the increased mortality and irreversible brain injury. Again, we have a lot of controversies on the rate of correction of the hyponatremia, generally highlight the central pontine myelinolysis, but ignores the harm associated with the cerebral edema, which is commonly present in the sodium is less than 110. When the sodium is below 100, the patient with hyponatremia encephalopathy, it's very, very difficult to treat. And we have lost 1 or 2 cases in spite of treatment with in combination with the nephrologist because of the cerebral edema. So the longer the cerebral edema associated with the hyponatremia persists, the more damage to the brain or more. So the one side, the fast correction to prevent the cerebral edema, and the other side, the CPM, central pontine myelinolysis. We have to balance this. So what is the moderate to severe hyponatremic encephalopathy? When the serum sodium level is 120 to 129, and the patient is nausea without vomiting, and confusion, disorientation, headache. In other words, mild coma. The GC is less than 7. We call this as moderate hyponatremic encephalopathy. When the serum sodium is more than 125, when the patient has got a severe vomiting, cardiorespiratory distress, abnormal deep somnolence, and the Glasgow coma scale of more than 8, then probably a severe encephalopathic symptom. In 2 patients, the patient is already having a cerebral edema. So fast correction, the profound hyponatremia, both acute or chronic, whatever it is, when the patient got symptomatic, it should be treated because the brain damage due to the brain edema, which outweighs the risk of central pontine myelinolysis in all categories and need fast correction. So fast correction means the correction aimed at 5 milliequivalent per liter in the first hour. That's the definition of the fast correction. So again, we follows the Atrox Medias formula. Again, it is always misleading because the vasopressin control of free water excretion is disturbed in hyponatremia, and therefore the rate of correction can vary, and the formula does not predict well. And the laboratory measures need to be repeated every second hourly. However, desmopressin can make this formula more predictable. So fast correction, you check the serum sodium and you infuse the 3% saline, 1 to 1.5 ml per kg body weight in 20 minutes, and repeat the serum sodium. And if the symptom improves, then you stop the 3% saline, and probably you can replace with the 0.9% saline until course of the specific treatment is started. If there is no improvement of symptom, and you treat the patient as usual, there is a general rules of raising the serum. There is a 8.5 to 10 millimole per liter. This is for the moderate encephalopathy. Again, check the sodium and the same dose of infusion. But here you need not repeat the second dose. If the patient improves, then you treat with the normal saline. And if the patient is not improving, then you follow the usual correction. That means raising the serum sodium by 10 millimole per liter per day. So the general rule. So first 24 hours, you have to raise only 10 millimole per liter. And the second day, 8 millimole per liter. And when the serum sodium reaches 130, you stop the treatment. And the symptom improved, probably you can continue treat the cause of the hyponatremia. It's a general rule of raising serum sodium. Always follow this formula. Not necessarily the formula. If you want to raise the serum sodium by 10 millimole per liter, roughly you can give 1 liter of 3% saline. That is the method by which we can very calculate easily with this formula. And coming to the rapid correction of hyponatremia, one of the bad effect is the osmotic demyelination syndrome, CPM. But it's a very rare but a dramatic complication. But it should be very important to diagnose this disease. So your patient is hyponatremia, you are treating with the saline, patient is improving, and again, 3rd day or 4th day, patient may develop some extrapyramidal symptoms or may develop an altered sensorium or the bilateral planetary subgoing. You may clinically diagnose this as a CPM. But if you do the CT or MRI, it may be normal because MRI takes at least 15 days, minimum 15 days to 4 weeks, the lesion to appear. So even if you know the diagnosis, you stick on your diagnosis. Just because of normal MRI, you don't change your diagnosis. Because this delay of initial negative MRI does not rule out the osmotic demyelination syndrome. So rapid correction of hyponatremia, what to do? Suppose you have corrected hyponatremia very fastly. The increase of more than 10 millimole of sodium during the first 24 hours or 8 millimole in any 24 hours, that means that we are correcting very fast. If you reach beyond this category, so discontinue the ongoing active treatment. That's the first step in the management, and infuse 10 ml per kg of electrolyte-free infusion, maybe 5% dextrose, or you give IV desmopressin 2 microgram, if necessary, repeated after 8th hourly. So this is for when you come across a rapid correction, you follow this guidelines, or you can use an alternative method. This is called as a DDAVP clamp. So in this method, you give proactive approach. So before you initiate your treatment correcting the hyponatremia, we start with the stop all the maintenance fluids, start 2 microgram of desmopressin IV 8th hourly, start 3% saline, 1.5 ml kg over 6 hours, and fluid restriction for 1.2 liters per day. Ruthless fluid restriction, and monitor sodium every second hourly. Once serum sodium rising predictably, decrease frequency to 4 to 6 hourly. Adjust the 3% saline rate to achieve the correction of 8 millimole per day. So continue the 3% saline until and DAVP until the serum sodium is 125-13. So this is a provocative approach to prevent the CPM in the case of a severe hyponatremic encephalopathy. And the consideration to be given to correcting the sodium even slower. Whatever the situation, you can give a slow correction rather than a fast correction, because the CPM does not occur in all individuals. There are some predisposing factors where the CPM is more common. For example, the serum sodium is less than 120, a rapid correction of hyponatremia, hypokalemia, alcohol use, malnutrition, or patient is already on dialysis, burns victim, HIV, eating disorders, or patient is already on diuretics, antidepressant medication. They are more prone for a CPM, where you must be very cautious. Probably, perhaps you may try the slow correction. So coming to the hepatic encephalopathy, it's a very common complication as detrimental effects on the quality of the life. Ammonia plays a key role in pathogenesis by producing the low-grade cerebral edema. We do not have any diagnostic gold standard for diagnosing hepatic encephalopathy. Always you combine the clinical method. Of course, the psychometric test and EEG will also support your diagnosis, and identification and the treatment of precipitating factors and treatment directed to reduce the ammonia level is generally effective. So the clinical picture of hepatic encephalopathy, again, you have a changes the mental function, which you already discussed, alteration in the alertness, attention disorders, cognitive dysfunction, consciousness and constructional ataraxias and other things. And you have a lot of motor dysfunction like rigidity, sometimes the kind of cerebral rigidity, and movement-induced tremors, Parkinsonism, choreoathetosis, and hyperreflexia. And this is a minimal encephalopathy. It's a condition without manifest neurological symptoms, but with a cognitive deficit shown by psychometric test. Patient is apparently normal if you examine the patient. And if you do the higher mental examination, minimum mental score examination is normal. But if you do some psychometric test, probably you can diagnose this minimal hepatic encephalopathy. And prevalence can up to 80%. So most of the cirrhotic patients, if you do this test, probably you can diagnose hepatic encephalopathy in 80% of the patients. Can negatively impact the quality of the life, and ability to work, and risk of the motor vehicle accidents also there. So hepatic encephalopathy diagnosis, history and examination, neuropsychiatric history, headache, and sometimes loss of sleep rhythm, psychiatric symptoms, mental status examination by S7 criteria GCS, neurological examination for motor abnormalities, and exclusion of the other causes of metabolic encephalopathy. So this is the construction difficulties. Difficulty in drawing the 5-point star, and you can see the writing difficulties. And this is the portosystemic hepatic encephalopathy score. So this is the psychometric test for the minimal hepatic encephalopathy, where we have a 5-paper test, the number connection test 1, 2, and the digital symbol test, serial dotting, and line tracing test. So the test takes at least 10 minutes. So I'm not going to talk in detail about the test. And if the score is normally it should be more than 4. If it is less than 4, that indicates that patient has got a minimal hepatic encephalopathy. So this is the pathogenesis of the cerebral edema in the hepatic encephalopathy. The ammonia is the culprit that causes astrocyte swelling, NMD receptor activation, And the lot of cellular changes like gene expression, protein mRNA modification, signaling that ultimately leads to osteosis as well as the neuronal dysfunction, then have neurological symptoms. Treatment is diet is a very, very important part of the treatment. Most of the cirrhotic patients are calorie deficient patient because they are unable to store the glycogen. They rely only on the neoglucogenesis, the energy expensive process which utilizes the amino acid to maintain the adequate glucose level. Guideline recommend us the energy intake of 25 to 40 kilocalories per day. That means it's more than the normal person's calorie requirement, and protein should be given. You should not restrict the protein intake 1 to 1.5 gram. Vegetable protein is better than animal protein because they are very tolerated well. And management infection, there are a lot of recent papers saying that without infection, there is no hepatic encephalopathy. So infection is the culprit. Because cirrhotic patients often have impaired host defense mechanisms. They have a bacterial translocation from the gut, resulting in the chronic endotoxemia and occult infection. So identify the infection and treat the infection. The hepatic encephalopathy will improve. Bowel cleaning is very, very important. Enema should be used. Meyer's open water enema is not sufficient. The vehicle need to be hypersmolar. The bowel cleaning with 25 ml of lactulose in 750 ml of water twice a day is highly effective. And this is the lactulose, the non-absorbable disaccharides, because our small intestine does not have the enzyme to split this disaccharide. They reaches the large bowel where increase the volatile fatty acid, hydrogen ion concentration, pH, so that attracts the ammonia into the colon and it promotes catharsis. So for the past 25 years, it's the only effective treatment. Still, we don't have any other treatment for hepatic encephalopathy. Lactulose 50 to 30 ml, 2 to 4 times a day. Dose is adjusted to ensure passage of the semi-solid stools. Lacteol is also another molecule which is available. And 2016 systematic review, a lot of trials confirm that they have a beneficial effect with a significant reduction of the risk of developing the liver failure and variceal bleeding and reduction of all-cause mortality. And it is also provide effective the primary and secondary prophylaxis against the development of encephalopathy. Antibiotics, rifaximin. It's a synthetic antibiotic. Again, 2018 meta-analysis conclude that rifaximin, when combined with the lactulose, highly effective. Dose is 550 milligram twice a day, and usually continue for extended period of time to prevent the recurrence. So only two drugs, rifaximin and the lactulose. Lola, we are using Reptonride, but 2018 systematic review does not show any benefit. Sodium benzoate, again, it's a very good drug because of tolerability issue. Patient has to swallow a large amount of liquid, maybe 2 liters per day. It's per dose. It's very, very impractical. Liver support systems, again, they'll do large randomized trials. There is some improvement in the conscious level, but there is no survival benefit. Again, it is not going to be useful. Liver transplant is the ultimate answer for hepatic encephalopathy. Coming to an acute hepatic encephalopathy, the treatment is entirely different. Whereas in a chronic hepatic encephalopathy, we don't have any cerebral edema. If at all, it's very mild. Whereas in acute encephalopathy, the cerebral edema plays a major role. So brain edema in acute hepatic failure, a window to the pathogenesis of the hepatic encephalopathy. So in the hepatic encephalopathy, intracellular edema that causes the disturbed CS of hemodynamics that can have the brainstem herniation. And you can see the one of patients with the normal CT on admission, and you can see the ventricles are there, and then the second CT you can see the no ventricles, only the diffuse neuronal edema. So treatment for acute hepatic edema due to acute fulminant hepatic failure is elevation of the head from 15 to 30 degree. Head position should be maintained at midline position to avoid obstruction of venous return to thorax. Mannitol should be given 20%, 1 gram per kg as a bolus, followed by the 0.5 gram IV 6th hourly or 8th hourly. Hypertonic saline, 3% saline as an initial bolus, followed by the 5 ml per kg, which may correspond to expected rise in the serum sodium of 5 milligram per liter. Continuous infusion of 3% at a rate of 0.5 to 1.5 ml kg per hour. So either you can use mannitol or hypertonic saline. Temporary therapeutic hyperventilation may be initiated under the direct neurosurgeon for the patient of signing the plan this thing. And if the edema is not responding to your conventional management, that's ident elevation, mannitol and 3% saline, or bridging therapy of controlled hyperventilation by ventilator, don't hesitate to call a neurosurgeon for a decompressive craniotomy. Coming to the last, the renal failure. The precise cause of the brain dysfunction in the uremia is still not known. Uremia itself cannot be a toxin. Usually it is rare to see uremic encephalopathy when the creatinine is below 7. Brain level of calcium, gonadotropin compounds and metabolites of tryptophan may play a role in uremic encephalopathy. The encephalopathy in uremic patient, the cause may be enormous. We have a lot of causes. Maybe hypokalemia, or hyponatremia, hypoglycemia, a lot of causes. Still, but if you clinically diagnose uremic encephalopathy by 3 important features. Number 1 is the progressive, dull, apathetic, confusion, blend slowly into the supine coma. All untreated uremic encephalopathy, they have a metabolic acidosis with a respiratory compensation and motor changes myoclonus. So altered sensorium, multifocal myoclonus and metabolic acidosis and respiratory compensation. If the triad is there, you think of a uremic encephalopathy. Of course, a lot of other confounders in uremia, the hyponatremia, hypertension, encephalopathy, Wernicke, if a patient on dialysis, they have a diamine deficient, they all mimic like a uremic encephalopathy. Treatment is very simple, hemodialysis, but neurological recovery does not always immediately follow the dialysis, and patients often continue to be in coma for maybe 7 to 10 days, and then only the patient will improve. Such a delayed recovery did not imply that the permanent brain damage. Thank you for the patient's hearing. And the few words about Professor Rafi. Rafiq is my best friend. I have had the pleasure of knowing the Rafiq for more than 25 years. I think when he was doing a PG, I think I was assistant professor in the neurology. So the PG, sir, assistant professor and assistant professor, associate professor and assistant professor, associate professor and chief, and HOD and unit chief. So a lot of associations. The qualities which are very impressed with Professor Rafiq is the versatile personality, because the Professor Rafiq involved in almost all aspects of all facets of life. He is a very much interested in politics, especially the Dravidian movements. Not only the Tamil politics. If you talk, you will talk about American politics, German, Cuba, everything. When we were in the DA's quarters, most of the time we discussed about this, rather than taking the classes or other activities. And he is always take responsibility, accept responsibility. For example, I think 3 years ago, when the dean asked us to take over the HIV ward, HIV surveillance center, which we were very much reluctant because we don't have enough staff. So immediately, Professor Ravi took the job and ran the department very well. And he is a voracious reader. He reads a lot of novels, English, politics, stories. I think 10 years ago, we both purchased a Kindle. Usually, I very much fond of purchasing the electronic items. But after that, I never touched this Kindle. But Rafiq read a lot of books in the Kindle. And he is a voracious traveler. And he visited almost all the places in India. And such a voracious traveler. I think Professor Rafiq is a role model for all of us, not only youngsters. So he is multi-talented in all aspects. He tastes each and every aspect of the life. And beyond his academic and the other accomplishment, he is a very well-wisher of mine and a very great support in life. So I wish Professor Ravi will have a healthy and happy retirement life. I would like to present a shawl to Professor Rafi.
Thank you for
Thank you,
your...
sir. Thank you for your nice and excellent talk about encephalopathy. Few words about Dr. Allegation. We are very good friends since 1993 onwards. 1993 onwards, we worked, both are worked nearby PH in 1993 at Sivasi HOD. On that day itself, he behaved like this only. He is a very nice gentleman. He won't disturb anybody's. And his wife and my wife is also a classmate. His son and my son also a classmate from pre-KG itself. We will have a good relationship for the past more than 30 years. He has given a very nice topic and a nice talk to us. Can you across any metronidazole encephalopathy, sir, and antibiotic induced and hypernatremia encephalopathy?
I have mentioned one of my slides. One of the ICU drugs that mimic like encephalopathy is a metabolic encephalopathy. Yes. Sorry, metronidazole induced encephalopathy. The one important thing is the metronidazole induced encephalopathy, which exactly mimic like a Wernicke encephalopathy, diamond induced encephalopathy. You can have the MRI if you take, you can have the periventricular, third ventricular hemorrhage, amyloid body necrosis. Classically, can present also as a ataxia, apnea, and the altered sensorium. But I have seen only one case, very, very rare. But hyponatremic encephalopathy is more common than hypernatremic encephalopathy. That's why I would discuss only one hyponatremic encephalopathy.
Thank you, sir. Students, one question. PGs. What is the first clinical symptoms which will appear in encephalopathy? PGs. Anybody? Anyone? Altered mental status is the first symptom which is produced by the encephalopathy. Then what is the first diagnosis of altered mental status? PGs. First diagnostic test we can do it. Anybody's? EGT. What is the first test you can do for acute encephalopathy? Very simple. We are sitting in the casualty. We can miss a lot of cases. That is why I ask you the PGs. Acute encephalopathy, we can do bedside test, LP, CSF.
for their time and valuable input for this session. For their time and valuable input for this session, I request Professor Dr. Periyasamy sir to honor our chairpersons today. I invite Professor Dr. Periyasamy sir, Chief of Medicine, to honor Dr. Balan sir, Senior Physician Co-Villain. Request Professor Dr. Periyasamy sir to honor Professor Dr. Mohamed sir.
I request Periyasamy sir to honor Dr. Kandasamy sir with the memento. As we move into our second session, we turn our attention to a topic of immense clinical significance: pearls and pitfalls, the management of thyroid disease. Managing thyroid disorders require precision, vigilance, and a deep understanding involved in diagnosis and treatment. This session promises to provide invaluable insights into the common challenges and critical considerations in managing thyroid conditions effectively. To guide us through this topic, we are privileged to have with us Dr. Shiva Prakash sir, Senior Consultant Endocrinologist in Tirunelneli. Known for his expertise in endocrine diseases, Dr. Shiva Prakash sir has a wealth of experience that will undoubtedly provide clarity and practical takeaways for our clinical practice. As chairpersons for this session, we have Dr. Nasir sir, Retired Professor of Medicine, Tirunelneli Medical College, Dr. Pabita Devi Madam, Professor and HOD, Department of General Surgery, Tirunelneli Medical College, and Dr. Babu Kandakumar sir, Professor of Pediatrics, Tirunelneli Medical College. I welcome you all to the dais.
So good morning to you all. First, I thank the organizing committee people for giving us an opportunity to chair the session. And it is a great pleasure to take part in the CME program conducted for honoring our retired Professor of General Medicine, Dr. Rafi sir. And I'm sure that you will have a brainstorming session in the next 45 minutes by Dr. Arun Prakash sir, a renowned endocrinologist in Tirunelneli. And I'm having a long association with Dr. Rafi sir. I am a junior to him and I had a long association, more than 30 years. With this, so do you want to?
We introduce the speaker, Dr. Sivaprakash sir, who is an endocrinologist, who did his UG from Tirunelneli and MD General Medicine from Madras Medical College, and he did his DM Endocrinology from AIMS, New Delhi. Now he is working as a senior consultant endocrinology, Kaveri Multi-Specialty Hospital. Over to you, sir.
Good morning at the outset. I think I feel privileged to talk in front of this esteemed audience, and especially in honor of Rafi sir. I think who I am in touch even before almost like more than 30 years. So I also take this opportunity to take thanks to Mahakarshan sir, who was my teacher, still vividly remember Arul sir, and Nazar sir, Arun sir, Alagan sir, all were good, my good teachers. And Babida madam, I think when I started government service, I worked along with madam, so it was a nice experience working with her as well. So I'll go to the topic straight. So pearls and pitfalls in the management of thyroid disease. So why this topic was given to me by the medicine department. So this is also going to be like a hybrid CME. This would cut across the surgeons, to the gynecologist, to the pediatric part. And whenever we see this is more of like some case-based discussions as well as interpretation of thyroid. So I think it is most of the time when we see, we just look at the lab values and we proceed for treatment. But I think that's not the case. We should know the physiology. To put it in simple words, the hypothalamo-pituitary axis you can see, and how it targets the brain, the cardiac, liver, intestine, and the musculoskeletal system. So the entire spectrum of thyroid disease revolve around this pathway. And another important aspect to consider is we take lab results straight as face values, which is wrong. I think we should know a little about, I'm not going to the depth, that when we measure whether it is free T4, free T3, free T4 or free T3 or total T4 or total T3, these are small molecules of very small proportions in the blood. So it's always, there are always methodological issues related to interfering compounds like antibodies, especially in pregnancy, or heterophil antibodies, especially in the setting of background of autoimmune diseases. As well as with the sandwich assays which measure TSH. I think this is one diagram to illustrate measurement of TSH, where there are two antibodies, which sandwich the serum TSH and then elicits a signal. So in many of the immunoassays, there are interfering substances which can interfere with the measurements and cause a wrong diagnosis. As also with total T4 and total T3, I think this we can see in many texts. I think before interpreting, make sure what conditions cause an increased total T4, total T3, what conditions cause a decreased T4, T3. I think these has to be kept in mind. So now we are presented with TSH alone. In some reports we get TSH, T4, T3. In some reports we get TSH, free T4, free T3. So now before proceeding to workup of a patient with the TSH report alone, so because for cost effectiveness we do only TSH. Remember that if a patient had been recently treated for thyrotoxicosis, sometimes TSH remains suppressed. So only a suppressed TSH is not going to add any value to the diagnosis. Non-thyroid illness, TSH can even reach up to 20. So we might be tempted to treat as a hypothyroidism, primary hypothyroidism, but that's not the case. The patient might revert back to normal. And central hypothyroidism. This is one entity where TSH can be low, normal, or high. And TSH secreting pituitary tumor. Now this is a very rare case, but we have seen where TSH can be perfectly normal. As also interfering antibodies. So let's go to Another scenario, usually we happen to see, okay, a patient comes with an elevated TSH and a low free T4, free T3. Now, the most common cause are Hashimoto's thyroiditis, which is chronic autoimmune thyroiditis, or post-radiation ablation, post-thyroidectomy, or during thyroiditis. This is a very important part because during thyroiditis, there is acute destruction of the thyroid follicular epithelial cells. That is following which, so it initially presents a thyrotoxic feature, then it goes into hypothyroidism. So that has to be kept in mind. And certain drugs like amiodarone, lithium, and also iodine deficiency. So here are some more common causes. I think it's far more common for us to see in metabolic syndrome patients who are obese to have mildly elevated TSH even up to 8 to 9, for whom a weight loss actually would bring back TSH back to normal. So this is part of a metabolic syndrome. In patients with nephropathy, proteinuria, impaired renal function, again, TSH can get mildly elevated. And also patients with untreated adrenal insufficiency, I have seen where TSH can be mildly elevated even up to 8 to 9. And we assume it for hypothyroidism and treat with levothyroxine, which accelerates cortisol metabolism and precipitates adrenal crisis. So we have to interpret in the context of the clinical background, take a good history, clinical picture, examine, and then you interpret the thyroid values. So of course there are some rare causes like familial dysalbuminic hypothyroidism where TSH can be normal or slightly raised, and also in psychiatric illness, this we have seen quite common, especially during acute psychosis, where TSH can be normal or raised and free T4, free T3 can be increased. This is a very common scenario for most of us, patients who are receiving levothyroxine treatment. And in that context, I'm saying, so patient is on adequate replacement, provided compliance and appropriate intake is there. So you get a normal TSH, but you get a free T4 high. So again, it can be a normal physiologic variant, or there can be less deiodination, efficient deiodination of free T4 to T3, but this is quite rare. Most important is maladministration. Patient takes it and immediately after a few minutes he takes coffee or any food, or takes iron or calcium supplements. So this is much more common in pregnant women. We have seen a lot from OG department, especially someone adds calcium or iron medicines in the morning. So at least 4 to 5 hours gap has to be given for adequate absorption of levothyroxine, because actually levothyroxine gets absorbed in ileum. So it has to travel a long distance. So make sure the vitamin tablets are given with a substantial longer duration gap. Malabsorption syndromes, especially with pancreatitis, and those who take pantoprazole, proton pump inhibitors, again the requirements may go high. So simple things need to be kept in mind. And anti-epileptic drugs which can interfere with the intrahepatic cycling of levothyroxine, as well as with oral estrogen therapy. So in some patients, you can see TSH is raised, but T4 is normal. Again, we have to think about TSH as an interference. There can be some antibodies like heterophil antibodies which can interfere with the measurement. And most often we can see for some patients, TSH should be high, but free T4 would be, TSH should be high and FT4 would be also be high. Now these patients, just before seeing the doctor, they would take more levothyroxine. They might not be communicating with us, they would take more. So this scenario we have seen very common, and some rare conditions like resistance to thyroid hormone. Now this is with reference to hyperthyroidism. Let's say TSH is suppressed, thyrotoxicosis, TSH is suppressed, and FT4, FT3 is normal. Classic 3 scenarios: Graves, multinodal goiter, toxic nodule. And remember, on the left side, I have diagnosed pregnancy solely based on thyroid function tests, where the scans have missed because scan was done after taking food without proper bowel preparation. So when the TSH is suppressed and T4, T3 is elevated, make sure in any woman on of reproductive age. I think 4 years back, a lady at 49 years came to me. She had amenorrhea. She fumed at me for ordering a urinary pregnancy, but she turned to be pregnant. So that has to be kept in mind. And hydatidiform mole also. So to put it in simple words, thyrotoxicosis, either it can be a hyperfunctioning thyroid gland or this scenario, thyroiditis. In hyperthyroidism, which is autoimmune Graves' disease, there is increased production of T4 and increased conversion of T4 to T3. Whereas in thyroiditis, there is follicular destruction of thyroid follicular epithelium cells. So the preformed T4 releases much more than T3. So at what stage we are seeing the patient? So here again history is very important. So any patient who has got a more than 3 years duration, 3 months or 4 months of thyrotoxicosis, mostly you are dealing with a Graves' disease with an autoimmune base. But a very recent onset, like say a 1 or 2 months duration of thyrotoxicosis, it could be either a Graves or it could be thyroiditis. So you can see at month interval at which natural history we are standing. So you have to interpret based on the TSH, T4 and the duration of thyrotoxic symptoms. So we can have painless postpartum thyroiditis, sporadic thyroiditis, subacute thyroiditis. In Hashimoto's, invariably it is going to be hypothyroidism, whereas in postpartum thyroiditis it can be autoimmune presenting as a Graves. So in thyroiditis, we are not going to treat with antithyroid drugs. That's the catch point. We are only going to treat symptomatically with beta blockers. Whereas with Graves, essentially patient needs antithyroid drugs. And quite often, I think still I see a lot of patients getting steroids for thyroiditis, which doesn't mandate. Nowadays, there is no role for steroid in thyrotoxicosis. This is with regard to amiodarone. I think quite often I get referrals for amiodarone in thyrotoxicosis. There are 2 patterns with regard to suppressed TSH and elevated T4, T3. In the type 1, there is an autoimmune background. So classically it presents like Graves, but the antibodies are generally absent, which indicates that it's the iron which is driving. But this occurs in the background of autoimmune background or in the setting of a toxic nodular goiter, whereas in type 2 it mostly behaves like a thyroiditis. So if it's type 2, you need to give steroids to stabilize the follicular epithelial cell, a short course steroids. And in type 1, patient may require antithyroid drugs, or if it's not responding, the total thyroidectomy after stabilization. So this is another scenario where you get a suppressed TSH, normal free T4, free T3, or a low free T4, free T3. Subclinical hyperthyroidism is 1 in 80, and patients can spuriously take levothyroxine. A patient, one among the family members may have taken, I have seen. Or most classically we see with regard to steroid therapy, dopamine, dobutamine, non-thyroid illness. These are much more common. And this is one of the commonest causes of a thyrotoxicosis-like picture. Now there are a lot of published literature. You can see, especially in children, you can see here the TSH are all suppressed. T4 is raised, T3 is raised, and the TSH receptor antibodies, which are so characteristic of autoimmunity, is also increased. And some have received antithyroid drugs. But all these 6 kids have been receiving biotin. So most of the time we give vitamin prescriptions left and right, and any dose exceeding more than 20 milligram per day. So as I had shown in one of the previous slides, those can, with the reference to streptavidin biopsies, this can sandwich between the antigens, capture and signal antigen, and cause the TSH to be unoccupied. So you get a low TSH. So even after 1 day of stopping biotin, the TSH picks up. So generally you can leave a gap of 7 days and retest. So this is a very common, I have seen 2 patients receiving biotin and receiving a diagnosis of thyrotoxicosis. Now in the context of a critically ill patient, let's say a non-thyroid illness, now again we are asked to give opinion for these patients. So in this scenario, we have got a TSH normal 0.1 to 0.4, as well as in the entire spectrum, normal to suppressed. And you have to remember that only in conditions where there is a clinically clear-cut picture, I think again going back to the history physical examination, only in the setting of a clear-cut thyrotoxic history, I think that forms the basis, then only we need to interpret. And if the TSH is suppressed and T4 is high, then we are dealing with thyrotoxicosis. Or if the TSH is suppressed and T4 is low also, it doesn't mean patient is having thyrotoxicosis. It might be reflecting an underlying non-thyroidal illness. And sometimes, occasionally we have seen patients with hypopituitarism, pituitary apoplexy, suppressed TSH with coexisting sepsis the neutrophil proteases can cleave the T4 and cause spurious elevated free T4, where actually it is hypopituitarism, but it actually, gives a wrong information like a thyrotoxicosis picture. So underlying clinical examination or history forms the pillar to a correct diagnosis. And this is illness patient, a critical ill with elevated TSH. So normal 5 to 20, more than 20, more than 20. The most important thing is that after a patient has recovered from a critical illness, it is important that a TSH can shoot even up to more than 20. So, and then it comes back to normal during the recovery phase. And if you add drugs like dobutamine steroids, the TSH can suppress. So along this spectrum you have to think, but if TSH is consistently more than 25, and there is clinical parameters to show that the patient is having myxedema coma, then you can treat with levothyroxine. Also you can take into corroboration of serum T4. If T4 is persistently low and it's sequentially going down, that also indicates it is myxedema coma. Now there are multiple drugs, I am not going into the details, so many drugs which can interfere with thyroid function. Just always have a backdrop, like the list is exhaustive. So just to add one or two cases, this is a 76 years old gentleman who got admitted with unsteadiness of gait, hiccups, dizziness, and he had been having it for the last 2 years, but there was no neurological illness. Every time he used to get admitted, he used to have hyponatremia. There was no diabetes, hypertension, or cardiovascular disease. He was given a diagnosis of primary hypothyroidism by another endocrinologist. This was like 8-10 years back with 50 microgram and on aspirin. Systemic examination was normal. So he had repeated admissions with recurrent hyponatremia. You can see the TSH is 17.4. FT4 is low, as well as the TP antibody is little bit on the higher end, and cortisol is normal. So the patient had recurrent hyponatremia, basal cortisol is normal, and he received 3% sodium chloride, dexamethasone, natrice, and theranom 50 microgram. They did an MRI. It was done outside. The cell was reported as normal. So the pituitary gland is normal, cortisol is normal, TSH is 17. So I did a reassessment after 2 weeks stabilization. The one important history everyone missed was a history of head injury. That was at 55 years. And he was unconscious for 15 days, and he was almost like in a deathbed. Then he recovered. And then he was given a tablet of aspirin. Now after reassessment, look at the cortisol. Cortisol is low, 1.47. Prolactin is low, slightly on the lower end. And FSH-LH is suppressed for his age. So after a month, patient underwent a repeat MRI, SELLA. That was an MRI screening. This is an MRI SELLA, focused only for the pituitary. You can see a huge pituitary macroadenoma. Suprasellar extension, as well as on the coronal section you can see there is a clear-cut suprasellar extension abutting the optic chiasma. So the diagnosis is actually central hypothyroidism. What the patient initially received was a diagnosis of primary hypothyroidism based on the TSH 17, but actually sometimes TSH can go high with pituitary causes also. So the diagnosis of panhypopituitarism, pituitary macroadenoma, non-functioning, no evidence of posterior involvement. So for this you need to understand one thing. That is always, if there is a lack of correlation between TSH and T4, free T4, always rule out hypopituitarism, central hypothyroidism. The TSH is high because of the increase in alpha subunit, right? So which is not bioactive, which is functionless. So lab-wise you are going to measure a high TSH, but it is functionless. So this is a missed case. I have seen so many patients even missed for 10 years. So always history taking is a must. Again, there are a lot of things which we need to account. Take TSH, FT4. There are a lot of issues. Now coming to the antenatal part. So this is to cut across the gynecology and pediatric part. When I was in IOG for 2 years, 3 years, many of my own colleagues would fume at me for not giving proper treatment. Now, why I'm saying is that there are a lot of diverse misconstrued information. See, the fetus adds a burden to the pregnant women. For a pregnant woman with hypothyroidism, Hashimoto's, because there is increased demand for the maternal thyroxine production, 1.5-fold introduction because of the fetal demand. And also that is active placental degradation of the thyroxine produced by the mother, and there is increase in the beta HCG, which actually drives TBG production because of the rise in estrogen. So there are multiple physiologies which go different when compared to a non-pregnant woman. So, what you need to remember is that with regard to the physiology, the findings of heat intolerance, weight loss, anxiety, palpitation, tremor, heat intolerance, all are seen in both pregnancy as well as a pregnant mother, as well as with thyrotoxicosis. And only a pre-existing, so many times you would be asked, right, treat with anti-thyroid drugs. Most are not thyrotoxic patients, which are all physiologic changes in pregnancy. And a simple cardiologic point is, with response to Valsalva maneuver, I think we as a UG, we are taught during sleep, if the heart rate is fixed, it is thyrotoxicosis, hyperthyroidism. So if there is a variation, even with ECG, whatever be the lab report, we are only dealing with the physiology and not with the hyperthyroidism. So you can see the overall rate increases 20 to 25%. I have seen patients having a heart rate of 150, and most mothers are anemic. That adds to the tachycardia. Nutrition plays a role. So take all factors into account and take the physiology into account. So this we have been reading since the 13th edition. Now I was wondering, many would say, why is not starting with anti-thyroid drugs? See, the normal range of circulating levels of FT4, I don't know what is the latest edition. This was like taken 2 years back. FT4, FT3 and TSH remain unaltered by pregnancy. Now this is because of physiology there is alteration. But remember that there is a huge alteration. You can see the TSH suppressed from 8 to 14 weeks. Only beyond 20 weeks it reaches the normal. T4 rises to plateau at 14 to 15 weeks. FT4, see, initially it rises. So this can make you treat unwantedly with anti-thyroid drugs. So this is the relation between HCG and TSH. A suppressed TSH because of an elevated HCG. Make sure that you have this picture in mind, because in pregnancy this is the most important part, because any woman who does not have pre-existing Graves' disease is very unlikely to have a Graves' disease in pregnancy. So these are some of the pooled data study. You can see this is with regard to normal women. You can see how much the TSH suppressed throughout the entire pregnancy. Generally in pregnancy, for many women, TSH is very much suppressed. And also make sure that the patient is not having hyperemesis gravidorum. You can see how much the beta HCG is directly correlated with nausea, vomiting, as well as hydrated deformed mole, usually symptomatic when the level is more than 3 lakh MAU per ml. So when the HCG is high, the FT4 is high, the TSH is suppressed. So this physiology has to be kept in mind. And do we do free T4, free T3 or total T4, total T3? See, this is a patient sample sent to multiple different labs. Can you see that none of the values are consistent? It's played over. Free T4, free T3 are notoriously wrong. You can get very abnormal results, played results during pregnancy. But total T4 and total T3 are much more consistent. You can see because of the HCG mediated effects, the T4, T3 rises from 8 to 14 weeks, then plateaus off at 20 weeks. So this is DGROOTS, which is our Bible. And most recent all recommendation, do not entertain measuring free T4 for pregnancy. And if you want to measure T4, always multiply the range of T4 into 1.5 times. So T4 also, reference also gets increased during pregnancy. Now why I am saying this, remember that if you are unwantedly treating a patient with anti-thyroid drugs, this I have seen many times. The first month you can see at the foot, the first almost 20 weeks, the fetus is entirely dependent on the mother for thyroxine. Only later, after 11 to 12 weeks only, the fetal thyroxine production starts. So all the neuronal proliferation, migration, cortex, hippocampi, everything would be affected if you are treating mother unwanted with anti-thyroid drugs. And this is one case illustration. This while I was in Chennai, famous IVF center. She was planned for a cervical cerclage. I was asked to give a clearance. You can look at the TSH. This is the first time she had conceived at 40 years. The TSH is suppressed, FT4 is increased, FT3 is increased. Pulse rate is 120. This is a twin pregnancy. And you can see at the foot, the reports. Some of them were furious. I didn't start anti-thyroid drugs. I reassured them this is only physiology. And the T4 you can see it's 15.7 and the T3 is 248. For pregnancy it is normal because you say you take 12. So even up to 18 it's normal. You multiply 12 by 1 up to 18 it's normal. So T4, T3 is showing reliable normal values. This patient I did not treat with the anti-thyroid drugs. I convinced the anesthetist. After follow-up, see the TSH has come back to normal. So this is our entirely normal physiological changes happening in pregnancy. And if you treat such patients, this after 40 years, they are most precious child. There is going to be fetal hypothyroidism and abortion. So why this child? Because the first one is with the unwanted antithyroid drug use. The second, the bottom would be because of neonatal thyrotoxicosis, improper treatment of maternal thyrotoxicosis. So interpretation, re-evaluate clinical history, age, pregnancy, any other factors like pregnancy, consider how they are taking, confounding medications, non-thyroidal illness. Then you can think of referral. I would like to cap off with this one scenario. So this while I was in IOG, I got a reference from pediatric SEH. You can read from surgical oncology, pediatrical, a 7-year-old girl who was diagnosed with papillary CA thyroid, first surgery. They referred to me. It was quite fishy because she was standing in the assembly for a long period. She had a syncope and fell. Someone noticed a goiter. So then they did an ultrasound abdomen, ultrasound thyroid, CT neck. So you can see ultrasound thyroid, diffuse goiter, CT neck, no nodules. And they did an FNAC, right? So in the FNAC, you can read the pathology report, highly cellular aspirate, few tight clusters of epithelial cells, papillas, and based on this, they have given a papillary carcinoma thyroid. They did another FNAC, which came as adenomatous goiter, so they were confused. If you look at the TSH is more than 150, look at the bottom. And when I put my fingers, it was just a simple diffuse goiter, primary hypothyroidism. Rather than giving me the levothyroxine, they unwantedly did an ultrasound. Actually, there is no role for ultrasound in most of the patients if you are very confident with your hands. So make sure that you don't do an unwanted ultrasound patients with diffuse goiter or with small nodulity, especially in the acute phase, whether it's thyrotoxicosis or with Hashimoto's thyroiditis. This is the American Thyroid Association guideline. Even for some patients with more than 1.5 cm, up to 1.5 cm, we can wait for the acute hyperinflammation phase to pass away. Because if you do ultrasound scans at that time, the lymphocyte aggregates will form as nodules. Sometimes I've seen 2 centimeter nodules. After a year or so, everything would return back to normal because the lymphocytic aggregation actually creates a macro pseudonodular appearance. So make sure that you use the imaging methods wisely. Also, when you do an FNAC, you can see the pitfalls. When we were studying pathology, Robin's pathology, the diagnosis was mostly based on the papillary pattern. But remember that when you do with Hashimoto's thyroiditis, where there is intense inflammation, there may be some nuclear features of papillary thyroid carcinoma. Again, so don't put unwanted needle if you are very clear. So the papillary thyroid mimics, we need to know the pathology also. How the papillary pattern is, whether it's short stubby. With short stubby, it goes to point out a benign. So papillary pattern, nuclear features. So this was in 90s, the FNAC, which was mainly based on papillary. So we have to also keep evolving. Now you look at the recent criteria, regardless of papillary pattern, it's the nuclear features which are most important. Nuclear crowding, grooves, snouts. So those are important features. So now this is a collection which I have taken in our college. So for 7 patients I have followed up. All are diffuse. Okay, even up to 1.5, there is no need to do an FNAC. So all these 7 would have been just left with the medicines. But if you can see 2 patients, coming with a permanent endotracheal tube for lifelong, both recurrent laryngeal palsy have been done. So this is the sad part. So I think it's, I still remember in UG, any thyroid we refer to, I think madam shouldn't mistake me, surgeon, but it's mostly you can go back is a good medical case, you can discuss it. And if there is a clear-cut nodule, features like Bethesda criteria or the ultrasonographic features, the TR, all are suggestive of FNAC, then you proceed with the surgeon. So most of the time, unwanted testing, unwanted imaging, misadventures can really change the fate of a patient. So here 2 patients have suffered a lot. Also, we have seen some patients, bilateral ovarian tumor with primary hypothyroidism asking for clearance for surgery. If you make the patient euthyroid, I have seen in one case where the tumor were like 16 into 18 centimeter size, regressed after 6 months when the TSH came to me. So all are fundamental physiology. So make sure that we look into the clinical history, understand the thyroid physiology, most important, what lab you are doing, whether the lab is standardized, and then take a decision. Thank you.
From the pediatrician point of view, I want to add a few relevant points for the sake of postgraduates. The neonatal screening program, there are 2 types of neonatal screening program. One type of screening program mainly concentrating on TSH alone. And what is commonly being followed is the TSH along with the T4. If T4 is low, then they do TSH level. That is an ideal recommendation. And as far as a newborn is concerned, even a fetus is having hypothyroidism, mother's thyroid state is very, very important. As already as I mentioned, up to mid-gestation, the maternal thyroid hormone is the main factor responsible for the development of fetal brain. If the fetus is hypothyroid, due to various reasons, still the mother's hormone plays an important role in the prevention of hypothyroidism of the fetus. That is very important. So mother's thyroid status during pregnancy is very, very important. And second point of view, there are 2 types of abnormality. One is a transient neonatal hypothyroidism. This entity is peculiar to a newborn baby, lasting for 6 to 8 weeks of post-neonatal period. This is due to the transplacental transfer of maternal antibodies, that is thyrotropin receptor blocking antibody that might cross the placenta and leading on to a transient hypothyroidism in the newborn baby, lasting for only 6 to 8 weeks. Until then only the antibody acts. This should be considered when there is a maternal history of antithyroid disorders, and also when there is a past history of transient neonatal hypothyroidism in the previous sibling. In this scenario, we have to treat the newborn baby with thyroxine for a period of 6 to 8 weeks. After that, the baby's thyroid function returns to normal. That is one important practical point as far as the pediatrician is concerned. And the most common cause for congenital hypothyroidism is the agenesis of the thyroid gland, and this contributes about 85%, and 15% contributed by thyroid hormone dysgenesis. That is defect in the hormone genesis. So 85% is mainly due to thyroid agenesis. So you have to take a critical decision how long we have to continue the thyroxine. So if you're having congenital hypothyroidism, don't stop the treatment for first 3 years of life. This 3 years very, very important as far as the brain development is concerned. So if you are having a baby with congenital hypothyroidism, you continue thyroxine for 3 years, then take a decision to stop thyroxine for a shorter period for about 3 to 4 weeks. And if you happen to see an increasing TSH, then you have to continue TSH lifelong. There is another important practical point as far as PGs are concerned. These are the certain things which differs from the
like a pituitary apoplexy, a pituitary stalk transection related to the road traffic accident, but this was a surprise. But the chances of pituitary stalk transection is much more common with the severe head injury. But he said was the last 20 years. Might be it would have been a slow growing pituitary adenoma. But he was much more symptomatic the last previous 2 years. Because prior to that, he did not have any admissions. Based on the first MRI, the previous neurologist had started antiplatelet because something related to hypertension would have thought and started answering. But that's not clear, sir.
So regarding this,
Is there any unique ultrasound feature of Hashimoto's thyroiditis?
No, sir. It can only show hypervascularity, increased heterogeneous echogenicity, as well as increased vascularity. In the setting of nodularity, as I said, lymphocytic aggregation, some radiologists pick it up very clearly. Like even they can say some germinal center formation. So it's only the increased vascularity, increased echogenicity, and hypervascularity based on the Doppler, which says the inflammation.
During pathology,
It is suppressed. Everything else will be raised.
Papillary carcinoma of the thyroid. Many biopsy report because thyroid is a very active tissue going on proliferating like intestine. In my opinion, papillary carcinoma lab test is always better pathology. Don't buy because the papillary carcinoma of the thyroid, many biopsy report will come because thyroid is a very active tissue going on proliferating like intestine. So papillary carcinoma is always better.
Only it's the educative part.
Sir, surgery is usually not advised. Surgery management is always, we usually won't advise surgery for diffuse goiter unless there is any toxic features. No.
Yeah, that's acceptable.
Regular teaching is only toxic.
I only say educative part.
Surgery is usually not advised.
Definitely.
No more medical management is always advised.
Sure.
Thank you, sir. Thank you, sir, for that deep dive into the pearls and pitfalls of thyroid disease management. I now request to honor Dr. Shiva Prakash, sir, for his eye-opening speech on thyroid disease. Thank you, sir. Thank you, sir, for that deep dive into the pearls and pitfalls of thyroid disease management. I now request to honor Dr. Shiva Prakash, sir, for his eye-opening speech on thyroid disease. For their time and valuable input for this session, I request Professor Dr. Rajesh, sir, Chief of Medicine, to honor our chairpersons. Request Professor Dr. Rafi honors Professor Dr. Pavitra Devi ma'am, Head of Department of Surgery. Next, I request Professor Dr. Rajesh, sir, to honor Dr. Babu Kandakumar, sir.
Thank you, sir. Moving to next session, we now shift our focus to the foundation of a vital medical specialty, clinical cardiology, back to basics. In a world of rapidly advancing technologies and treatments, it's often the fundamentals that provide the strongest grounding. This session aims to revisit core principles, unravel the complexities of clinical cardiology, and reinforce the basics that guide us in saving lives every day. To lead this important session, we have the privilege of welcoming Dr. Arun Gopalakrishnan, sir, Additional Professor of Cardiology, Sri Chitra Tirunelneli Institute of Medical Sciences. With an illustrious career in cardiology and a passion for teaching, Dr. Arun Gopalakrishnan, sir, has been a beacon of knowledge for both peers and students alike. Their expertise in simplifying complex cardiac concepts is widely recognized and making him the perfect choice for the session. A warm welcome for you to the dais. As chairpersons for this session, we have Dr. Ravi Edwin Sir, Professor and HOD of Cardiology, Tirunelneli Medical College, Dr. Arul Sir, Retired Director of Cardiology, Madras Medical College, and Dr. Rajavel Murugan Sir, Professor and HOD of Medicine, Thoothukudi Medical College. We welcome you to the dais, sir.
Good morning, everybody. First of all, it gives me a great honor. I thank the Department of Medicine for having invited the classmates today, me, Arul, and Rafi. We both were classmates, and God has elevated us to the best profession. Arul retired as a Director of Cardiology, and me, HOD of Cardiology, and Rafi as a HOD of Medicine. So, same batch. So Goddess and Dr. Thiruvasamani, HOD of Urology. So we are a blessed batch. And I remember me and Rafi studied medicine before the final year exam. In the opposite to our hospital, there was a lodge. So we stayed together and we read medicine. I hope Rafi would have remembered that. And we were reading tetralogy because at that time 50% only they passed. Professor GS was our examiner. 25% medicine pass. So we were so fortunate that we got our pass in medicine and in 1988. So we vividly remember that. And now regarding the speaker, Dr. Arun Gopalakrishnan, and we all look forward for him for his wonderful talk. He is from Tirunelneli Hospital, additional professor of cardiology, and he is the right person to talk for us because we look towards Tirunelneli for all the things. So he has come here to deliver the clinical cardiology pearls. Even though we have come to the TAVR, TAVI, everything in cardiology, the basics, the cardiology. Because there were one session in a conference, is death obsolete? Is death useful in cardiology? So, and one beautiful, it was in a European Society of Cardiology in Europe. There were a debate, is death useful or not? And beautifully the clinical cardiology session, he talked over it. 80% of the diagnosis in cardiology becomes over when you do a proper clinical examination. Only 20% other things. So that is the beauty of cardiology. You know everything, the look of the patient itself, we can come to a diagnosis 50%, and if we touch the patient, another 30%. If we take our step, all the diagnosis is over. So this was our teaching. Professor Venugopal, I cannot forget my guru, because on seeing him only, we all took medicine. Me, Arul, Rafi, everyone, Somasundaram in our batch, everyone took medicine because our professor. Because he used to teach ECG, clinical cardiology at 1 a.m. You can I think the night clinics culture now, I think, is it there or not, I don't know. But we were taught medicine at 12 midnight and 1 a.m. So that was the, so that's what we were brought into the field of medicine. So over to Dr. Arun Gopalakrishnan.
Thank you, sir, for the kind words. And at the outset, I would like to congratulate Dr. Rafi sir for his wonderful career and wish him all the best for his days ahead. And I should also thank Dr. Ratnakumar and the entire team from Tirunelneli Medical College, including the Department of Medicine, for having me here, although I am not an alumnus of Tirunelneli Medical College. And After all the, wonderful 2 sessions we've had from neurology and endocrinology, organs which are related to head and neck, high fly talks, we'll get down to somewhat lower down, and hopefully we'll have interactions also. And I would be happy to be corrected by my eminent faculty here because learning never ends. So we'll discuss clinical cardiology, and I'll be discussing essential things for the postgraduates. So it'll only, obviously you cannot, I will not be able to deal everything that is required, but nevertheless, it will be an overview of history taking in cardiology, general physical examination, cardiovascular examination. So some salient points which I would like all the postgraduates to note is identify symptoms. The first thing when you take a case history of a case which is cardiovascular is to identify that the symptoms are related to the cardiovascular system or the symptoms are related to other systems. You should know what are the cardinal cardiovascular symptoms. Someone asks you, they include exertional dyspnea, angina, fatigue, patient's syncope, and plus minus cyanosis, which you may be able to elicit from history itself. Then the aim of cardiovascular history taking is to identify which side of the heart is involved. Is it involving the right heart or the left heart or both sides of the heart? Try to identify from history what is the type of heart disease. Is it a heart disease related to a valve, or is it related to something else? What is the duration of heart disease, and what are the secondary changes, and what is the functional class of the patient? So when you take a history, these are all things that you know, but it is always useful to discuss regarding the index patient before going to other persons, other things like family history. So sometimes what we notice that the person talks about the patient, goes back to the family, and then comes back to the past history and all. Always discuss things regarding the patient and then go to the past history. And some things that are relevant for history taking with respect to evaluation of dyspnea is try to identify whether the dyspnea is of cardiac origin or not. For that, you should try to identify what is distinguished between exertional breathlessness or exertional dyspnea versus non-exertional breathlessness. There are several mechanisms of cardiac dyspnea. I've just tried to jot them down. These are all questions which are asked for the exam. The reasons for dyspnea in left heart disease versus the reasons for dyspnea in right heart disease. You should know what is paroxysmal nocturnal dyspnea and distinguish it from orthopnea. Paroxysmal nocturnal dyspnea is the mechanisms are different, and it is a characteristic sign of a left heart disease, as opposed to orthopnea, which may be associated with left heart disease or right heart disease. Some other terminologies which you may be asked about are what is platypnea, what is bendopnea or tripopnea. I will not be able to discuss each of them in detail. It's all homework for you if you don't know. Then you should know what is the NYHA classification, the New York Heart Association classification, and remember there is a specific scale called Bog dyspnea scale to classify the extent of dyspnea. This is the often used NYHA classification, which classifies symptoms into 4 categories, and this definition is almost always asked for clinical examination, and invariably less than 50% of postgraduates, those who appear for the exam, answer them correctly. There is a rider. The first thing that you should tell when you are asked to tell what is NYHA class 1 or 2 is patient with heart disease, and then comes the rest. So this is only for patients with the heart disease. So patients with heart disease and has no limitation of physical activity. Ordinary physical activity does not cause undue palpitation, fatigue, shortness of breath or angina. It's because angina can also be classified by NYHA. So this is the definition of class 1. So you can go back and identify how the other symptoms are graded. Regarding angina, the typical description of angina you should know. Then you should know what is the difference between typical angina, atypical angina versus non-anginal chest pain. What are angina equivalents? And there is a specific classification for the severity of angina using Canadian Cardiovascular Society classification. Again, regarding palpitations, the aims of history taking will be to distinguish between hemodynamic cause of palpitation versus arrhythmic cause of palpitation. The implications are different. You all know that you should try to identify the onset, offset, rapidity and regularity. Just one cue is that if the patient tells you that there is an abrupt onset of pounding neck sensation, it is more often than not associated with a specific type of a PSVT, that is the AV nodal reentrant tachycardia. Again, syncope was discussed by, to an extent in the earlier talk, but nevertheless, these are some of the features that may suggest that the syncope is related to cardiovascular system. If the patient has a known heart disease, if there is an abnormal cardiovascular examination, there is a family history of sudden cardiac death, male gender, elderly age, the episodes are few, palpitations or chest pain associated. So, and as I am basically a pediatric cardiologist, you will find me dwelling into pediatric topics in and out, and it's important for you to identify history of cyanosis as well, especially when you take history regarding to congenital heart disease. If the history comes with cyanosis, then you should know when the cyanosis started, whether it is static or whether it is worsening gradually. Is there history suggestive of a cyanotic spell, or is there history of squatting in older children? Is there history of stroke or brain abscess, history of joint pains? And there are cyanosis may not always be present at birth, it may present later on. These are the cause of late onset cyanosis. Again, questions which are asked to you in exam. Then when there is history of surgery in the past, try to identify what the type of heart disease from history of surgery. If you find a scar in the left or right postlateral thoracotomy, the list is there. If it's a mini thoracotomy versus a midline sternotomy, the heart diseases that you will think of are listed there. So these are things for you to note down when you try to jot down differential diagnosis. Then what happened to the patient after an intervention? If the patient had cyanosis and there was reduction in cyanosis after surgery, it means the pulmonary blood flow has increased. What are the causes for the same? If the patient had heart failure to begin with and after a surgery heart failure has come down, that means the implications are different. I have listed out the causes. So again, these are the things that you need to interpret during history to bring down to a differential diagnosis. Again, has surgery resulted in development of cyanosis or worsening of cyanosis? That can also happen. Not always does surgery lead to improvement in cyanosis. There are surgeries where after surgery the patient may become cyanotic, or on follow-up the patient becomes cyanotic. So whether it's a shunt block, a patient overgrowing the size of shunt, development of pulmonary vascular disease, there are several causes for the same. Then how to elicit history of heart failure in infancy? Whether there is feeding difficulty, precordial activity, sweating, the child prefers to rest on shoulder. These are all features of heart failure in infancy. So if the patient had heart failure in early childhood and over a period of time the heart failure has improved, what does it mean? It can mean that the heart disease has improved on itself, or there are other complications that have developed. So what are they? They differ in different heart diseases. So this is a list of what you need to be aware of when you take history. Another presentation will be, sometimes you may have a patient who presents without any forthcoming symptoms, incidentally detected heart disease. Now how to approach that? So remember, a patient is asymptomatic at presentation does not automatically mean that the heart disease is hemodynamically insignificant. Also try to identify if the patient has been advised the need for an intervention, or was the patient advised just medical management. So the interpretations can change based on that. So at the end of history, our aim should be to classify the spectrum where the patient fits into. First, identify that the patient has a problem related to the cardiovascular system. Try to distinguish whether it's an acquired heart disease or a congenital heart disease. If it is an acquired heart disease, is it a left-sided heart disease or a right-sided heart disease? If it is a left or right, if it is a left-sided heart disease, try to distinguish between valvular or myocardial or pericardial or arrhythmia as much as possible. If it is congenital, try to distinguish between acyanotic heart disease versus cyanotic heart disease. Or if it's acyanotic, is it associated with increased pulmonary blood flow, or is it an obstructive heart disease or others? Cyanotic, there are 3 physiologies of cyanotic heart disease. History taking will help us identify each of these physiologies. So at the end of history, we should be in one of these boxes. If we are in one of these boxes at the end of history, as Sir said, 50% of diagnosis is actually done. And like you know, we already discussed the NYHA classification for classification of symptoms. Remember, there is a classification called the Ross classification, which is used for symptom stratification in children. It has got some more features in addition to the NYHA class. These are all things that you take in general examination, but sometimes the first thing that you mention in general examination should be the first impression on examining the patient. That refers to the decubitus. Is the patient lying down all the time, or is the patient sitting upright all the time? Is the patient visibly dyspneic? These are important cues that you have to tell before going to the rest of the examination. Often that is missed. It is not just that the patient is conscious and cooperative. It is about telling whether the patient is able to sit up when required, lie down when required, able to walk when required. So that impression is important as the first thing when you start examining a patient. Then after the vital signs, in head-to-foot examination, these are the things that you need to look for. Do not forget to examine the oral cavity, the spine, any thyromegaly, fundus and the gait. General physical examination ends only, you go to systemic examination only after these things are done, because a significant proportion of your diagnosis can be formed at this point. You might be taking several anthropometric indices, but often what we notice that the person will take the height and weight and then leave it there. It is important to interpret what does, if the person's height is 150 centimeter, what does that mean? Is it short statured? Is it abnormal? Is it normal? Interpretation of each anthropometric sign is more relevant than just giving the numbers. And the intelligent student should make it a habit to calculate the body mass index and try to identify the body surface area as well, because some of the cardiovascular system findings have relevance to body surface area. And you should not be surprised if somebody asks you some of these novel anthropometric indices which are now often used in cardiology, because they have more relevance to cardiovascular health as well. So remember some of these, you need not classify, take them in every examination, but you should be ready for questions regarding novel anthropometric indices. And at the same time, if you are taking history of an elderly patient, the patient is barely able to stand, or the patient is sick, you must be able to grossly assess whether the patient is frail or not. There is a frailty index. Please go back and read the frailty index, the Fright criteria. And when you start cardiovascular examination, do not directly go to the precordium. You have to, the cardiovascular system examination includes pulse, blood pressure, JVP, and then the precordial examination. So you have to dwell in detail with each of them. You know regarding the arterial pulse, but when somebody asks you what are the abnormalities of pulse volume, some people don't know what to tell. Or what are the abnormalities of pulse character, people don't know what to tell, where to look for. So if you examine systematically, these are the points that you need to take down for examination of arterial pulse, volume abnormalities, character abnormalities, look for peripheral pulses, and make down a point on each of them, because the examination goes in a pattern for a certain reason. Because without examining the arterial pulse, there is no point in looking at the blood pressure, because blood pressure is an interpretation of findings that are actually already partly elicited in arterial pulse examination. Then JVP refers to two components, the jugular venous pulse and jugular venous pressure. Jugular venous pulse refers to the oscillating top of the vertical column of blood in the internal jugular vein that reflects the pressure changes accurately in the right atrium, while jugular venous pressure refers to the actual vertical height of oscillating column of blood. So be aware of both terminologies. You all know why internal jugular vein is used. Why the internal jugular vein is used. These are the questions that are routinely asked for in the examination. Why not the external jugular vein? You can go back and read. Again, next question that always the candidate is asked is how to take the JVP. Should you take it lying down? Should you take it sitting upright? Should you take it in 45 degree? Any JVP that is elevated when if you are able to see the neck, the jugular venous pulses or the pulsations in the neck, venous pulsations in the neck when the patient is upright, JVP is elevated. Because as the definition goes, it is the vertical height of the blood that is measured. And literature over the years have shown clearly that if the JVP is elevated, when if you are able to see when the patient is upright, JVP is elevated. Then you can look at the description of the waveforms and the patient is made at 45 degree and all. But if it is elevated in sitting position, it is definitely elevated. You should know how to measure in both ways, in sitting and in 45 degrees. Then if you take in 45 degree, if the venous pressure higher than 3 centimeter higher than the sternal angle is considered abnormal. You know why? Because the 5 centimeter, the reference angle is at the angle of Lewis, and these are the reasons. And you know the conversion factor, how to convert the height in millimeters of blood into millimeters of mercury. That is the conversion factor. Centimeters of water into millimeters of mercury. Another question that is routinely asked is how to distinguish between JVP and carotid pulse. These are the points that you already know, but you are routinely asked the differences between JVP and carotid artery pulse. Another question that is routinely asked is how to elicit the abdominal jugular reflex or hepatojugular reflex. Remember, it is not reflex, it is reflux. So it is a back pressure that is elicited from the abdomen into the neck veins. And some important cues to remember is that you should not hold the breath and the compression should be sustained. And these are the interpretation when you have a sustained elevation. And you can have false positive, these are causes for false positive and false negative hepatojugular reflex are listed out here. And another important, at postgraduate level, at MBBS level, elevation of, if you are able to identify the JVP is elevated, that is good enough. But at postgraduate level, you should be able to identify the waveforms as well, especially when the patient does not have sustained tachycardia and is in gross heart failure. In the absence of sustained severe tachycardia, you should be able to, if the JVP is elevated, you should be able to elicit the JVP waveforms. For this, you should always come back to how to identify elevated JVP waveforms is by simultaneous auscultation or by simultaneous palpation of the arterial pulse. And you all know which are the waves of the JVP A, C, X, Y, this X and Y descents and the V wave. But how to distinguish between which is A, which is V? For that, you have to time with, this is the timing cycle with the ECG. Remember, the systolic in an ECG is from the peak of R to the end of T wave, and a systolic positive wave is the V wave, and a diastolic positive wave is the A wave. How to identify that clinically? For that, you can either use the second heart sound by auscultation or by palpating the pulse. So, the A wave precedes the first heart sound, and X prime corresponds to the second heart sound and the radiatal pulse, and the Y descent occurs out of phase and occurs after the second heart sound. So identify the second heart sound or what happens at systole, and then identify what lies out of phase. So after S2, the descent after S2 is Y, before S2 is X prime. This is the checklist for precordal examination, you all know, and it's always advisable to combine inspection and palpation together, because it is advisable to not say apex looks up. It may be here in inspection and then it is somewhere else in palpation. It's always better to combine inspection and palpation together. And another important thing to note in cardiac examination is to not miss the position of the cardiac apex and also the situs. Abdominal situs and cardiac position should not be missed while you elicit other findings as well. And then some relevant points in auscultation. What is a normal first heart sound? Questions which are asked for exam. What is a normal first heart sound? Normal first heart sound is the first heart sound that is best audible at the apex. It's louder than the second heart sound at the apex, and it is rarely appreciated. How to assess the first heart sound? First heart sound you should assess for constancy, intensity split, and intensity. More than the first heart sound, questions are asked regarding the second heart sound to the candidate. So how to describe the second heart sound? Describe the split and the individual component. And when you describe the individual components, it's always advisable to describe the pulmonary component in relation to the aortic component. Is the pulmonary component loud? Is the pulmonary component soft? That is what is most crucial. Not the A2 is loud or A2 is soft. That is much rarer a finding than abnormalities of the pulmonary component. So, pulmonary hypertension is present or not is what is exactly what the examiners are looking for you to commit. So, describe the pulmonary component in relation to aortic component. What are the reasons for the delay in for the normal splitting? These are the reasons. Where to read this? Any idea? Can any postgraduate tell me where to read this? Any postgraduate can tell me where to read this clinical cardiology? 1 or 2 books? Any name of any book? Very good. Jules Constant. So go back and read Jules Constant or Abrams. 2 good old clinical books which you should go back and read. Okay. So another thing that is asked is what is hangout interval? Okay. In the previous slide, it showed that one of the reasons for the splitting is hangout interval. What is hangout interval? It is described here, but I have not. It is labeled there, but I don't know whether you understand or not. Hangout interval refers to the time between the crossover of the pressure waveforms in the corresponding ventricle and the great artery. If it's the right heart, hangout interval we usually refer to the right heart, because left heart pressure changes are very minimal. So with respect to the right heart, we have the right ventricular pressure tracing and the pulmonary artery pressure tracing, which is given there. At the point of the dicrotic notch, the time interval between the ventricular pressure trace to the aorta, to the dicrotic notch, that is the hangout interval. That gets altered by respiration. That is what we assess. What are the types of split of the second heart sound? What is normal split, wide variable split, fixed split, paradoxic split? Okay, these are the 4 types of split of the second heart sound. Now, most commonly asked question is, what is a normal split of the second heart sound? Normal split of the second heart sound refers to a second heart sound that is split normally in inspiration. That is A2 followed by P2 and is single in expiration. This is what you should tell if you are asked to tell what is a normal second heart sound. A normal second heart sound is a second heart sound that is normally split in inspiration and single in expiration. So you can go back and read the descriptions of wide variable split, fixed split, paradoxical split. Are you aware there is a classification of paradoxical split? We'll come to that. The causes for wide fixed split, narrow fixed split, causes for paradoxic split are written down. And this is the classification for a paradoxic split. Type 1, type 2, type 3. So, only clinically you will be able to identify only a type 1 paradoxic split. Paradoxic split means you get a P2 followed by A2 in expiration and single in inspiration. If you are able to identify that, you have identified paradoxic split. Most common cause of paradoxic split? I had listed out the cause of paradoxic split here. Most common cause of paradoxic split? most common paradoxical split in adults? Left bundle branch block. Left bundle branch block. So, how to, if you have a doubt whether the split is normal or paradoxic, how will you elicit it at the bedside or with the patient? Do a Valsalva. Do a Valsalva maneuver unless the patient is in gross heart failure. You will be able to distinguish between a normal split versus a paradoxic split. How to identify? That is described here. For want of time, I will give it to you as a homework. So normal split versus paradoxic split, you distinguish it with the Valsalva. There is a pseudo-paradoxic split of second heart sound as well. Pseudo-paradoxic split of the second heart sound is seen in COPD. The mechanism is because the lung comes in between during deep inspiration. Third heart sound. Third heart sound, there are several types of third heart sound. Physiological third heart sound, pathological third heart sound. Pericardial knock is also a type of third heart sound. Pericardial knock is also a type of third heart sound. So these are the causes of a third heart sound. So it may be physiological, which is seen in children, or in hyperkinetic states. In pregnancy, you may find a third heart sound. Volume overload states, LV dysfunction, constricted pericardium. Remember, pericardial knock is a third heart, so it's a loud, early third heart sound. And the mechanism of pericardial knock is listed here. When it has a clicking or a snapping quality rather than an S3, you term it as a pericardial knock. That's all. Fourth heart sound. These are the causes of fourth heart sound. Fourth heart sound, usually, remember, third heart sound is better heard than palpated. Fourth heart sound is better palpated than heard. In hypertrophic cardiomyopathy or in systemic hypertension, you can palpate. In an elderly, you can palpate a fourth heart sound. Once you palpate, you feel a double apex kind of feeling. Then you go back and auscultate carefully. You'll be appreciate the fourth heart sound. Another thing is gallop. Various types of gallops are there. What is gallop? When you have a second heart sound and an additional multiple heart sounds in diastole. It may be an S3 gallop or an S4 gallop. S3 gallop may be called a proto-diastolic gallop when it's an early diastole, or it may be an atrial gallop when it is late in diastole. It's an S4 gallop. And when they occur together, it is called a summation gallop. So, you may be asked, what are the causes for S3 gallop, what are the causes for S4 gallop, and what is a summation gallop? And this is the description of a classical description of a summation gallop. Clicks. What are the types of clicks? You have constant clicks and phasic clicks. Phasic clicks means clicks that change with the respiratory phase. There is only one classic cause for phasic click, that is a pulmonary valvar click. All other clicks are constant. They can be valvular, aortic, or vascular in either sides. There is non-ejection click. There is a click of AV valve, more commonly mitral valve, less commonly tricuspid valve. What happens? How to elicit the changes in the click with the dynamic auscultation? It's mentioned here. Opening snap is another clinical finding that you need to elicit. Click is a systolic event. Snap is a diastolic event. Click is a systolic event, snap is a diastolic event. Please remember that. And the A to OS interval is inversely proportional to the severity of the transmitral gradient. And these are the ways that you describe murmur day in and day out. Just listed here so that you don't miss any of the points. And as sir already mentioned, before reaching auscultation, 80% diagnosis should be made. You will be able to diagnose with history and general physical examination and precordial inspection and palpation. 80% of diagnosis in all, even complex congenital heart diseases, you will be able to make a diagnosis. Auscultation adds least. So, it is not the stethoscope that probably adds maximum to the clinical diagnosis. It is the history and examination prior to auscultation. Remember the terminology of murmurs. You don't diagnose ejection systolic murmurs. These days it is a typical description as a mid-systolic murmur. So please try to follow the standard description of murmurs. Systolic murmurs may be called early systolic, mid-systolic, late systolic, or pansystolic. There is another terminology called S1 coincident murmur, again a pansystolic murmur. Somebody asked you what's an S1 coincident murmur, it's only a pansystolic murmur. These are the causes of the various types of murmurs. And in general, the classical description of the crescendo decrescendo murmur, which used to be called as ejection systolic murmur and now termed as mid systolic murmur, as the severity of the obstruction increases, the murmur length increases and the peaking becomes closer to the second heart sound. Except, in general, as the severity of the outflow tract obstruction increases, the peaking of the murmur becomes late, length of the murmur becomes more, and peaking becomes late in all forms of obstruction except tetralogy of Fallot. Except tetralogy of Fallot, where the intensity of murmur is inversely proportional to the severity of outflow tract obstruction. When the quantum of blood flow is less, the murmur becomes faint. So much so that in a cyanotic spine, you may not have a murmur. It is most reassuring to have a tetralogy patient with a loud murmur than a tetralogy patient with a faint murmur. So, murmurs without heart diseases. These are the causes of murmurs without heart disease called as innocent murmurs. And unlike systolic murmurs, diastolic murmurs are almost always pathological. So, the mid diastolic murmur and continuous murmur, the list of continuous murmur. What is a continuous murmur is another question that is routinely asked. Continuous murmur need not last throughout systole and diastole. Any murmur that begins in systole continues over the second heart sound and into a part of diastole. That is a continuous murmur. Any murmur that begins in systole continues over the second heart sound into varying extents into diastole is a continuous murmur. These are the causes of continuous murmurs. Well, I'll skip auscultation. Dynamic auscultation. These are the maneuvers that I've only mentioned the maneuvers that you do in the modern era. I've taken out phenylephrine or amyl nitrite or all other things which you don't use in the modern day. These are the maneuvers that you can easily do day in and day out or for examination purpose. Respiratory changes, Valsalva, isometric hand grip and postural changes. So, I think I'll skip them for want of time. So, to conclude, at the end of clinical examination, how to write a clinical diagnosis. That is another important thing that the postgraduate should know. First thing is to write a hemodynamic diagnosis. What exactly is it? If it is a valvular heart disease, severe valvular heart disease is a valvular heart disease. If it is an acyanotic heart disease, increased pulmonary blood flow, it is an acyanotic heart disease, increased pulmonary blood flow. That is the hemodynamic diagnosis. The anatomical diagnosis comes subsequently. Then try to say what is the etiology. If you think it's rheumatic, yes, it is rheumatic. If it's infective endocarditis, put that way. Then what are the associated parameters? In other words, what are the complications? Is there pulmonary venous hypertension? How is the ventricular function? Is there pulmonary arterial hypertension? What are the complications associated? Is there are there embolic phenomena? The functional status of the patient, associated diagnosis, and for congenitals, the weight and saturation, like this. So, if you have a valvular heart disease, multivalvular heart disease, likely rheumatic heart disease, then the individual lesion, then go in a systematic manner from the pulmonary venous side to pulmonary arterial side, from the ventricular function, pulmonary venous, pulmonary artery, rhythm, whether the patient is in heart failure, any complications, functional class. If it's for congenital heart disease, this is how you write a diagnosis. And in congenital heart disease, do not forget to mention the situs and the cardiac position. Thank you.
Thank you for the wonderful presentation. I think we cannot cover the entire cardiology in a very short span of 45 minutes. First of all, I don't want to lose my strength. I always want my identity to be kept. As a doctor, we want the strength And before writing any prescription, it's better to use your stat. That is what I advise my students. I got my stat 42 years back, but even after my retirement, my first tool is the stethoscope. So as Ravi was telling, even in our American Heart Association, there was a debate. Okay, but as the youngsters, we have to teach the clinical things. Out of my experience, for the past 14 years, I am a DM examiner. My experience is a good student who is very good in clinics will be a very good physician, very good cardiologist. So that is what I have observed. Intervention comes late. Intervention is your skills, and even the technician can do a thing. But as a clinical cardiologist, you have to know the entire thing about history taking and clinical examination. That is what you are highlighting. We have learned our clinical knowledge from our gurus. So many of our gurus here taught us the thing. The 5 cardinal symptoms, even I remember even now, is the most vital thing that makes a clinical diagnosis 50%. I diagnose with the history. Even 90% I diagnose, because chest pain is one thing. The patient comes with chest pain, ECG is normal, echo is normal. But history taking alone, history, nothing but the history only confirms the clinical diagnosis of an underlying coronary artery disease. That is what first I have learned. Because many times I have seen student bringing the case, ECG normal, echo normal. History taking, I ask them to get admitted. In another 15 minutes, the patient will have an acute MI. So history taking is very, very important, especially in cardiology. First is the chest pain. Second thing is the palpitation. Chest pain, I never leave any patient as non-coronary without taking this cardinal chest pain. Retrosternal chest pain brought on by exertion and relieved by rest. Very classical. Nothing else gives the diagnosis rather than your history. Second thing is your symptom of breathlessness. Mostly I use the symptom of breathlessness for the left heart problem or right heart problem. Mostly our students will be getting a mitral stenosis, a PND, underlying left heart disease. Either a mitral stenosis is the most common, mitral regurgitation. A PND is there means a left heart disease is there. It is usually a left atrium to left ventricular outflow tract obstruction. That is the history which always asks them to do it. As you rightly told, orthopnea can be due to a right heart problem or a left heart problem. Second thing, mostly this thing, and also you can assess the severity of the disease by taking the breathlessness history. Third thing is your palpitation. Palpitation, what I advise my students is 2 things are very, very important. Palpitation. If the palpitation comes abruptly and stops abruptly, it is very, very important. That can come only with a supraventricular tachycardia or a transient VT. A palpitation which occurs gradually and weans up gradually, it is mostly a hyperdynamic circulatory state like anemia or any other hyperdynamic circulatory state. This is the third thing from for undergraduates, I am telling.
Yes,
the fourth thing is the your pedal edema. So, okay, all the conditions can produce pedal edema from your hypoalbuminemia, but a pedal edema appearing before the other symptoms and along with the JVP gives a clue that the patient is having an underlying heart disease. In that way, the clinical examination helps you in making a confirmation of diagnosis of an underlying heart disease. So, chest pain, symptom of breathlessness, palpitation, giddiness. Giddiness is also very, very important. That also gives a very good clue. Any patient who has transient loss of consciousness more than 30 seconds, it is unlikely to be a cardiac disease. A cardiac symptom of unconsciousness or near syncope cannot last for more than 30 seconds, because if it is a VT, unless it is reverted, the patient will die. So no premonitory symptoms, sudden giddiness is very transient, is most likely to be a cardiac disease. These are the 5 cardinal symptoms for an undergraduate or a postgraduate must know. From your clinical examination, usually for even for MBBS, MD, in those days we were failed for multivalvular heart disease, EDM, we missed. So we were failed because, as Rafi was telling, out of 100, only 22 were passed in the MBBS. So now as a teacher for so long a duration, certain clinical findings are subtle. When 2 of the 3 examiners are having a difficulty in eliciting a murmur or eliciting, or we have some controversies, then we always give the advantage to the students. So subtle signs or subtle symptoms can be corrected, but sign which is very, very classical should not be missed from the student's point of view. Especially as you were telling, the first start sound, always use the first order. Mostly they get mitral stenosis. A varying intensity of first order sound, roll out mitral stenosis, that's the classical teaching. A loud first order sound could be a mitral stenosis. The second order sound, as I rightly pointed out, P2. A2 I'm not bothered. Always I'm bothered with P2. P2 loud. It is reason manja. Either ASD pulmonary hypertension, VSD pulmonary hypertension, or PDA pulmonary hypertension, and other things help you to roll out the things. Absent P2, it is always a congenital cyanotic heart disease that has to be rolled out. S3 always denotes a systolic dysfunction of the heart. S4 always denotes the diastolic dysfunction of the heart from the basic point of view. Murmur, you classically told about the murmur, everything you told about. As you rightly, mid-systolic murmur and a continuous murmur and pansystolic murmur. Pansystolic murmur, only three conditions: tricuspid regurgitation, mitral regurgitation, VSD. These three are very classical pansystolic murmur. A mid-systolic murmur always a LVOT obstruction or RVOT obstruction in the form of aortic stenosis or a pulmonary stenosis. In that also you have clearly pointed out the peaking of the murmur always helps in ruling out the severity of the disease. The later peaking, always the severity is more. And continuous murmur, mostly for the younger generations, it could be a functional murmur or it could be usually a PDA for undergraduates. You have highlighted most of the things. Thank you for the excellent presentation. Thanks for your presence here. Okay, thank you.
So we all know that of all the branches of medicine, cardiology is always a superstar. It is a field of passion and fancy. So having done my UG and PG in this college, where the basics are taught very beautifully, wonderfully by so many eminent teachers such as VG sir, Velu sir, and GS sir, Alagasan sir, and my beloved chief Gidarani madam, and my mentor Nasser sir, and Mohan sir, Palray sir. I have a great worry that clinical cardiology is deteriorating. It is actually dying. So we physicians are not sticking to clinical cardiology. We are just jumping to the investigative cardiology. So nowadays the investigative cardiology is gaining momentum and clinical cardiology is rapidly deteriorating. And this is a wonderful session, sir. So I appreciate the Dr. Arun sir, there is for a wonderful session. Actually, it was like revisiting my UG and PG period. He has taught a lot of clinical cardiology basics like types of split out, second out sound split, and then Fried criteria and memory shuffle. So it was a wonderful class. So this must be an eye-opener for all the UGs and PGs. Please stick on to the basics. So my co-chairpersons, Arul sir and Ravi sir, were excellent clinical cardiologists. I learned a lot of clinical cardiology during rounds in my UG period from Ravi sir and in my PG period from Arul sir. So they taught me very well. So my request to UGs and PGs, please stick on to the basics. So don't do the investigative cardiology. So basics always give 70 to 80% of diagnosis in any other field, especially in cardiology. So nowadays so many young deaths are occurring in 40 to 50. So why? Because of it is not due to the rapid increase in the MI, because we are missing so many things in the clinical cardiology. So if you give weightage to the symptoms, definitely we will diagnose. So thank you RK sir for giving for choosing this topic, very interesting and wonderful topic, and giving me this honor to sit as a chairperson in the CME for superannuation of my beloved PG teacher and my friend, my guide, Mohamed Rafi sir. And I wish a grand success and a graceful and a peaceful period after his superannuation. So thank you for this opportunity.
Congratulations, Dr. Arun sir, for having, because I learned a lot still. So it was very nice. The expiratory split, you said no, type 1, type 2, type 3. I asked Arun, so this is a new point I am learning. So that is the joy of learning medicine and cardiology. So congratulations for a wonderful talk. And you mentioned Jonathan Abrams. So that was my favorite book. Yes. Out of all cardiology books, because I named my second son Jonathan. So that is the thing. So I loved cardiology and clinical cardiology to such an extent. Thank you, sir, for your wonderful
thank you, sir.
talk.
This is for postgraduates also. The references from Abrams and Jules Constant. So
Yeah,
old books.
most of the things are from Jonathan. Yes. So we as chairperson want to honor the superstar of today, my closest friend and dear friend Rafi.
I immensely pressured to with my both superstars of my classmates, TVMC, 1982 batch, sandwiched between Ravi and Arul. I never seen Ravi without the strength from the CRI period. Still, even is entering the dean room or after the cath lab, is always with a strength and smile. It's a peculiarity, and I admire my friend Arul. He's a teacher. Both are not only my classmates. Arul is my PG teacher in the medicine, and Ravi is the PG teacher in the cardiology department when we are doing medicine. Thank you. And my dear, one of the well-known, well-versed student who take lead in all the aspects, whatever he take. Professor Rajavel Murugan is one of the superstar of the TVMC. He leads, he is now heading the department in the Thuthukudi, which makes the height in the entire south. Thank you.
I will give my talk on the Superannuation Day of Rafi.
Thank you, sir, for this refreshing talk on the basics of clinical cardiology, which can trump even the best physicians among us. I now request our chairpersons to show our gratitude for his concise speech on clinical cardiology with a small token of appreciation. Professor Dr. Shabana Ma'am, Chief of Medicine, to honor our chairpersons for today. I now request Professor Dr. Mohamed sir to speak a few words and share his thoughts on today's occasion. I kindly request retired Professor Dr. Mohamed sir to speak a few words on today's occasion.
ரவி ரிட்டையர்மெண்ட்டு ரஃபி கூட ரிட்டையர்மெண்ட்டு. ரஃபி வந்து அவங்க பேட்ச்சு வந்து ஒண்டர்ஃபுல் பேட்ச். ஏன்னா ரவி, அபு, ஆல் பீப்புள் ஆர் வெரி ஃபேமஸ். அண்டு அவங்க பேட்ச் எக்ஸாமில் தான் இந்த காலேஜுக்கு இருந்த பெரிய கெட்ட பேர் வைப்பாச்சு. இது நான் துணிஞ்சு சொல்லுவேன். எக்ஸாம் அவங்களுக்கு 10:30 மணி வரைக்கும் ராத்திரி நடந்தது. அப்படி தானே ரபி? 10:30 மணி வரைக்கும் நடந்தது. ஏன்னா ஆமாம், 12 வரைக்கும் நடந்தது. அந்த பேட்சுக்காரங்க ரொம்ப கெட்டிக்காங்க. இப்போ எங்களுக்கெல்லாம் என்ன, நாங்கள்லாம் ஓல்டு பீப்புள், எங்களுக்கு நம்ம பையங்க நல்லா இருக்காங்கன்னு ஒரு சந்தோஷம். அதுவும் ஆமாம், எம்எம்சிலலாம் திருநெல்வேலிக்காரன்னா அமெரிக்காக்காரன் இந்தியனை பார்த்த மாதிரி பார்ப்பாங்க. என்ன இவனுக்கெல்லாம் என்ன தெரியும் அப்படின்னு பார்ப்பாங்க. நான் பிஜி படிக்கும்போதே அதை கொஞ்சம் மாற்றினேன். ஏன்னா அங்கெல்லாம் சீப் சொல்லியாச்சுன்னா அப்படியே படுத்துருவாங்க, அதுதான் கரெக்டு அப்படின்ட்டு. நாங்கள் கொஞ்சம் ஃபிசிஷியன் கான்ஃபரன்ஸ் எல்லாம் நம்ம ஊர் மாதிரி அங்கே போய் எதிர்த்து பேசி அண்ணாமலைகிட்டே எதிர்த்து பேசிக்கிட்டு வந்தவங்க. அப்போ தான் மாறிச்சு. அந்த ஜிஹெச்சில் திருநெல்வேலி மெடிக்கல் ஸ்டூடெண்ட்டு படித்த ஸ்டூடெண்ட்டு டைரக்டர் ஆஃப் கார்டியாலஜி அப்படின்னா எனக்கெல்லாம் பயங்கர சந்தோஷம். இந்த காலேஜ் மாதிரி எங்கேயும் சொல்லி கொடுக்கறதில்ல. அதனால தான் நான் இஎஸ்சியில் வேலை பார்க்கும்போது இந்த கிளினிக்கல் கார்டியாலஜி பற்றி பேசும்போது பல்ஸ் பார்த்தா டேக்கி கார்டியா இருக்கு, 140 130 இருந்தது. ஆஸ்கல்டேட் பண்ணால் ஹார்ட் சவுண்ட் மஃபிள்டு. டேக்கிகார்டியா, ஹார்ட் சவுண்ட் மஃபிள்டு, மயோகார்டல் இன்ஃபாக்ஷன் அப்படின்னு கொறி போட்டு திருநெல்வேலி மெடிக்கல் காலேஜுக்கு அனுப்புனேன். இங்கே யார் இருந்தாருன்னா விவிஆர் இருந்தார். விவிஆர் வந்து மதுரையில் எம்டியில் எல்லாத்தையும் போட்டு பார்க்குற ஆள். அவர் இசிஜி எடுத்துகிட்டு இன்ஃபாக்ஷன் இருந்திருக்கு. அப்போ தான் வரதராஜன் படிச்சுட்டு வந்திருக்காரு. இல்லை இங்கே வாடா, நீ எம்டியாடா, இங்கே பாரு, இஎஸ்ஐயில் ஒருத்தன் டேக்கிகார்டியா மஃபிள் சவுண்ட் கொரி இன்ஃபாக்ஷன் போட்டிருக்கான் அப்படின்னு நம்ம பேரை எங்கேயோ ஏற்றி, அப்படி தான் நான் இந்த காலேஜுக்குள்ளே நுழைவுக்கு முன்னாலே எனக்கு ஒரு நல்ல பேர் இங்கே இருந்தது. ஸோ ரஃபி பேட்சு வந்து ஒண்டர்ஃபுல் பேட்சு. ரஃபி அவருக்கு அடுத்த கிரேடு என்னென்னா, எங்கள் ஊரில் பிஹெச்சில் ஃபஸ்ட்டு எம்டி அவர் தான். ரொம்ப நாள் வேலை பார்த்தாரு, அங்கே கிராம மக்களுக்கு சேவை பண்ணார், அவருக்கு நன்றி. அண்டு என்னை பொறுத்தவரையில் ரிட்டையர்மெண்ட் ஆனோன்னா எந்த அசைன்மெண்ட்டும் இருக்கக்கூடாது. நான் சித்திரை திருநாள் போனேன், அந்த எங்கேயும் போனேன், டைம் வாழ்க்கை போதான் 7 மணிக்கு ஓபி 7 மணிக்கு ஓபின்னு வந்துட்டு அதுக்கப்புறமா ரிலாக்ஸ்டாக இருக்கணும். ஏன்னா டாக்டர்கள் என்னை பொறுத்தவரை மோஸ்ட் கர்ஸ்ட் கம்யூனிட்டி வந்து டாக்டர்ஸ் தான். ஏன்னா முதல்ல காசு இருக்காது, டைம் நிறையா இருக்கும், என்ஜாய்மெண்ட்டு கூட வீட்டோடு இருக்க மாட்டோம். கிளினிக் போகிறேன்னு போயிட்டு அப்புறம் கொஞ்ச நாள் கழிச்சு காசு இருக்கும், டைம் இருக்காது. நிறைய காசு இருக்குது, ஸ்டேலிங்கில் ரிசார்ட் இருக்குது, போகிறதுக்கு டைம் இல்லை. காசும் டைம் வந்துடும், உடம்பு ஒத்துக்காது. ஏன்னா ஸோ அதுக்கு போகாமல் அட்லீஸ்ட் ரிட்டையர்மெண்ட் ஆன உடனே நான் காலையிலே போகிறதில்ல கிளினிக்கு. காலையில் சிவில் சர்ஜன் குவார்ட்டர்ஸ் ஜோராக ரிட்டையர்மெண்ட்டை ஃபீலிங்கே கிடையாது. எல்லாம் தெரியும், எங்களுக்கெல்லாம் தெரியும். ஜாலியாக இருக்கணும். ஏன்னா லைஃபு அதுதான் லைஃபு, வாழ்கிறது தான் லைஃபு அப்படின்னு சொல்லி ரஃபிக்கு நல்லா ரெஸ்ட் எடுத்து நல்ல முறையில் அமைதியாக நல்லா வாழணும்னு வாழ்த்துக்கிறேன். தேங்க்யூ.
ஹலோ, என் பேர் டாக்டர் வேலுன்னு பேர். என்ன புதுசாக வந்த பையங்களுக்கு நம்ம யாருன்னு சொல்லணும்ல. வாஸ் ப்ரொஃபஸராக இருந்தேன் இங்கே மெடிசன் டிபார்ட்மெண்ட்டில். அப்புறம் ரஃபிக்கு அருமு பாண்டியன் எல்லாம் சரவணன் எல்லாம் சின்ன பையங்க தான். நான் ரிட்டையர்டாகி 22 வருஷம் ஆச்சு. இதுதான் 22 வருஷம் ஆச்சு. மாதம் கிட்டத்தட்ட 22 வருஷம் ஆச்சு. இன்னும் இந்த ஐக்ரௌண்டு தான் சுற்றி சுற்றி வந்துக்கிட்டே இருக்கோம். வேறு எங்கேயும் போனதில்லை. போத்துல சிரிக்காது என்ன, அப்படி தான் அது. ஏன்னா இந்த காலேஜை விட்டு நான் எங்கேயும் போகிறதுக்கு வாய்ப்பு கிடையாது. இப்படி தான் இருப்போம். இங்கே தான் சுற்றி சுற்றி வருவோம். என்ன லாப நஷ்டத்துக்கும் நாங்கள் கலந்துக்கிற பேர் வழிகள் இங்கே. அதனால் அவர் ரஃபீக்கை பொறுத்தளவில் ஒரு சாதாரண கவர்மெண்ட் சர்வெண்ட்டு கிடையாது. அவர் மோர் தென் தட். நாங்களாம் இருந்தால் வேலை பார்த்தா சம்பளம் வாங்கினோம், வீட்டை போய் சேர்ந்தா ரிட்டையர்மெண்ட்டு முடிஞ்சு வச்சு என் கதை. அவர் கதை அப்படி இல்லை. நாட் ஒன்லி ஹிஸ் அகாடமிக் கேரியர் தவிர, அவருடைய பொறுப்பை தவிர, கவர்மெண்ட் பொறுப்பை தவிர எக்ஸ்ட்ரா பொறுப்பு நிறைய செஞ்சு இங்கே உள்ள டாக்டர்ஸில் மற்றவங்க நிறைய உதவி செஞ்சுருக்காரு. அது உண்மையை எனக்கு பாராட்ட வேண்டியது. அதனால் எக்ஸ்ட்ரா அவுட் ஆஃப் த வே வித்தவுட் எனி மானிட்டரி பெனிஃபிட் அந்த மாதிரி செய்யக்கூடிய ஒரு வாலண்டரியாக செய்யக்கூடிய ஒரு நபர். அதனால் அப்படி ஒரு கெட்டிக்காரத்தனமான அவர் வாழ்க்கையில் அவர் சாதிச்சிருக்கார். அவர் என்னை பொறுத்தளவில் அவர் வாழ்க்கையில் அவருடைய ப்ரொஃபஷனல் கேரியரில் சாதனை பண்ணியிருக்காரு. அப்படி தான் நான் எடுத்துக்கிட்டேன். ஏன்னா அவர் இருந்த பீரியடில் என்ன வேணுமோ எல்லாத்துக்கும் செஞ்சுருக்காரு. யார் எதை எடுத்தாலும் ரஃபீக்கை தேடிப்பாங்க அப்படின்னு சொல்கிற அளவுக்கு ஒரு ஒரு பிக்சரை க்ரியேட் பண்ணியிருக்காரு. அதான் சார் பெரிய. நாங்கள்லாம் இருந்தால் வாத்தியார் வேலை பார்த்தா போனோன்னு கணக்கு, அதோட முடிஞ்சு வச்சு. அவர் அப்படி இல்லை. எங்கெங்கெல்லோ போயிருக்காரு. எந்தெந்த அசோசியேஷனில் இருந்து நம்ம ஜனங்களுக்கு, நம்ம டாக்டர்ஸ் கேட்டகரிக்கு எஸ் டன் லாட் ஆஃப் ஒர்க். அதெல்லாம் நம்ம அப்ரிஷியேட் பண்ணணும் இல்லையா? அந்த மாதிரி ஒரு நபர் இன்றைக்கி ரிட்டையர்ட் ஆகுனா, ரிட்டையர்மெண்ட்டு முடிவு கிடையாது. நான் தான் ரிட்டையர்டாக 22 வருஷம் ஆச்சு. இன்னும் ப்ராக்டிஸ் பண்ணிட்டு தான் இருக்கேன். நான் நைட்டில் தூங்கினேன் 2 மணி நேரமாக 3 மணி நேரம், அது கூட சந்தேகமாக தான் இருக்குது. அவ்வளோ தூரத்துக்கு வேலை பார்த்துட்டு தான் இருக்கேன். அது வேலை பார்க்கலாம், எத்தனை வருஷம் வேணாலும் வேலை பார்க்கலாம். அது ஒன்றும் பெரிய விஷயமே கிடையாது. காலையில் கூட ஓப்பி முடிச்சு தான் வராங்க. புரியுதா உங்களுக்கு? அது ஒரு பெரிய விஷயமே கிடையாது. ரிட்டையர்மெண்ட் இஸ் நாட் எ எண்டு. மேபி இட்ஸ் எ பிகினிங் ஆஃப் இன்னொரு ஏதாவது. ஒவ்வொரு லைஃப்பில் ஒவ்வொரு ஸ்டேஜ் இருக்குது. இது ஒரு ஸ்டேஜ். அடுத்த ஸ்டேஜ் உங்களுக்கு போஸ்ட் ரிட்டையர்மெண்ட். என்னை பொறுத்தவரை போத் எக்கனாமிக்கலி ஆஸ் வெல் அஸ் அதர்வைஸ் ஐ டெவலப்ட் மை செல்ஃப் ஆஃப்டர் ரிட்டையர்மெண்ட். இது உண்மை. அது நான் ஆஸ்பத்திரி கட்டினது எல்லாமே ஆஃப்டர் ரிட்டையர்மெண்ட் தான். அதுக்கு முன்னாடி என்கிட்ட ஒன்றும் கிடையாது. ஸோ ஐ ஹவ் டன் மை எஸ்டாப்ளிஷ்மெண்ட் ஒன்லி ஆஃப்டர் ரிட்டையர்மெண்ட். அதை தான் சொல்ல வரேன். ஸோ ரிட்டையர்மெண்ட் இஸ் நாட் எ எண்டு. இட் மே பி பிகினிங் ஆஃப் ஒன் மோர் இயரா. அப்படி தான் நம்ம எடுத்துக்கணும். அதனால் அவர் இன்னும் நிறைய சாதனைகள் பண்ணுவார்னு நான் நினைக்கிறேன். அவருக்கு நிறைய ஆப்பர்ச்சுனிட்டி கொடுங்க. இந்த காலேஜில் இருக்க ஸ்டாஃபெல்லாம் அவரை பயன்படுத்திக்கங்க, அவ்வளோதான் சொல்லுவேன். அவருக்கு எல்லா இடமும் தெரியும். பொலிட்டிக்கல் ஆல்சோ இட்ஸ் இன்ஃப்ளூயன்ஷியல். நல்லாவே தெரியும் அவர் பொலிட்டிக்கல். இன்றைக்கும் அவர் கவர்மெண்ட்டு இஸ் காட் எ வெரி குட் ஹோல்டு. அதனால் அவரை தயவுசெய்து நல்லா பயன்படுத்திக்கங்க. உங்களுடைய அசோசியேஷன் ஸ்ட்ரென்தன் பண்ணுறதுக்கு பயன்படுத்திக்கங்க. அவர் மூலமாக சில காரியங்கள் நீங்கள் கவர்மெண்ட் சேர்த்து உங்கள் வெல்ஃபேருக்கு அவரை பயன்படுத்திக்கன்னு தான் சொல்லுவேன். ஏன்னா அவர் ரிட்டையர்மெண்ட் ஆகிட்டான்னு நினைக்கவே வேண்டாம். நிறைய விஷயங்கள் செய்வார். அவர் கவர்மெண்ட் லெவலில் மினிஸ்டர் பற்றியில் அவருக்கு கண்டிப்பாக அவர் அடுத்தாப்புல மினிஸ்டரானாலும் ஆயிடுவார்னு நினைக்கிறேன். அவர் அடுத்தாப்புல மினிஸ்டரானாலும் ஆயிடுவார்னு எனக்கு ஒரு சந்தேகம் இருக்குது. ஆமாம் சார், இது எனக்கு தெரியும். அந்த ஃபேமிலி பேக்ரவுண்டை பற்றி எனக்கு நல்லாவே தெரியும். எங்கள் அப்பா என் ஃப்ரெண்டு. அவங்க அப்பா என் ஃப்ரெண்டு, க்ளோஸ் ஃப்ரெண்டு. மஸ்தான் பேர், பெரிய பொலிட்டிஷியன். நீ கேள்விப்பட்டீங்க மஸ்தான் தம்பி திருநெல்வேலி இரட்டையர்கள் திருநெல்வேலியில் கேள்விப்பட்டீங்களா? பிறகு தெரியல. மஸ்தான் தம்பி திருநெல்வேலி 2 பேர் இரட்டையர்கள்னு பேர். அவ்வளோ தூரத்துக்கு பாலிட்டிக்ஸ் இங்கே கோலோ சின்ன ஆட்கள். அவருடைய பையன் அவர். அதனால் அந்த பேக்ரவுண்டு அவருக்கு இன்னும் இருக்குது. வைகோவுக்கு திக்கு ஃப்ரெண்டு அவர். வைகோவுக்கு ஆஸ்தான வைத்தியரே வருதான் இங்கே மகாராஜ். ஸ்டாலினுக்கே ஃப்ரெண்டு எடுத்துட்டார். அதனால் அவரை நல்லா யூஸ் பண்ணிக்கங்க. அவர் ரிட்டையர் ஆகிட்டதை பற்றி நினைக்கவே வேண்டாம். அருள் சார் தானே ஆகிருக்காரு. அருள் சார் இப்போ தான் 31 எம்எம்சி ரிட்டையர் ஆகியிருக்காரு ஆஸ் டைரக்டர் ஆஃப் கார்டியாலஜி. அங்கே என் பேரன் தான் அங்கே மெடிசன் டிபார்ட்மெண்ட்டு பார்ட்டியெல்லாம் அரேஞ்ச் பண்ணியிருக்கா. அவர்கிட்ட சொல்லியிருக்காரு, அவர்கிட்ட கேட்டுக்கு நீ எங்கேருந்து வரேன்ருக்கா, திருநெல்வேலிருந்து வரேன்ருக்கா. திருநெல்வேலிருந்து யாருப்பாண்டுக்கு நீங்கள் என்ன சொல்லியிருக்காரு, என்னுடைய பேரன் இருக்காரு. அப்போ அவர் அவ்வளோ தூரத்துக்கு அவர் அப்ரிசியேட். காலையில் ஃபோன் பண்ணிட்டா சார், 1ஆம் தேதி காலையில் வந்து நியூ இயர் கிரீட்டிங் சொல்ல ஃபோன் பண்ணது தான் உங்களை பற்றி பேசிட்டு இருக்கான். தாத்தா அவர் பெரிய ஆளாக இருக்கார், உங்களை பற்றி இவ்வளோ பேசுகிறாரு. என்ன ஏப்பா, நான் அன்றைய காலத்தில் நல்ல வேலை செஞ்சுருக்கேன்னு அர்த்தம். அது நான் நல்ல வேலை செஞ்சுருக்கேன், அதை இப்போ வந்து அதை ஞாபகப்படுத்துறாரு. அவ்வளோதான், வேறு ஒன்றும் கிடையாது. நான் கவர்மெண்ட்டுக்கு நல்ல விசுவாசம் உழைச்சிருக்கேன்னு அர்த்தம். அவ்வளோதான், அதை பற்றி அவர் ஒன்றும் இல்லை. தேர் இஸ் நோ ஃபர்தர் கிரெடிட் ஃபார் மீ. அருள் வந்து பெரிய ஆள், அவர் ஜீனியஸு. அவர் +2லேருந்து ஜீனியஸ் எனக்கு தெரியும். +2 எக்ஸாம் எப்படி நடந்துச்சுன்னு எனக்கு தெரியும் அருளை பொறுத்தளவில். சரி, நான் சொல்லிட்டு இருந்தேன், உங்களுக்கு இங்கே ஒரு பார்ட்டி வச்சுருக்கணும், ரிட்டையர்மெண்ட் பார்ட்டி. அது தவறு இன்றைக்கி மெட்ராஸில் மட்டும் வச்சுருக்காங்க. அதான் சொல்லிட்டு இருந்தேன். இதோட கிளப் பண்ணியிருக்கலாம் அவரை. உண்மையாக சொல்கிறேன், அவர் நம்ம பையன் தானே. இங்கே படித்தார், இங்கே எம்பிபிஎஸ் படித்தார், இங்கே இது படித்தார், இங்கே எல்லாம் இருந்தால் இங்கே சர்வீஸ் பண்ணார். இங்கே கார்டியாலஜி ஒர்க்கே முக்கால்வாசி இங்கே தான் பண்ணார். ஒரு லிமிட்டட் பீரியட் he was in சென்னை பிகாஸ் ஆஃப் த போஸ்ட். அதனால் அவரை நம்ம வந்து ஷுட் ஹவ் ஆனர்ட் ஹிம். அவ்வளோ அந்த ஃபங்க்ஷனில் அவரையும் சேர்த்துக்கணும்னு எனக்கு ஒரு அபிப்பிராயம். தவறாக இருந்தால் மன்னிச்சுங்க, உண்மையை சொல்கிறேன். அவர் என் பெட் ஸ்டூடெண்ட்டு, நான் சொல்லி தான் ஆகணும். அவனுடைய சேவைகள், அவனுடைய உழைப்பு, அவளை இன்டெலிஜென்ட்டு எனக்கு தெரியும். அவர் ஐக்கியூவை பற்றி சாதாரண இடப்பட முடியாது. +2 ஏமா ஒரு முக்கியமான விஷயம், +2 அவர் பேப்பரை வாங்கி இன்னொரு கொடுத்து எழுதி சொன்னதெல்லாம் எனக்கு தெரியும். இப்போ பாருங்கள், +2 நீங்கள் உங்கள் பேப்பரை வாங்கி இன்னொரு பேப்பரை கொடுத்து எடுத்து சொல்லி அவர் வந்து அவரும் மெடிக்கல் காலேஜ் வந்துட்டான்னு எனக்கு தெரியாது. இதெல்லாம் நான் கதைத்தானே இருப்பேன். இவர் பேப்பர் வாங்கி கொடுத்துட்டாங்க இன்னொரு ஆள்கிட்ட. அவர் எழுதி அவர் மார்க் வாங்கி அவர் இதே மெடிக்கல் காலேஜில் நுழைஞ்சிட்டார். அது யாருன்னு எனக்கு தெரியாது. புரியுதா உங்களுக்கு? இந்த மாதிரி கதையெல்லாம் நிறைய உண்டு. இந்த மாதிரி கதையெல்லாம் நிறைய உண்டு. அவங்கள பற்றி சொல்லணும்னா நிறைய சொல்லிட்டே போகலாம். அதனால் அவருக்கும் சேர்த்து நம்மளுடைய பாராட்டு. நம்ம இந்த இதில் நான் அவரை பெருமைப்படுத்திக்கிறேன். என்ன, இந்த ரஃபிக்கு நல்ல மனுஷன், பெரிய ஆள், நல்ல மனுஷன் மட்டும் இல்லை, மனசு உள்ள ஆள், பெரிய ஆள். அவரை நீங்கள் பயன்படுத்திக்க, அவளான்னு சொல்லுவேன் நான். சரியா? அடுத்தாப்புல ரத்னகுமார் வரான்னு நினைக்கிறேன். அவர் என்னுடைய பெட் ஸ்டூடெண்ட்டு தான், என்கிட்ட தான் பிஜி பண்ணார். அவர் வந்து நல்லாவே தெரியும். அவர் டிபார்ட்மெண்ட் அவர் வந்து ஒரு பயங்கரமாக ஆர்கனைஸ் பண்ணுவார். இப்போ அந்த போஸ்ட்டு டாக்டர் மீனாகுமாரி எடுத்துதான் நினைக்கிறேன், ஆர்கனைசிங் கெப்பாசிட்டியை. அவர்கிட்ட இங்கே இவங்க வாங்கியிருக்காங்க. அவர் பயங்கர ஆர்கனைசர். இப்போ அந்த ஆர்கனைசிங் தான் அவர் ப்ரொஃபஸர் ஆகிட்டார். அதை நீங்கள் எடுத்துருக்கீங்க. அவ்வளோதான். நல்லா பண்ணுறேன், நல்லா பண்ணீங்க. அதனால் பண்ணுங்க, ஒவ்வொரு ஃபங்க்ஷன் நல்லா பண்ணுறீங்க. பாராட்டுக்குள்ள விஷயம். டிபார்ட்மெண்ட் ஆஃப் மெடிசன் நல்லா இருக்கிறத பற்றி எனக்கு அவர் என்னமோ ரஃபீக் வந்து மெடிசன் டிபார்ட்மெண்ட் தனியாக ஒரு இது பண்ணியிருக்காருன்னு நினைக்கிறேன். மெடிசன் டிபார்ட்மெண்ட்டு தனியாக ஒரு விங்கு கிரியேட் பண்ணி ஒரு இன்ஸ்டியூட் மாதிரி ஆக்காக இஸ் ட்ரையிங். ரஃபீக்கு அவர் ஒரு மினிஸ்டர் நேரிட்ட பேசிட்டார். பேசி இந்த இதில் வந்து இன்ஸ்டியூட் இருக்குல்ல சார், மதுரையில் இன்ஸ்டியூட் ஆஃப் மெடிசன் இருக்குல்ல, அந்த மாதிரி ஒரு கிரியேட் பண்ணுறது இஸ் ட்ரையிங் இஸ் லெவல் பெஸ்ட். அது எனக்கு தெரியும். ரஃபீக்கு அந்த வேலையை பண்ணிக்கிட்டு இருக்காரு. அதனால் அவருக்கு எல்லா ஹெல்ப்பும் பண்ணுங்கள். அவர் யூ வில் டூ இட்டு. அதனால் அவர் நல்லா இருக்கணும். நல்லா இருந்து அவர் நீங்கள் எல்லாம் நல்லா பயன்படுத்திக்கணும். அவர் நல்லா சர்வீஸ் பண்ணணும். பப்ளிக் சர்வீஸ் பண்ண காட்டும் உங்களுடைய கம்யூனிட்டிக்கு, டாக்டர்ஸ் கம்யூனிட்டிக்கு அவரை சர்வீஸ் பண்ண அவரை பயன்படுத்திங்க. அவ்வளோதான் எனக்கு தெரியும். நல்ல பையன், என்கிட்ட படித்த பையங்க தான், எல்லாருமே என்கிட்ட படித்த பையன் தான், இன்க்ளூடிங் ஆர்வம் பாண்டி. சரியா? நல்லா எல்லா பையங்களும் நல்லா தான் இருக்காங்க, யாரும் குறை சொல்ல முடியாது. அந்த காலத்தில் நம்மகிட்ட படித்த பையங்க எல்லாருமே எவரிபடி நல்லா இருக்காங்க. த்ரூஅவுட் வேர்ல்டு இருக்காங்க, உலகம் முழுவதும் இருக்காங்க. எல்லா பையனும் நல்ல பையங்களாக தான் இருக்காங்க. இப்போவும் அந்த பையங்க வரணுங்கிறத நமக்கு ஒரு ஆசையை வந்து. இப்போ இருக்க பிஜி ஸ்டூடெண்ட்ஸை பற்றி எனக்கு ஐடியா இல்லை. ஆமாம், பாம காலேஜ் நானும் சாரும் ஒன்றா தான் வேலை செஞ்சோம். அப்புறம் அவர் வந்து கொஞ்ச நாள் பாம காலேஜ் எம்டி போனார். அப்புறம் அது பிடிக்கலன்ட்டு ஓடியான்ட்டார். 3 மாதம் இருந்துட்டு ஓடியான்ட்டார். அப்புறம் டெர்மட்டாலஜி எம்டி போட்டார். யூஆர் செலக்டட் இனிஷியலி ஃபார் பாம காலேஜ் பிகாஸ் போத் ஆர் ஒர்க்கிங் இன் பாம காலேஜ் டிபார்ட்மெண்ட் மெடிக்கல் காலேஜ். அப்போ அவர் போய் செலக்ட் ஆகி போயிட்டு பாதியில் ஓடியான்ட்டார். சரி, என்ன போன மச்சான் திரும்ப தான் வந்துட்டு என்னன்னு கேட்டேன். அது அவ்வளோதான், அந்த டிபார்ட்மெண்ட் நமக்கு பிடிக்கலன்ட்டார். அதுக்கப்புறம் ஹி சோசன் தி டெர்மட்டாலஜி டிபார்ட்மெண்ட். அது
இவர் நானும் போகும்போது அப்ளிகேஷன் போட்டோம். இவர் மைக்ரோபயாலஜி போட போகிறோம்னாரு. நான் இப்போ ஃபார்மகாலஜி போடுறேன்னு போட்டாச்சு. செலெக்ஷனும் ஆயாச்சு. நம்ம கேரக்டர் எப்படின்னா போவேன், எம்டி கிடைக்கும் போக மாட்டேன். அது ஏன்னா கல்யாணம் வந்து ஹவுஸ் ஏஜை முடிச்சு அடுத்த வாரம் கல்யாணம். பொண்டாட்டியை பார்க்கவா படிக்க போவா, ஏன்னா அப்படியே எம்டி பாம காலேஜ் போவோம். அப்போ ஜாலியாக இருந்தது. பாம காலேஜ் போட்டு செலக்ட் ஆயாச்சு. அப்போ நானும் என் ஃப்ரெண்டும் செவந்திப்பட்டி ரோட்டில் நடந்து போயிட்டு முடி, இல்லை நீ மெடிசின் நல்லா படிப்பேடா, உனக்கு மெடிசின் தான்டா இன்ட்ரெஸ்ட்டு, ஏன்டா பாம காலேஜ் போய, அது ஜாலியாக இருக்குண்டா அப்படின்னு சொல்லிட்டு அவன் சொன்னான், டேய் மசுறு மண்டையில் இருக்கிற மசுறு தனி தான், தாடி மசுறு தனி தான், நீ நல்லா யோசி, பாம காலேஜ் கொஞ்ச நாளைக்கு நீ எடுத்ததே எடுத்துக்கிட்டு இருப்ப, போர் அடிச்சிரும்னா. எனக்கு பக்குனுச்சு. ஆமாம், ஏன்னா நம்ம மெடிசனாக படித்து பால் விட்டு ஊசே எந்த கனாலிச்சுன்னா நான் எம்பிபிஎஸ்லேயே படிப்பேன் கேட்டிலா. ஏன்னா நான் சர்ஜரி தேட்டருக்குள்ளே போக மாட்டேன். ஏன்னா நம்ம கைக்கும் சர்ஜரிக்கும் தெரியாமல் சேர்ந்துட்டோம் மெடிக்கல் காலேஜில் அப்படின்னு சொல்லிட்டு மெடிசின் தான், ஃபிசியாலஜி, பெத்தாலஜி, மைக்ரோபயாலஜி, மெடிசின் 4 தான் அப்போ வச்சு. அப்போ தான் நான் மாறினேன். செலக்டட்னு வந்து வேறு ஆளையும் போட்டாங்க. அப்படி தான் நான் கேஷுவாலிட்டிக்கு போனேன். ஏன்னா அப்துல் ரசாக்குன்னு எனக்கு 5 வருஷம் சீனியராக போஸ்டட் அஸ் ஃபார்மகாலஜி டியூட்டர், வைஸ் மகாகிருஷ்ணன் ஆல்ரெடி ரிலீவ்டு ஃபார் போஸ்ட் கிராஜுவேட்னு சொன்னாங்க. அப்போ நடராஜன் சார் இருந்தார், அவரெல்லாம் மறக்க முடியாது. சார் நம்மளை மாற்றி, ஆமாம் நான் மாற்றிட்டாங்களா சார், நான் கவலையே படாடா, நீ கேஷுவாலிட்டிக்கு போ, நான் பார்த்துக்கிறேன்னு. அப்படி தான் கேஷுவாலிட்டி கொடுத்தாங்க. அப்படி தான் அந்த கதை போச்சு. ஸோ ரஃபீக் சார் ஹெல்த் மினிஸ்டர் ஆயிடுவார். இப்போ அவர் இல்லை, நான் அவர்கிட்ட அதை சொல்ல மறந்துட்டேன். நீங்கள் இந்த காலேஜை விட்டுறாதுங்கய்யா. ஆமாம், இல்லை அவர் ஆயிடுவார். ஏன்னா பொன்மணி கிடையாது, இப்போ பொன்மணி இல்லாதனால இவர் தான் அடுத்து. ஸ்டாலினோட ரொம்ப நெருக்கம். ஆமாம், நான் வாங்கிடலாம். ஸோ அவர் வேறு என்ன, இந்த காலேஜுக்கு ஏதாவது இந்த விட்ட குறைகளை கொஞ்சம் உதவி செய்யணும்னு நான் அவர்கிட்ட கேட்கணும்னு நினச்சேன், மறந்துட்டேன். ஏன்னா வேலு சார் அதை கிளப்பி விட்டார். ஸோ வீல் யூட்டிலைஸ் ஹிம் பிகாஸ் ஹீ இஸ் எ மேன் ஹூ இஸ் சோஷியல் வெல்ஃபேரில் ரொம்ப அக்கறை உள்ள ஆள். ஏன்னா அதே மாதிரி உள்ளூர் மேலே முடிஞ்சு. ஸோ Rafiq will help the college. Though he retired, he keep this institution in his mind, because I hope he will become health minister of the state and he will remember this college. Thank you.
I welcome our beloved Dean Madam and our Medical Superintendent to Rejumed 2025.
ஹலோ, இந்த அக்கேஷனில் டாக்டர் கந்தசாமி பற்றி 2 வார்த்தை சொல்லணும். அவர் வந்து எனக்கு சான்ஸ் கிடைக்கல. இந்த வாட்ஸ்அப் கிட்டப்பெல்லாம் நமக்கு ரொம்ப ஓடாது, புரியுதா உங்களுக்கு? யூ பிகம் ஏ நேஷனல் ஃபேமஸ், அதையும் நம்ம இந்த இடத்துல சொல்லணும். நேஷனல் உங்கள் டிபார்ட்மெண்ட்டில் நீங்கள் ஒரு சாதனை பண்ணிட்டீங்கன்னு எல்லாருக்குமே தெரியுது, நம்ம அப்படி பார்க்கும்போது தெரியுது. அதனால் உங்களுமே நான் அப்ரிஷியேட் பண்ணுறது என்னுடைய கடமை. ஆஸ் யூ ஆர் மை ஸ்டூடெண்ட், I have to appreciate this is an occasion for me. Please accept the occasion.
Respected Dean, delegates and friends, a warm and heartfelt welcome to the inaugural function of Rejumed 2025 of Department of General Medicine, Tirunelneli Medical College, on the occasion of the superannuation of Professor and Head of Department of Medicine, Dr.Mohamed Rafi. It is truly a privilege to have all of you here as we embark on this momentous occasion. I'd like to invite First, I would like to call upon our chief guest, our beloved Dean Ma'am, Dr. Revathi Balan Ma'am, onto the stage. She is the epitome of grace, leadership, and is known for her zeal for initiative. Next, I would like to invite our beloved Head of Department of Medicine, Professor Dr. Mohamed Rafi sir, who has guided and led the department so far with kindness, diligence, and serenity. A teacher can inspire hope, ignite inspiration, and instill a love of learning. Allow us the honor of inviting onto the stage the guest of honor for today, Mr. Maria Ratnam Devadas, retired teacher who guided our beloved Rafi sir to where he is today. Now, I'd like to invite our medical superintendent, Professor Dr. Balasubramanian sir. Next, I would like to invite the better half of our beloved professor, Mrs. Mariam Bibi ma'am, onto the stage.
Next, I would like to invite Dr. Mahakrishnan sir, retired professor and HOD of dermatology, onto the stage. Next, I would like to request the presence of Dr. Velu sir, retired professor, Department of General Medicine, Tirunelneli Medical College, onto the stage. Next, I would like to invite Dr. Armugam S. Mohan sir, retired professor and HOD of Medicine, Tirunelneli Medical College. Last, I would like to invite Professor Dr. Rattumar sir, Chief of Medicine and Organizing Secretary for Rejumed 2025. He is a student favorite and is known for his down-to-earth demeanor. Onto the stage, please. Let us begin the program by paying our respects to our culture and traditions. I kindly request everyone to stand for the Tamil Thai Vart.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் மதனமென திகழ்வரத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Let us now proceed to the physician prayer, a moment of reflection and inspiration for all of us. I invite Dr. Ospas ma'am to lead us in the prayer.
Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray that you give skill to my hand, clear vision to my heart, and strength to my body. I pray that I will always realize that being a physician is a privilege and honor. With the simple faith of the child, I will rely on thee. Thank you.
Thank you, ma'am. Next, I would like to invite Professor Dr.Mohamed, Chief of General Medicine, to deliver the welcome address and set the tone for today's session.
அனைவருக்கும் என் இனிய காலை வணக்கம். இந்த நல்ல நாளிலே இந்த விழாவில் வாழ்த்துரை வழங்குவதற்காகவும் வரவேற்புரை வழங்குவதற்காகவும் என்னை அழைத்தமைக்கு மிக்க நன்றியை தெரிவித்துக் கொள்கிறேன். இந்த விழா CME என்று சொல்லப்படுகிற கண்டினியூஸ் மெடிக்கல் எஜுகேஷன் மட்டுமல்ல. இவ்விழா இன்றைய நாயகரும் மருத்துவத்துறை தலைமை பேராசிரியருமான டாக்டர் முகமது ரஃபி அவர்களுக்கு பணி நிறைவின் காரணமாக நடத்தப்படுகின்ற இரு பெரும் விழா. அவரை பற்றி சொல்வதற்கு முன்னால் இவ்விழாவினை நடத்துவதற்கு ஆரம்பத்திலிருந்து எங்களுக்கு ஆக்கமும் ஊக்கமும் கொடுத்து இந்த விழாவை நல்லபடியாக சிறப்பாக நடத்துவதற்கு உறுதுணையாக இருந்து இந்த விழாவிற்கு சிறப்பு விருந்தினராக வருகை தந்திருக்கும் எங்கள் முதல்வர், மக்களின் முதல்வர், மாணவர்களின் முதல்வர் டாக்டர் ரேவதி பாலன் அவர்களை வருக வருக என்று வரவேற்கிறேன். அவர்களுடைய அன்பும் ஆசையும் ஆதரவும் என்றென்றும் இத்துறைக்கு இருக்கும் என்று நம்புகிறோம். அடுத்ததாக இன்றைய சிறப்பு விருந்தினராக கலந்து கொள்ள வந்திருப்பவர், யூஸ்வலாக இந்த மாதிரி ஒரு ஃபங்க்ஷனுக்கு சிறப்பு விருந்தினராக யாரை கூப்பிடுவாங்க அப்படின்னா, ஒரு பொலிட்டீஷியனை கூப்பிடுவாங்க, ஒரு எம்பியை கூப்பிடுவாங்க. ஆனால் சாருடைய சிறந்த குணம், அவருக்கு கற்றுக் கொடுத்த ஆசிரியரான திரு மரிய ரத்னம் தேவதாஸ் அவர்களை இங்கே வரவழைத்திருக்கு. இந்த ஒரு நிகழ்வே போதும் அவருடைய ஆட்டிடியூடை சொல்வதற்கு. அவர் பேட்டையில் படித்த ஆசிரியர்களை பற்றி முகநூலில் அடிக்கடி நிறைய பதிவுகள் போடுவதுண்டு. தற்பொழுது சிறப்பு விருந்தினராக வந்திருக்கும் திரு மரிய ரத்னம் தேவதாஸ் அவர்களை பற்றியும் பதிவை நான் பார்த்திருக்கிறேன். ஒரு ஆசிரியரை நாம் மிக உயர்ந்த நிலைக்கு சென்ற பிறகும், அதுவும் நமது தொடக்க கல்வி ஆசிரியரை நினைவில் வைத்து என்றென்றும் போற்றுவது என்பது மிக உயர்ந்த பண்பு. இது மாணவருக்கும் பெருமை, கற்றுக் கொடுத்த ஆசிரியருக்கும் பெருமை. இப்படிப்பட்ட ஒரு அருமையான வாய்ப்பு எல்லோர் வாழ்விலும் அமையாது. நாம் ஓய்வு பெறுகின்ற தருணத்தில் நமக்கு கற்றுக் கொடுத்த ஆசிரியர் சிறப்பு விருந்தினராக கலந்து கொள்வது என்பது அரிதாகவே நடைபெறும் நிகழ்ச்சி. அதற்காக இறைவனுக்கு நன்றி செலுத்துகிறேன். அடுத்ததாக மருத்துவமனையின் மெடிக்கல் சூப்பரிண்டென்ட் டாக்டர் பாலசுப்ரமணியம் சார் அவர்கள், அவர் உயர் பதவியில் இருந்தாலும் என்றும் எங்களுடன் நண்பனாகவே பழகுவார். மருத்துவத்துறைக்கு மிகுந்த உறுதுணையாக இருப்பவர். அவரையும் வருக வருகவென்று வரவேற்கிறேன். எங்களுடைய ஆசான் குரு டாக்டர் மகாகிருஷ்ணன் சார், அவர் ஓய்வு பெற்ற பின்பும் இக்கல்லூரியுடன் தினம் தினம் தன்னை இணைத்துக் கொள்பவர். ஆசிரியர்களின் ஆசிரியர், அவர்களையும் வருக வருக என்று வரவேற்கிறேன். அடுத்ததாக என்னுடைய குரு இந்த அளவுக்கு உயர்ந்ததற்கு மூல காரணம் ரஃபிக் சார் அவர்களுடைய குருவும் கூட. அவர் இங்கு பணிபுரிந்த காலத்தில் அவரை வாக்கிங் ஹாரிசன் என்று சொல்வார்கள். பேராசிரியர் டாக்டர் வேலு சார் அவர்களையும் வருக வருக என்று வரவேற்கிறேன். சாருடைய துணைவியார் மரியம் பிவி அவர்களையும் வருக வருகவென்று வரவேற்கிறேன். அவர்கள் இருவரும் எப்பொழுதும் மேட் ஃபார் ஈச் அதர், எங்கு சென்றாலும் இணைந்தே செல்வதை பலமுறை கண்டிருக்கிறேன். சாருடைய மிகப்பெரிய ப்ளஸ் பாயிண்டே அவருடைய தொழில், குடும்பம், சோஷியல் லைஃப், சமூக வாழ்க்கை மூன்றையும் பேலன்ஸ் பண்ணி நல்லாவே போவார். சார் அடிக்கடி என்று சொல்வார், உங்களுக்கு சோஷியல் லைஃபே கிடையாது அப்படின்னு. அது எனக்கு ஞாபகம் இருக்குது. அவர் அந்த மூணையுமே நல்லா பேலன்ஸ் பண்ணி போவார். ஒரு வாரம் ஃப்ரெண்ட்ஸோட டூர் போனார்னா அடுத்த வாரம் ஃபேமிலியோட டூர் போவார். அந்த மாதிரி சாருக்கு உறுதுணையாக இருக்கும் அவர் துணைவியார் அவர்களையும் வருக வருக என்று வரவேற்கிறேன். மற்றும் இங்கு வருகை தந்திருக்கும் இக்கல்லூரியைச் சேர்ந்த பேராசிரியர்கள், சிறப்பு பேச்சாளர்கள், தூத்துக்குடி மருத்துவக் கல்லூரியின் பேராசிரியர் மற்றும் உதவி பேராசிரியர்கள் அனைவரையும் வருக வருக என்று வரவேற்கிறேன். மருத்துவத்துறை மற்றும் பிற துறைகளின் சார்பில் வந்திருக்கும் பேராசிரியர்கள் மற்றும் உதவி பேராசிரியர்களை வருக வருக என்று வரவேற்கிறேன். இக்கல்லூரியின் மருத்துவத்துறையினுடைய முதுகலை மாணவர்கள் இந்த விழா நடைபெறுவதற்கு மாபெரும் உறுதுணையாக இருந்திருக்கிறார்கள். அவர்களையும் வருக வருகவென்று வரவேற்கிறேன். எல்லாவற்றுக்கும் மேலாக 4-5 நாட்களாகவும் அதற்கு மேலாகவும் இந்த ஃபங்க்ஷனை எப்படி நடத்துறதுன்னு நிறைய பிளான்லாம் போட்டுகிட்டே இருந்தோம். பட் ஒன்றும் ஒர்க் அவுட் ஆகலாம் சொல்ல முடியாது, முழுமை பெறல. ஆனால் நேற்று மார்னிங் லீவ் முடிஞ்சு நம்முடைய அண்டர் கிராஜுவேட்ஸ் வந்த உடனே ஜெகன், ஹரிகரன், கார்த்திக் 3 பேரையும் கூப்பிட்டு சொல்லி ஒரு 5 minutesல they have planned and did this to the level. So that is our undergraduates and ever-loving students. I welcome you all on behalf of the Department of Medicine. Thank you.
Thank you, sir. Let us now honor our guests for today. I invite Professor Dr. Shavana ma'am, Chief of Medicine, to honor beloved Dean ma'am. Next, I request Professor Dr. Jafar sir, Chief of Medicine, to honor Head of Department of Medicine, Professor Dr. Rafi sir. To honor our guest of honor, I call upon Chief of Medicine Professor Dr. Periyasamy sir onto the stage. To honor Mrs. Mariam Bibi ma'am, I invite Dr. Meena Kumari ma'am, Senior Assistant Professor of Medicine, to the stage.
ரெண்டாவது பொசிஷன்ல ஜஸ்டின் பால் இருக்கான்.
I now invite Dr. Govindarajan sir, Assistant Professor of Medicine, to honor Professor Dr. Mohamed sir.
ஸ்பெஷாலிட்டி என்னன்னா
I now invite Dr. Govindarajan sir, Assistant Professor of Medicine, to honor Professor Dr. Mohamed sir, Assistant Professor of Medicine, to the stage. To honor Professor Dr. Velu sir, I invite Dr. Ahmed sir, Assistant Professor of Medicine, to the stage. I invite Dr. Sen Rajaperumal sir to honor our Medical Superintendent, Professor Dr. Balasubramanian sir. I request Professor Dr. Marchwin Kingston sir to honor Dr. A.S. Mohan sir. To honor Professor Dr. Kumar sir, I request Dr. Shiva Subramanian sir, Assistant Professor of General Medicine, onto the stage. Next, let us light the lamp, a symbol of knowledge and enlightenment, to mark the beginning of this auspicious occasion. I request our dignitaries on the dais to come forward for the lighting of the lamp ceremony. Now we will be distinguished speakers today. I would like to invite our beloved Dean, Dr. Revati ma'am, to speak a few words.
எல்லோருக்கும் என்னுடைய அன்பான மதிய வணக்கத்தை தெரிவித்துக் கொள்கிறேன். முதற்கண் நம்ம ரஃபிக் சாருக்கு மரியாதை செய்யும் விதமாக இந்த ஷார்ட்டாக போர்த்துகிறோம். முதற்கண் இந்த சிறப்பான விழாவிற்கு எங்களது அழைப்பை ஏற்று வந்திருக்கின்ற எனது குருவாக விளங்குகின்ற பெருமை மிகுந்த மகாகிருஷ்ணன் சார் அவர்களுக்கும் என்னுடைய குருவான வேலு சார் அவர்களுக்கும் இந்த சிறப்பான விழாவிற்கு என் மருத்துவ மாணவர்கள் பேராசிரியர்கள் பணிவன்பான வணக்கத்தை தெரிவித்துக் கொள்கிறேன். இரண்டாவதாக நம்ம இந்த விழாவிற்கு கதாநாயகனாக இருந்து சிறப்பாக செயல் திட்டங்களை வகுத்து கொடுத்தார்கள் என்ற என்னுடைய யூஜி மாணவர்களுக்கு இந்த நிறைந்த சபையில் பாராட்டின 2 வயது மூத்தவர். இந்த குடும்பத்தில் நான் அவரை அண்ணா என்று தான் அழைப்பேன். நான் 1995 எம்டி படிக்க வரப்ப அதுக்கப்புறம் 2 வருடம் கழித்து 1997 எம்டி சார் படிக்க வந்தாங்க. அதற்கு முன்னாலே நாங்கள் எல்லாம் இந்த மருத்துவக் கல்லூரியில் ஒன்றாக பயின்றவர்கள். நம்முடைய கார்டியாலஜி டாக்டர் ரவியட்வின் சார் அவங்க எல்லாருமே கிளாஸ்மேட்ஸ் தான். ஸோ அதெல்லாம் நினைக்கிறப்ப எங்களை விட்டு நம்ம எல்லாமே விட்டு வயது முதிர்வு காரணமாக விடைபெறுகிறார்கள் என்ற செய்தி நான் டீனாக இருக்கிறப்ப இது நடக்கக்கூடாதுன்னு நினச்சிட்டே இருக்கிறேன். இன்னும் கொஞ்ச நாளுக்கு சார் 62 வயசு வரைக்கும் இருக்குன்னு நான் நினச்சிட்டு இருக்கேன். மேலும் எங்களது அழைப்பை ஏற்று சித்திரை திருநாள் மருத்துவக் கல்லூரியிலிருந்து வந்திருக்கின்ற பேராசிரியர்கள், மேலும் எங்களது ஃப்ரெண்டாக இருக்கின்ற டாக்டர் நடராஜன் சார் மதுரை மருத்துவக் கல்லூரி மருத்துவமனையிலிருந்து வந்திருக்கின்றார், அருள் சார் பெருமைக்குரிய எம்எம்சியிலிருந்து வந்திருக்கின்ற அருள் சார், அனைவருக்கும் சிறப்பான பாராட்டுக்கள். நான் என்னவென்று கூறுவதற்கு கொஞ்சம் வருத்தமாக இருக்கிறது. சார் தலைமையில் இதுவரை ஒரு 60-100 பேருக்கு இதே மாதிரி ஒரு செலிப்ரேஷன்ஸ், கிரேட்டஸ்ட் செலிப்ரேஷன் பண்ணி செய்து வழி அனுப்பியிருக்கிறார்கள் மருத்துவர்களை. அது கடைசியாக சாருக்கு இந்த மாதிரி ஒரு வழியனுப்பு விழா வர்றது கொஞ்சம் குறையிற மாதிரி இருக்குது. ஆனாலும் எங்களுடைய டீம் ஸ்பிரிட்டில் 2 விஷயத்தை சொல்லணும். நான் பணியேற்றப்ப எமர்ஜென்சி மெடிசன் ஹெச்ஓடி இல்லாமல் இருந்தாங்க. அண்ணாவுக்கு ஒரே ஒரு ரெக்வஸ்ட் தான் கொடுத்தேன், நீங்கள் மெடிசின் டிபார்ட்மெண்ட்டை நல்லா பார்க்குற மாதிரி எப்பொழுதுமே என்னுடைய தாய் கன்சர்ன்ட் டெய்லி தாய்வாடுக்கு ரவுண்ட்ஸ் போயிட்டே தான் இருப்பேன், எனக்காக நீங்கள் அந்த வேலையை பார்க்கணுன்னு சரிப்பான்னு தாய்வாடு ஹெச்ஓடியாகவும் அவர் நான் கடந்த 2.5 வருடமாக பணியாற்றிருக்கிறார்கள். அந்த செய்தி உங்கள் எல்லாருக்கும் தெரியாமல் இருக்கலாம். ஆனால் மெடிசின் ஹெச்ஓடி அது அலாங் வித் அவர் தாய் ஹெச்ஓடியாகவும் இருந்திருக்காரு. ஃபஸ்ட்டு தாய்வாடு பற்றி சொல்லப்போனால் இந்த தாய்வாடுடைய சிறப்பான செயல்பாட்டினால தான் நம்ம உறுப்பு மாற்று தட் இஸ் டிரான்ஸ்பிளான்ட் ஆர்கன் ரிட்ரைவலில் தமிழ்நாட்டிலே நாங்கள் 3வது இடத்தை பெற்றிருக்கிறோம். அமைச்சரின் திருக்கரங்களால் தமிழ்நாட்டிலே 3வது இடத்தை பெற்றிருக்கின்றோம். அதற்கு நமது அண்ணா அவர்களுடன் பணியாற்றி கொண்டிருக்கிற எங்கள் நெஃப்ராலஜி டீம், யூராலஜி டீம், என்னுடைய செவிலியர்கள், அனைத்து துறை பேராசிரியர்களும் இந்த சிறப்பான நிகழ்வை செய்து நமது திருநெல்வேலி அரசு மருத்துவக் கல்லூரி மருத்துவமனைக்கு பெரிய பெருமையை சேர்த்தார்கள். அந்த நிகழ்வை சொல்லப்போனால் இந்த ஒரு 1 வீக் முன்னால் தான் அந்த ஈவினிங் நடந்துச்சு. எங்களை ஆர்டரில் உட்கார வைக்கிறப்ப கூட எம்எம்சி அதுக்கப்புறம் மதுரை மருத்துவக் கல்லூரி, அப்புறம் தஞ்சாவூரை உட்கார வச்சுட்டு நான் மட்டும்தான் லேடி டீன். அதில் நான் மட்டும்தான் கடைசியாக நானும் பாலா நம்ம சார் எல்லாம் உட்காந்துருந்தோம். மேடம் நீங்களாம் கடைசியில் போய் உட்காருங்க நாங்கள். ஆனாலும் அந்த லிஸ்ட்டை கையில் வச்சுக்கிட்டே இருந்தேன். கடைசியில் நான் சொன்னேன், நாங்கள் தான் நிறைய வச்சுருக்கோம் ஆர்கன் ரிட்ரைவல் இதெல்லாம் எக்கனாமியெல்லாம் ரன் பண்ணி கொடுத்துருக்கோணும். மறுபடியும் அதை எடுத்துகிட்டு போய் ரீகன்சிடர் பண்ணி அருள் தம்பராஜ் சார் மேடம் தான் 3வது பிளேஸு, தஞ்சாவூர் 4வது பிளேஸ்னார். தஞ்சாவூர் சார் அப்போயும் எங்களோட சண்டை போட்டார். அப்போ கூட நாங்கள் அமைதியாக தான் நின்றுட்டே இருந்தோம். ஆனால் அங்கே பேர் வாசிக்கிறப்ப நாங்கள் 3வதுன்னு வந்தோடனே எங்கள் டீமுக்கு, நம்ம காலேஜுக்கு எல்லாருக்குமே அந்த நிகழ்வு ஒரு ஸ்கூல் கேர்ள் மாதிரி தான் அந்த ஈவெண்ட்டு ஹாப்பியாக இருந்துச்சு. ஏன்னா எல்லா எல்டர்ஸையும் விட நம்ம ஒரு சின்ன ஒரு இதாக இருந்தால் கூட நம்மளுடைய அயராது உழைப்பு, ஒற்றுமை எல்லா காலேஜை விட பணியில் அவளை பெர்ஃபெக்டாக செய்கிறதுனால தான் நம்ம திருநெல்வேலி அரசு மருத்துவக் கல்லூரி மருத்துவமனை தலை நிமிர்ந்து நிற்கிறது தமிழ்நாட்டின்ற சிறப்பான செய்தி எல்லோருக்குமே இந்த நிமிடத்தில் நான் சொல்லிக்கொள்ள விரும்புகிறேன். மேலும் அண்ணனை நினைக்கிறப்ப எப்பொழுதுமே அந்த சங்கம் வந்துகிட்டே இருக்கும். அந்த முகமே சங்க முகமாக தான் இருக்கும். இனி சங்கமும் எப்படின்றது சிரிச்சிட்டே இருக்காரு 2வது பிளேஸில் இருக்கவர். ஸோ அதை நான் ரொம்ப சொல்ல முடியாது. அகாடமிக்கு பேசுகிறப்ப மார்த்தாண்டம் சாரை அது ஒரு பெரிய இழப்பு தான். அது கொஞ்சம் அன்எக்ஸ்பெக்டட். ஸோ 100% பாஸ்ன்றது இது தமிழ்நாட்டிலே இந்திய வரலாற்றிலே நம்ம திருநெல்வேலி மெடிக்கல் காலேஜ் மட்டும்தான் 100% மெடிசின் பாஸ் கொடுத்த பெரிய தலைவர்கள் இவர்கள் தான். அதுக்கு சாருக்கு சிறப்பான 200%. ஸோ எதுக்கு சொல்கிறேன்னா, என்கிட்ட கேட்பாங்க, எனக்கு நம்மளுக்கு தெரிஞ்சவங்க கேட்பாங்க, மெடிசின் நம்ம ஹஸ்பண்ட் டாக்டர் பாலுன்ட்டு கேட்குறப்ப மெடிசின் படிக்கிற எந்த நல்ல இடம்னு. எங்கள் ஹஸ்பண்ட் படிக்கிறப்பெல்லாம் 2 பிஜி சீட் தான். டாக்டர் பத்மநாபனும் இவங்களும் தான். எப்பொழுதுமே நியூராலஜி சாருக்கு தெரியும், மகாகிருஷ்ணன் சார், வேலு சார்லாம் அவங்களுக்கு குரு. அந்த ஒரு படிப்பு அது எல்லாமே 24 ஹவர்ஸும். எனக்கு சாருக்கு கல்யாணம் முடிஞ்சப்போ நம்ம நியூராலஜி கணேசன் சார் சொல்வார், உனக்கு கல்யாணம் ரேவதி கூட தான் நடந்திருக்கீங்க, நான் ஹாஸ்பிட்டலே சுற்றிட்டு இருக்கேன், போன்னு விரட்டி விடுவாங்க. அந்த அளவுக்கு நம்ம வேலு சார் இவங்கெல்லாம் வந்து படிப்பு பற்றி அவ்வளவு ஒரு பயங்கரமாக சொல்லி கொடுப்பாங்க. ஸோ அதெல்லாம் நான் கேள்விப்பட்டிருக்கேன். மேலும் வந்து யாரும் மெடிசின் சீட் எங்கே வாங்கலாம் கேட்டப்போ கூட நான் திருநெல்வேலியை தான் நாங்கள் சஜஸ்ட் பண்ணோம். ஏன்னா அவ்வளவு கிளினிக்கல் மெட்டீரியல், நிறைய பேஷண்ட்ஸு. இப்போ நம்மளுடைய க்ரோயிங் லெவலே ரொம்ப அப்கிரேடு. இன்னும் நம்மளுடைய 70 கோடி பிஎம்ஜேவிக்கு வந்துருச்சுன்னா திருநெல்வேலியிலே தமிழ்நாட்டு டவுன் சவுத்தில் இட் இஸ் ஐகானிக் லேண்ட். இட் இஸ் அன் ஐகானிக் லேண்டாக நம்மளுடைய திருநெல்வேலி அரசு மருத்துவக் கல்லூரி மருத்துவமனை விளங்க போகுது. அதற்கும் இன்னும் ஒரு 2 மாதத்தில் கிரிட்டிக்கல் கேர் பிளாக்கும் அண்ணன் சொல்லிகிட்டே இருக்கிற மாதிரி தாய்வாடும் கிரிட்டிக்கல் பிளாக்கும் நம்ம பிஎம்ஜேவிக்கு கிட்ட போகுது. அதுக்கும் நீங்கள்லாம் வந்து சிறப்பிக்கணும் என்ற ஒரு நல்ல ரெக்வஸ்ட்டை சொல்லிக்கொள்ள விரும்புகிறேன். 100% பாஸ்ன்றது வந்து இது எளிய விஷயம் கிடையாது. அந்த சாதனையும் நம்ம மருத்துவர்கள் செய்திருக்கிறார்கள். அந்த சிறப்பான நிகழ்வுக்கும் எல்லா ஒரு நிறைந்த சபையிலும் அனைத்து மருத்துவத்துறை பேராசிரியர்கள், இணை பேராசிரியர்கள், துணை பேராசிரியர்கள், சீனியர் பிஜிஸ் கற்றுக் கொடுத்த அனைத்து நல்ல உள்ளவங்களுக்கும் இந்த சிறப்பான தருணத்தில் என்னுடைய நன்றியையும் பாராட்டுகளையும் செலுத்துகிறேன். அதற்கு அடுத்தாற்போல் சாரை பற்றி சொல்லணுன்னா, ஒரு தமிழ் வேந்தன் மாதிரி, ஏப்பா கொஞ்சம் பேசாமல் இருக்கலாம்ல. இது வந்து நாங்கள்லாம் வந்து ஒரு உள்ளுணர்வோடு பேசுகிறோம். இந்த காலேஜிலே படிச்சிருக்கோம், இந்த ஒரு 300 ஏக்கருக்குள்ளே நாங்கள் வாழ்ந்திருக்கோம். இந்த காலேஜை விட்டு ஒருத்தவங்க போகிறது வந்து கொஞ்சம் வருத்தமான நிகழ்வு தான். இந்த மாதிரி ஒரு சபை வந்து கிடைக்கிறதே பெரிய வாய்ப்புன்னு நான் நினைக்கிறேன். அது இவ்வளோ நாள் வந்து 30 வருஷ காலமாக எங்களோடே இருந்திருக்காங்க. இந்த ஒரே மாவட்டத்துடைய தனது அனைத்து சேவையும் செய்த மிகப்பெரிய லக்கியஸ்ட் பர்சன் சார். ஸோ அப்படி வந்து தனது சேவை முழுக்குமே இந்த திருநெல்வேலி மாவட்டத்துக்கு அவர் செய்திருக்கிறார்கள். அது வந்து ரொம்ப யாருக்குமே இந்த வாய்ப்பு கிடைக்காது. அவருக்கு அந்த வாய்ப்பு கிடைச்சிருக்கு. அதையும் அவர் நல்லபடியாக பயன்படுத்தியிருக்கார்கள். எப்போ பேசினாலும் நான் வந்த டீனாகி வந்து இந்த 2.5 வருஷமும் ஒரு நிகழ்வில் கூட அவரை விட்டுட்டு நான் வரவே மாட்டேன். நான் அவருக்கு ஸ்பெஷல் சூப்பரன் போஸ்ட் போட்டு கொடுத்துருக்கேன். அவருடைய தகுதி திறமையை சேர்த்து நான் வந்து அவருக்கு சாருக்கு நீண்ட நாள் அவருடைய ரெக்வஸ்ட்டை நான் நிறைவேற்றி கொடுத்துருக்கேன். அது எனக்கு ரொம்ப பெருமை. ஸோ அது எந்த ஸ்டேஜ்னாலும் அவர் பேசுவார். தமிழில் ரொம்ப நல்லா பேசுவார். கொஞ்சம் நாளுக்கு முந்தி கூட தமிழ் மன்றம் வந்து மிகச்சிறப்பாக ஆர்கே சார் தலைமையில் நாங்கள்லாம் நடத்தினோம். கலெக்டர் சார் வந்து இப்படி ஒரு நிகழ்வை நான் பார்த்ததே இல்லையே எங்கள் கோயம்புத்தூர் மெடிக்கல் காலேஜில் கூட. அவ்வளோ அழகாக அவங்க யூஜி ஸ்டூடெண்ட்ஸு, பிஜி ஸ்டூடெண்ட்ஸு, மெடிக்கல் தட் இஸ் டாக்டர்ஸ் எல்லாம் இவ்வளோ ஒரு தமிழ் மேலே ஈடுபாடாக டான்ஸு அந்த இதெல்லாம் சார் தான் ஆர்கனைஸ் பண்ணார். ஸோ அந்த அளவுக்கு பட்டிமன்றம் எல்லாமே ரொம்ப சிறப்பாக செய்தார். நம்ம வந்து ஒரு தமிழ் பேச்சாளரை, டாக்டர் கம் தமிழ் பேச்சாளரை இந்த திருநெல்வேலி மருத்துவக் கல்லூரி மருத்துவமனை இனி ஒரு காலம் பார்ப்போமா நம்மளுடைய வரலாற்றுன்றது மிகப்பெரிய அச்சம், மிகப்பெரிய ஒரு டிமாண்ட். ஸோ இவ்வளவு சிறப்பு மிக்க ஒரு ஐகானிக் ஃபிகரான என்னுடைய மிக பாசத்துக்குரிய அண்ணனும் அண்ணியையும் நீண்ட நெடுங்காலம் வாழணும், எல்லோருக்கும் நல்லது செய்யலும் என்று கூறி மிகவும் அன்புடன் விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you. Now we would like to hear from our guest of honor. It is truly an honor to have you with us today. Ladies and gentlemen, please join me in welcoming our guest of honor to deliver his speech.
திருநெல்வேலி மருத்துவக் கல்லூரியினுடைய பொது மருத்துவத்துறை தலைவர் பேராசிரியர் டாக்டர் முகமது ரஃபி அவர்கள் பணி நிறைவு பெறுகிற இந்நாளில் பெருமை சேர்க்கும் விதமாக அவர்களை வாழ்த்தி மகிழ்கிற இந்த தருணத்தில் மேலும் சிறப்பு சேர்க்கிற வகையில் வருகை தந்திருக்கின்ற ஆசிரியர் பெருந்தகை ஆர் மரியரத்னம் தேவதாஸ் அவர்கள் பேட்டை காமராஜர் மேல்நிலைப் பள்ளியில் முதுகலை தாவரவியல் விலங்கியல் ஆசிரியராக 33 ஆண்டுகள் பணியாற்றி எண்ணற்ற மாணவர்களை மருத்துவர்களாய் பொறியாளர்களாய் சமூகத்தில் உயர்ந்த நிலைக்கு உருவாக்கிய சிறப்புக்குரியவர்கள். அவர்கள் தன்னுடைய மாண்புமிகு மாணவராகிய நம்முடைய பேராசிரியர் டாக்டர் முகமது ரஃபி அவர்களை கௌரவிப்பதற்காக வருகை தந்திருக்கிறார்கள். ஆசிரியர் பணியில் இருந்து பணி நிறைவு பெற்றாலும் தங்களுடைய பணி வாழ்வில் 33 ஆண்டுகளை கடந்து ஓய்வு காலத்தில் 30 ஆண்டுகளை நிறைவு செய்திருக்கிறார்கள். அத்தகைய உன்னத உயர்ந்த ஆசிரியரை வணக்கத்தோடு அண்ணாந்து பார்க்கிறோம். வானம் அண்ணாந்து பார்க்கிற உயரம் இவரின் உயரம். இவரின் உயரத்தை எங்கே இருந்து எப்படி அழப்பது, யார் கொண்டு அழப்பது? அதற்காகத்தான் நம் டாக்டர் அவர்கள் பள்ளி மாணவராய் தொடங்கிய நிலையில் இருந்து அவரின் பள்ளி ஆசிரியரை கொண்டு மதிப்பிடுவதுதான் சரியாக இருக்கும்.
என்னை அழைத்த திரு ரஃபி டாக்டர் ரஃபி அவர்களையும் நான் மனதோடு பாராட்டுகிறேன். ஓல்டன் டேஸ் ஆர் கோல்டன் டேஸ், ஓல்டு பாய்ஸ் ஆர் கோல்டு பாய்ஸ். நான் இதை ஏன் சொல்கிறேன் என்றால், சிறு வயதிலிருந்தே ரஃபி எனக்கு தெரியும். அவர் பேபி கிளாஸ் படிக்கும்போது என்னுடைய மகளும் சேர்ந்து படித்து கொண்டிருந்தார். அதோடு இந்த மைக்கேல் என்கின்ற ஆசிரியர் அவரும் கூடத்தான் வேலை பார்த்து கொண்டிருந்தார். அவருடைய குடும்பம் எனக்கு மிகவும் நெருக்கமான குடும்பமாக இருந்தது. அவருடைய தாயார் கிளார்க்காக வேலை பார்த்தார்கள். என்னுடைய மனைவி ஹையர் செகண்டரி ஸ்கூல் ஹெட்மிஸ்ட்ரஸாக இருக்கும்போது அவருக்கு அடியில் அந்த அம்மா கிளார்க்காக இருந்தார்கள். சரியான நேரத்திற்கு வருவார்கள், தன்னுடைய வேலையை சரியாக செய்வார்கள். அவ்வளோ தூரம் சிறப்பு மிகுந்த ஒரு பொறுப்புள்ள தாய் அந்த தாயாக இருந்தார். இவர் படிக்கிற காலத்திலேயே மிகவும் ரெகுலராக இருப்பார். அதாவது நான் அவருக்கு சயின்ஸு, இங்கிலீஷ், பயாலஜி 3 பாடங்களையும் கற்றுக் கொடுத்தேன். காலையில் 8:30 மணிக்கு நான் ஸ்கூலுக்கு வருவேன். வழக்கமாக பள்ளிக்கூடம் ஆரம்பிக்க வேண்டியது 10 மணி தான். ஆனால் நான் இருப்பது 8:30 மணிக்கு இருப்பேன். இவர் 8:25க்கே வந்து விடுவார். நான் சொல்லுகின்ற ஒவ்வொரு வார்த்தையும் கவனமாக கேட்பார். ஒவ்வொரு வார்த்தையும் கவனமாக கேட்டு தன்னுடைய பிரெயின் ஆகிய கம்ப்யூட்டரிலே பதிவு செய்வார். நான் என்ன போர்டில் எழுதுகிறேனோ அதை உன்னிப்பாக கவனிப்பார். அதையும் தன்னுடைய பிரெயின் கம்ப்யூட்டரிலே பதிவு செய்வார். எந்த கேள்வி கேட்டாலும் பதில் சொல்வார். எந்த கெட்ட வழக்கமும் அவர்கிட்ட கிடையாது. நல்ல பையங்களோடு தான் பழகுவார். அருமையான மாணவனாக இருந்தார். நான் அப்போதே சொல்வேன், ஒரு டாக்டருக்கு வேண்டிய குணம் என்னவென்றால் பேஷண்ட் சொல்வதை கவனிக்க வேண்டும், அடுத்தது பேஷண்ட்டை ஆப்சர்வேஷன் பண்ண வேண்டும். இந்த 2 குணங்களும் உங்களிடத்தில் இருக்கின்றது. ஆகவே நீங்கள் ஒரு சிறப்பான டாக்டராக வருவீர்கள் என்று அந்த காலத்திலே நான் அவருக்கு ஒரு மோட்டிவேஷன் கொடுத்தேன். அதன்படியே அவர் சிறப்பான ஒரு டாக்டராக வந்துவிட்டார். அவருடைய குடும்பமும் அவருக்கு மிகவும் உதவியாக இருந்தார்கள். அவருடைய தகப்பனார் ஒரு அரசியல்வாதி இருந்த போதிலும் அவருக்காக நன்றாக வேலை செய்து முன்னுக்கு கொண்டு வந்தார். அவருடைய தாயார் மிகவும் அவரோடு கோஆப்ரேஷன் பண்ணி நன்றாக மேலே கொண்டு வந்தார். அவருடைய சகோதரி ஆபிதா என்னுடைய மனைவியிடத்திலே தான் படித்தது. அதுவும் ஒரு டாக்டராக ஆகிவிட்டது. ஆக அந்த குடும்பத்தை கடவுள் நன்றாக ஆசீர்வதித்தார். இன்றும் அவர்கள் நீண்ட நாள் வாழ வேண்டும், நல்ல சிறப்பாக இருக்க வேண்டும் என்று ஆண்டவனை பிரார்த்தித்து எனக்கு வாய்ப்பு கொடுத்ததற்காக நான் நன்றி சொல்லிக் கொள்கிறேன். தேங்க்யூ, தேங்க்யூ, தேங்க்யூ.
Thank you, sir. Next, I invite Professor Dr. Rafi sir to share his thoughts on this special occasion.
திருநெல்வேலி மருத்துவக் கல்லூரியை முதலிடத்தில் கொண்டு வந்து சேர்ப்பேன் என்று கங்கணம் கட்டி கொண்டு செயல்பட்டுக் கொண்டிருக்கின்ற என் அருமை சகோதரி கல்லூரி முதல்வர் ரேவதி அவர்களே, என்னை சான்றோனாக்குவதில் பங்கிருந்ததோ அதே போல் என்னை களிமண்ணாக இருந்து என்னை சிற்பமாக உருவாக்கிய என்னுடைய அனைத்து ஆசிரியர் பெருமக்களுக்கும் பிரதிநிதியாக இன்று வந்து என்னை வாழ்த்திய என்னுடைய 10ஆம் வகுப்பு ஆசிரியர் மற்றும் என்னுடைய உயிரியல் ஆசிரியர் எம்ஆர்டி சார் அவர்களே, என்னுடைய மருத்துவ பேராசிரியர்கள் என்று மறைந்தாலும் இன்று எங்களுடைய இதயத்தோடு இருக்கின்ற என்னுடைய வேணுகோபால் அவருடைய ஆசையோடு இன்று உரையாற்றி என்னை மகிழ்வித்த பேராசிரியர் வேலு சார் அவர்களே, பேராசிரியர் மகாவிஷ்ணன் சார் அவர்களே, முன்னாள் துறைத் தலைவர் பேராசிரியர் மோகன் அவர்களே, வருகை இருக்கின்ற மதுரை மருத்துவக் கல்லூரியுடைய தலைமை பேராசிரியர் நடராஜன் சார் அவர்களே, வருகை தந்திருக்கின்ற பல்வேறு பேராசிரியர்களே, என்னுடைய கிளாஸ்மேட்ஸ் பேராசிரியர் அருள் அவர்களே, பேராசிரியர் எட்வின் சார் அவர்களே, மருத்துவக் கல்லூரியுடைய கண்காணிப்பாளர் பாலசுப்ரன் சார் அவர்களே, துணை கண்காணிப்பாளர்கள் சரவணன் அவர்களே, என்னுடைய நண்பர் கந்தசாமி அவர்களே, மற்றும் வருகை வந்து பேசி அமர்ந்திருக்கின்ற திருவனந்தபுரம் வந்து அருமையாக உரையாற்றியிருக்கின்ற நம்முடைய பேராசிரியர் அவர்களே, வருகை தந்திருக்கின்ற அனைத்து பேராசிரியர்களே, பல்வேறு துறை தலைவர்களே, எனக்கு அப்புறம் இந்த பொறுப்பை ஏற்று மேலும் செவ்வனை செய்ய காத்திருக்கின்ற பேராசிரியர் ரத்னகுமார் அவர்களே, அனைத்து துறை பேராசிரியர்களே, உதவி பேராசிரியர்களே, என்னுடைய கண்ணின் மணியாக விலகிக் கொண்டிருக்கின்ற மருத்துவ மாணவர்களே, மாணவ செல்வங்களே, உங்கள் அனைவருக்கும் என்னுடைய நன்றி கலந்த வணக்கத்தை தெரிவித்துக் கொள்கின்றேன். மிக அதிகமாக பேசக்கூடியவன், ஆனால் இந்த சந்தர்ப்பத்திலே திருமண மாப்பிள்ளை திருமண வீட்டிலே பந்தி பரிமாறினால் எவ்வாறு இருக்குமோ அதுபோல நான் பந்தி பரிமாறுவது சரியாக இருக்காது என்ற அந்த காரணத்தினால் ஒரு சில வார்த்தைகளை மட்டும் ரத்தரசரக்குமாக கூறி விடைபெறுகின்றேன். பெருமைக்கும் ஏனை சிறுமைக்கும் அவர்தம் கர்மமே கட்டளைக்கல் வள்ளுவர் கூறியது. நாம் பெரியவரா சிறியவரா என்பது நாம் என்ன செய்தோம் கர்மம், அதுவே கட்டளைக்கல். அந்த கட்டளைக்கல்லாக நான் உங்களைத்தான் கருதுகின்றேன். நீங்கள் நான் எதை தக்கவை, நான் எதை தகாதவை என்பதை எடை போட்டு அதன் மூலமாக நான் இங்கே உங்களுடைய வாழ்த்துக்களை பெற்றிருக்கின்றேன். ஆக நீங்கள் சரியான கட்டளைக்கல்லாக என்னை உணர்ந்திருக்கிறீர்கள் என்று உங்களுக்கெல்லாம் கோடான கோடி என்னுடைய நன்றிகளை தெரிவித்துக் கொள்கின்றேன். இந்த நேரத்தில் நம்முடைய முதல்வர்கள் கூறியதைப் போல பல்வேறு 60க்கும் மேற்பட்ட நிகழ்ச்சிகள் நடத்தினார். 100க்கும் மேற்பட்டவர்களுக்கு இந்த போன்று பணி நிறைவு விழாக்கள் ஏற்பாடு செய்து இன்றைய தினம் நானும் இந்த பணி நிறைவு பெறுகின்ற இந்த நேரத்தில் வந்து நிற்கின்றேன். எல்லாவற்றுக்கும் ஒரு நேரம் இருக்கிறது. இந்த நேரம் நான் விடைபெறுகின்ற நேரம். விடைபெற்றாலும் இந்த திருநெல்வேலி மருத்துவக் கல்லூரி என்னுடைய நெஞ்சில் என்றும் விலகாது. 35 ஆண்டுகள் அரசு பணியில் இருந்திருக்கின்றேன். அதில் 3 ஆண்டுகள் இங்கேயே பொது மருத்துவத்துறையில் பிஜியாக இருந்திருக்கின்றேன். 25 ஆண்டு காலம் இதே மருத்துவத்துறையில் பணியாற்றியிருக்கின்றேன். மிகச் சிலருக்கே கிடைக்கக்கூடிய இந்த வாய்ப்பு கிடைத்தமைக்காக எல்லாம் உள்ள இறைவனுக்கு நன்றி கூறுகின்றேன். என்னை மருத்துவராக்கிய என் தந்தைக்கும் என் தாய்க்கும், என்னை மருத்துவராக்கிய என்னுடைய ஆசிரியர்கள் அனைவருக்கும், என்னை மிகச்சிறந்த மருத்துவராக உருவாக்கிய அனைவருக்கும் இந்த நேரத்திலே நன்றி தெரிவித்து விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you, sir. I request our Dean to kindly present a memento to honor our guest of honor, Mr. Maria Ratnam Devadas, sir. Next, I request our Head of Department of General Medicine. Next, I request our Head of Department of General Medicine, Professor Dr. Rafi sir, to honor our Dean ma'am, Dr. Rejumed Balan ma'am, with a memento. Next, I would like to invite Mr. Michael, a schoolmate of Professor Dr. Rafi sir, with whom he laughed, cried and grew up together with, to honor Dr. Rafi sir. As we come to the close of this inaugural function, I invite Dr. Perisami sir to deliver the vote of thanks and express our gratitude to everyone who made this event possible.
Good afternoon, everyone. So it is an honor to deliver vote of thanks on behalf of organizing committee of Rejumed 25. And this CME holds some special significance as it is organized to celebrate our superannuation of our HOD, Dr. Rafi sir, and his remarkable contribution to medical education and patient care have been truly inspiring. And first and foremost, I extend my heartfelt gratitude to our chief guest, Dean Madam, Dr. Rejumed Balan Madam, for her presence and valuable contribution to this CME. And I also thank our guest of honor, Mr. Maria Ratnam Devadas, MA MET, for gracing this occasion with the words of encouragement. And I would also express my sincere gratitude to our Vice Principal, Dr. Suresh Dai sir, and Professor Kandasamy sir, Deputy Medical Superintendent, PMSSI, and Dr. Balasubramanian, MS, TVMCH, and Dr. Saravanan, Deputy Medical Superintendent, PMSSI, for gracing the event with their presence, and your support and encouragement greatly enriched this occasion. And a special thanks to all esteemed speaker and moderator, and Dr. Alagasan sir, Dr. Sivaprakash sir, Dr. Arun Gopalakrishnan sir, Dr. Ayyappan sir, and Dr. Natarajan for delivering engaging and insightful session that have added immense value to this CME. And a very big thanks to our organizing chairman, Dr. Rafi sir, and organizing secretary, Dr. Ratnakumar sir, along with the entire team for their hard work and dedication to make this CME successful one. And I thank all attenders in person and virtual. Thank you for your active participation and enthusiasm. And I thank our sponsor and partner for unwavering support which made the events is possible. Once again, I thank you all. Have a good evening.
Thank you, sir, for your kind words. Please stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता
जय हे जय हे जय हे जय 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 हे
With this, we conclude the inaugural function. Let us now proceed to the rest of the day's program. Thank you everyone for your attention, and I wish you all a productive and enriching day ahead.
ஃபைல் எதுங்க இருக்கா ஒரு எல்லோ கலர் ஃபைல் வச்சிருந்தேன்
Our next session is both timely and crucial, addressing a topic that poses significant challenges in critical care settings. Approach to tropical fevers in ICU. In tropical regions like ours, these fevers often present as a diagnostic and therapeutic dilemma, making this discussion highly relevant to our clinical practice. To enlighten us on this subject, we are privileged to have with us an eminent speaker, Dr. Ayyappan Sir, critical care physician, consultant and head of ICU at Apollo Specialty Hospitals, Madurai. Dr. Ayyappan Sir brings with him vast experience in managing critically ill patients, and his expertise in tropical fevers is unparalleled. This session will be chaired by a distinguished panel of experts. Dr. A.S. Mohan Sir, retired professor and HOD of medicine, Tirunelneli Medical College. Dr. Saravanan Sir, professor and HOD of neurology, Tirunelneli Medical College and Hospital. Dr. Krishnamurthy Sir, professor and HOD of thoracic medicine, Tirunelneli Medical College. I invite the speakers and chairpersons onto the dais.
So, good morning to everyone. So it is our pleasure to be a chairperson in this topic, especially during our HOD, medicine HOD, Professor Rafi retirement. So he is known to me from 1982 when he joined in our college. I was 3 years senior to him. And after that, we worked in the Department of Medicine as our PG, and then co-assistant professor, then co-professor. So like that, our relation is more than 40 years. So one thing, everybody talked about everything, so I want to tell one thing, important thing. He is a doctor-friendly doctor. So anything, any problem comes to any doctor, he will immediately come to the stage. He has been the president of the TNGDA, Tamil Nadu Government Doctor Association, for several years, and he is activist, like trade union activities. He will fight for doctors. That quality is very much important, apart from the academic and other things. So I wish him a happy and healthier and prosper retired life. So as our professors told, so after retirement, because doctors, especially government doctors, are doing double work. So they are working in the hospital, then after that, so they are practicing. So they are spending more than 12 hours, working 12 hours during this government service. So I request to take adequate rest and enjoy life. So social and family life, you have to, after retirement, so you have to follow this. So once again, thank the organizer for giving us the opportunity. Like this, regarding Dr. Ayyappan, he is not new to us. He is an alumni of our college. He is our student. Already he has given lecture last year during our API medicine updates. So he is one of the famous infectious disease specialist. So in Madurai, Apollo Hospital. So today he is going to talk about this fever, how to approach, especially in this season. So nowadays, after this swine flu, dengue, and this so corona, so fever is threatening everybody. So I request him to throw lights on this issue.
Good afternoon. It's really a privilege to be standing in front of these the stalwarts of the medicine, and I'm extremely thankful to the organizing team, especially Dr. Ratnakumar sir, for giving me this opportunity, and to be in front of my professors and my beloved teachers is really a wonderful experience and a privilege. Yeah. Without wasting much time and ado, we will go to the topic per se. But before that, two most important disclaimers which I want to make is, actually, I am an intensive care specialist and not an infectious disease specialist, so I have my limitations in this field. And the other thing is, it's what we are going to speak about is tropical fever. And the major thing is, the cases which I have come across are predominantly the tip of the iceberg. In other words, the tropical fever, majority of them have mild disease and 80% of the patients escape without coming to the intensive care unit. Only 20% of the patients require in-hospital or intensive care therapy. And among those, only 5% have the high risk of mortality. So whatever I am speaking will be from my perspective of more of a critically ill tropical fever patients rather than your day-to-day practice of what you see in your general practice tropical fever patients. So without much ado, we will go into the topic, which is the tropical fever. Why do you call it as tropical fever? Because it is unique to the tropics and the subtropics. How do you say that? Because you have this disease particularly in this geographic location between the Tropic of Cancer and Capricorn and as well as the subtropics. So why is it unique? Because we have a fond habit of following Western literature as well as Western guidelines for everything. Unfortunately, we don't have Western guidelines for this. So we should have our own guidelines. Unfortunately, we don't have. So based on our clinical experience, we treat these patients. So warmer climate as well as monsoon rains are the trigger for these patients. And as well as if you look at the epidemiology of it, which is very alarming. So as a whole, the tropical fever contributes to a large burden of the infection or the disease population in the community. And this is a point prevalence study done in 2017 by Tata Memorial, where they found that this was a single point prevalence study done across multiple ICUs across the country, where they found that every 1 in 20 admissions into the ICU is secondary to tropical fever. This clubbed together of all the tropical fevers, not a particular fever alone, and out of which 1 in 15 patients have high risk of mortality. So that is the magnitude of the disease we are discussing about. And when they did a subpopulation analysis of the group of diseases which contribute to this tropical fever, this was another study done in CMC Vellore in 2017. What they found was, we all are aware that the most common tropical fever which we come across is dengue. So we can say point blank that it is dengue. But the second most common, what we will think is either malaria, typhoid, but it was not that. It is the re-emergence of the great mimic, which is the scrub typhus, which is being brought into limelight recently with the media coverage of the increasing incidence of scrub typhus in the community. Yeah. So why is this tropical fever important is, majority of them are vector-borne diseases. So it in a nutshell reflects the healthcare system in the community. Not only about the medical facilities or the medical care, about the entire healthcare system in the country. Yeah. So without boring much about this, I will discuss a case which we encountered nearly a year ago. This is a 29-year-old male who is a chronic alcoholic who was referred to us from another hospital. Actually, he was referred to our neurologist. He is a chronic alcoholic with a history of fever and loose stools, who presented to us with the dysarthria and quadriparesis, more of lower limb rather than the upper limb, and following an episode of diarrhea. So he was referred as a case of possible AADP or a Guillain-Barré syndrome to our neurologist. So his investigations, if you look at, revealed mild transaminitis with thrombocytopenia as well as multi-organ, moderately deranged multi-organ involvement. Yeah. So since the history was similar to GBS, we did neuroimaging as well as a CSF analysis as well as electromyography, which were all inconclusive. We could not find out what was the cause. And the subsequent days, he started to deteriorate with high-grade fever spikes, and he started having worsening bicytopenia. So at this point, our major differential was probably AADP, triggered by a tropical fever, could be a Shigella or something of that sort. Other major differential, because he had a uremia also, was TTP, for which we looked at schistocytes, which was also negative. But then when we looked at the overall picture, clinical profile, as well as fever and the labs, what we found was he was in a sort of a hyperinflammatory state. If you look at, his ferritin was elevated, his LDH was elevated, his triglycerides were elevated, and he showed hepatosplenomegaly. And when we looked at the criteria, he fit into something previously called as macrophage activation syndrome, or currently the secondary hemophagocytic lymphohistiocytosis. So what did we do? So we did a bone marrow biopsy, and to our surprise, we got this. There was hemophagocytes seen in the bone marrow. So we know that it was a hyperinflammatory state secondary to some infective foci, which we were not able to find. So we sent all the tropical fever workup, and in which we found that initially Vidal we didn't send, we sent only typhoid IgM, and we got it as positive. So probably based on the history and as well as outside food intake, it was a typhoid fever which has resulted in a hyperinflammatory state resulting in secondary HLH. You won't believe, he was having high-grade fevers of 102 to 103 with a procal of 30, and he was worsening with minimal NORAD support. We started him on dexamethasone and etoposide based on this diagnosis with simple antibiotics of azithromycin and ceftriaxone to cover the typhoid. So if you look at the data, there has been lot of studies coming across reporting this incidence of high incidence of secondary HLH. Most of them are reported secondary to dengue, but what we have come across in the past 1 year is nearly 8 to 10 cases of typhoid related HLH. So this is pretty common, and unless you diagnose it, it is very difficult to treat it. And a irrational escalation of antibiotic without diagnosing the primary etiology will not solve our questions. So with this background, we'll have a word about the typhoid. Typhoid, as we all know, it's caused by Salmonella typhi and paratyphi, which is, and other non-typhoidal Salmonella, which we will not be discussing about. Okay. So we know the typical features, and it is during the second week illness, we come across these complications. During the first week, it will be fever, chills with bradycardia, which is common to majority of these tropical fever syndromes. Okay, it is during this second or the third week where we can have the immune phase of the disease, where we can have this sort of macrophage activation syndrome. So how to diagnose this? There is a common thing to do Widal test for all these patients. It is neither sensitive nor specific, and unless you have a rising titers after say 1 or 2 weeks of the initial test, it doesn't give you any value. So what are all the tests? The gold standard is going to be either your bone marrow or your blood culture in the first week, and probably in the second week what you have to look at is more often serology. So you have 2 serological tests which are available for typhoid, which is the Typhoid, as well as the other one is the Tubex. So the Typhoid gives you both IgG and IgM. So if you have a IgM positivity with Typhoid with the clinical profile which fits into it, it is very well sensitive and specific to give you a diagnosis of typhoid. And probably with this background, you may not require anything other than ceftriaxone or azithromycin. Previously, when we were taught, the drug of choice used to be fluoroquinolones, especially in South Asia, Southeast Asia, because of the incessant use of fluoroquinolones. The resistance to fluoroquinolones amounts to more than 80%, especially in Indian subcontinent. So the drug of choice currently is ceftriaxone, but fortunately, in spite of the overzealous use of azithromycin or macrolides, azithromycin still holds good for our typhoid. So what we do is, in stable patients, we start with third generation cephalosporins, always accompany it with a blood culture to look for MDR and XDR typhoid. So when do you call it as MDR typhoid? If you have a Salmonella typhi, so always send your blood cultures along with your serology, because your serology will give you antibody diagnosis, but if you have a culture positivity, you can always know the sensitivity and specificity. So if you have a culture showing Salmonella in the first week, with resistance to fluoroquinolones, it becomes MDR typhoid, for which the drug of choice is going to be your third generation cephalosporins. If it is resistant to your third generation cephalosporins also, it is going to be XDR typhoid, and the treatment for which is going to be your carbapenems. Even in MDR and XDR typhoids, your azithromycin holds good. So why is it important is, we in our center itself for the past 1 year, we had 3 cases of XDR typhoid where we had seen third generation cephalosporin resistance. So the other thing which you have to make note here is, patients who are critically ill probably will require prolonged course of therapy with ceftriaxone at least for 10 days. And the dose of azithromycin also is slightly on the higher side. You give 1 gram bolus followed by 500 mg for not for 5 days, it's for 7 days. Other drugs which are routinely recommended are not commonly used. Chloramphenicol and telithromycin has been recommended, but it is not very commonly used. Okay, so this is about typhoid. And you have patients who have typhoid who work in mass markets like your food and beverage. Then you have to look for chronic carrier state, especially in females and with biliary anatomical abnormalities. You should send them a stool culture after your completion of treatment or at the end of 1 month to rule out chronic carrier state. If your stool culture comes as positive for typhoid, then you should give 4 weeks of radical cure with levofloxacin or ciprofloxacin based on your sensitivity. So this is how you diagnose a typhoid, look at your complications and treat it appropriately. So based on this picture, we can have a nutshell, or we can know about the demography of a tropical fever patients. Why I am insisting on it is, these are fairly young patients with a male predominance who work outdoor. And the most alarming thing which we come across in critical care is, when you have a patient who have a sepsis secondary to a particular organ, who present in sepsis and multi-organ failure, when we treat such a patient, when we compare it with a patient who comes with multi-organ failure secondary to a tropical fever, the outcomes are very different. In other words, the patient who comes in multi-organ failure with a tropical fever have a better outcome compared to your differentiated or a localized sepsis. Yeah? So that is why it's very important to diagnose these patients. And the most common, apart from the demography, the most common symptom which you come across is your fever with no localizing sign. You will not be able to localize it into pneumonitis or pyelonephritis or cholecystitis. It will be a pan involvement of most of the systems with a saddleback or alternate fever with some amount of multi-organ involvement. There will be mild transaminitis of AST more than ALT. There will be marginal increase in creatinine, and there will be mild hyperbilirubinemia involving multiple systems. And not to mention, there will be retroorbital pain, which is very specific for your dengue. And if you look at signs, you can look at, depending on the tropical fever, you can have various signs like conjunctival suffusion, black eschar, myalgia, or rashes based on what tropical fever you are coming across. Okay. And labs wise, I have already mentioned, I will not go into the details of it. Okay. But something which is specific for all of them, and most prominently dengue, is this acalculous cholecystitis or GB wall edema, which underlines the fact that there is a diffuse inflammatory process going on. Okay. So we will discuss about only the 4 major topics, which is dengue, malaria, and we have already discussed about the enteric fever. Other than that, lepto and scrub. So I will not waste much time on it. You have 4 dengue viridae, and it is spread by, as we all know, Aedes aegypti and Aedes albopicus. Okay. So previously, what we used to follow is based on this 1997 WHO classification, which has been reclassified currently in 2009 to avoid confusion. So there is no terminology as of now as dengue hemorrhagic fever. So to avoid confusion, what they have simplified it is dengue, dengue with warning sign, and severe dengue. In severe dengue, you have 3 subclasses, which can be dengue with severe plasma leakage resulting in shock, dengue with severe bleeding, and dengue with severe multi-organ involvement in the form of AKA or transaminitis. So when do you call it as dengue without warning sign? You have a patient who has a typical symptom but serology positive, you diagnose them as probable dengue. You have either serology or NS1 positive, you label them as dengue. If they don't have any warning sign, they are just dengue. If they have warning sign in the form of either decreased platelet count, increasing hematocrit, or headache, or persistent vomiting or mucosal bleed, you classify them as dengue with warning sign. Why do you classify them? So based on this, you can support the treatment. These are class A patients who can be treated on OPD basis. These are class B who requires in-hospital treatment, and these are patients probably who will require ICU stay. So I will not waste much time in it. Thus, when you look at it, again, your dengue will have a saddleback fever. In other words, it is biphasic illness. In the first 3 to 5 days, you will have acute febrile illness. There will be a period of defervescence followed by a immune phase wherein you will have the acute worsening. This is in line with the immunological response to the viremia. So that is when it happens. But what we don't understand is it's not the primary dengue which is more harmful, it's the secondary dengue which is very harmful. So what we come across is something called as, if you have there are 4 dengue viridae, and when you have an infection with a single serovar, it gives you nearly lifelong immunity. That is neutralizing antibiotics. But this neutralizing antibiotics will be heterotypic or non-neutralizing for the other dengue serovars. So what it does is, it does something called as antibody dependent enhancement. So what it does is, this antibody goes and binds to the virus, but it does not neutralize it because of it non-neutralizing. It does have the capacity to neutralize. So what it happens is, it binds to it, it gets engulfed by your macrophages as well as your monocytes, and it goes unprecedentedly multiplies inside these phagocytes. And this rapid viremia results in the cytokine release, resulting in the immune phase, which happens in the 2nd week of illness. So how do you diagnose this? So basically, your diagnosis rests on 2 things. One is the structural protein NS1 protein, which has not been approved by the government of India to make a diagnosis. It's the serological diagnosis which has to be there to label them as dengue. It can be either IgG or IgM. What we commonly come across is your NS1 and IgM will be packaged as a serological test, and if either one of it is positive, in the first week your NS1 will be positive and you label them as dengue. In the 7th day or 6th day of illness, your IgM becomes positive and you label them as dengue. But there is a fine line, if you see here, where your NS1 will also be the least and your IgM titers are slightly rising, where you may miss a dengue. It is in this condition where your IgG takes over. So IgG most commonly is neglected, but if you have a secondary dengue, your IgG titers may be of very good help. in making a diagnosis. If you have a very high titers of say more than 1:640 with a rising titer after a week or two after the initial titer, it is also suggestive of dengue. So that is what is very important. You look at IgM in the early phase. If you look at IgG, you repeat a IgG to look for rise in the titer. So management, I will not go into the details of it. If you look at the WHO, it has itself given you guidelines for 10 ml per kg, 7 ml per kg, but it is time that we move away from this protocol-based management and we practice towards precision medicine. Every patient is not the same. A patient A may require 10 ml per kg of fluid, but the patient B may not require. It may be underfilling for that patient or overfilling for that patient. So use your, what we tell in intensive care is use your dynamic indices of preload. You use either IVC as a marker, serial IVC monitoring, or you use your stroke volume variation. Your fluid is given to increase your cardiac output, not to fill the system. So your fluid should be given to increase the cardiac output. There may be a phase wherein you may have to fill the tank further, but your filling up of the tank will not result in stroke volume or increase in cardiac output. So never follow protocol-based medicine. Try to practice precision-based medicine, and each patient is different, and try to identify how much of fluid is ideal for a particular patient and give that amount of fluid. And there is one more flaw in the WHO guideline which they have given is the usage of dextran or statar starch as a replacement fluid when you have a dengue shock syndrome, which is strongly against recommendation what we practice in critical care, because after the advent of something called as glycocalysis, the role of colloids has come down. Even if you use colloids, that can also leak across the capillaries. It remains in the interstitial space for a longer time, worsening the interstitial edema, and try as far as possible avoid using colloids. If at all you have a overload with crystallite, try to use not semisynthetic colloids but natural colloids like albumin. Okay. So the cause of mortality in dengue most of the time is secondary to capillary leak in adults and not because of your thrombocytopenia and bleed, which is more common in pediatric population probably. So the resuscitation mainly is going to be fluid and addressing the supportive elements. You give them life support in the form of CRRT or a sled in case of renal failure. You give them lung protective ventilation if they have a capillary leak and pulmonary edema, and support them for 48 hours, and recovery is the rule in dengue. If you support them for 3 to 4 days, they will come into the recovery phase and they will recover. And on that note, I will just discuss about a patient. This is a 45-year-old patient with hypertension who presented to us again with altered sensorium. He was referred from another center. At that time, his GCS was 11/15. And during the course of the say, after 12 hours in the ICU, he threw a GTCS and he became unresponsive, got intubated. His GCS became 3/15. So he has thrombocytopenic, coagulopathic, uremic with multi-organ involvement with the GCS of 2T/15 and was on ventilator. Only reassuring thing which we had while we were treating him was briskly reacting pupils and spontaneous respiratory effort. If both were absent, probably we might have to label him as brain death. So in a corporate setup, it is very difficult to continue treating such a patient for the inordinate cost which they pay for the ICU. We were under tremendous pressure why we were treating the patient. So with all the due risk, we did a MRI for this patient. MRI was normal. He continued to have thrombocytopenia, so we could not do a CSF analysis, but we did all other tropical fever workup which came out to be negative. Then when we were looking at the history and speaking to the attenders, his daughter was also ailing with a similar complaints and she was dengue positive. So then our perspective towards him changed, and probably what we were dealing with was probably a dengue encephalitis, and we did nothing but support him with ventilation with all other supportive therapy to improve his AKA as well as nutrition status as well as to prevent the secondary bacterial infection with just ceftriaxone and doxycycline, because we wanted to cover probably meningitis also. And to our surprise, after 72 hours of invasive ventilation, he started obeying commands. And by 7th day, he was out of ventilator. And when we did a IgG for him, IgG titers were very high, and we repeated IgG titer after 5 days, which was more than 4-fold rise. So which brings us to the diagnosis. Probably it was a expanded dengue, which is a coin which is currently termed in the 2012 update WHO on dengue, which is expanded dengue, where they don't have the typical features of capillary leak or other organ dysfunction. They may have single organ involvement also. Yeah. So coming to the next common tropical fever, leptospirosis. Yeah, leptospirosis is quite common, and with the monsoon being quite heavy, we had quite a bit of cases of leptospiro. It's a spirochete which has a multiple serovars. The most common one which we come across are Leptospira intragans and Leptospiro vili. Again, this also has a biphasic response. The first week will be a febrile illness. In only the second week, you will have a saddleback fever followed by your immune phase where you develop your icteric leptospirosis. If you have to have one thing, they have most of the tropical fever have similar symptoms, but each will have a catch point which you can find out. If you have a dengue, you will have a retroorbital headache and neck pain or a headache. If you look at Leptospira, what will be there is, in signs you will have subconjunctival effusion, and when you have your labs, you will find that this AKA is most often non-oliguric AKA and most often associated with hyponatremia and hypokalemia. What it causes is this leptospiro or this spirochete has a unique capability of causing activation of sodium potassium ATPase in the renal tubule, thereby having a diuretic effect on the kidneys, thereby causing non-oliguric AKA as well as caluresis, resulting in a AKA with hypokalemia. Most commonly what we come across is hyperkalemia with AKA, but what we see here is hypokalemia with AKA. Other than that, the symptoms will be same. It can cause diffuse capillary leak in the form of ARDS, it can cause pedal edema, it can cause effusion, it can cause polyserositis. But again, coming to the diagnosis is going to be based on your serology. It's very difficult to culture your leptospira, so your diagnosis is going to be based on two things. One is microscopic agglutination test, which is the diagnostic test of choice, but very little centers practice it. So the modality which you are going to use is going to be your ELISA IgM. So it has a fairly good sensitivity and specificity, and with the given clinical profile, if you have ELISA positive or a serology positive, we can very well go ahead and confirm the diagnosis of leptospira and treat them accordingly. And there has been a multiplex PCR technique which is in the foray, which probably will come in the next year, where we have the PCRs of all the common tropical fever which we are coming across, and this will give us a point of care test probably in 60 to 90 minutes, probably in the next year. So the PCR, if you are doing, it has to be in the blood in the first 6 days and probably in the urine in the from the second week. Because the mode of spread is also, your spirochetes will be eliminated in the urine from the second week of illness, and when it gets contacted through the broken skin, it results in invasive illness. So how do you treat leptospira? Leptospira, again, if you come across, all the diseases will have majority of the time most common treatment, which is going to be again your doxycycline, azithromycin, and third generation cephalosporins. I won't go into the details of it. So if you have a OPD based treatment, you can either treat them with the doxycycline or oral azithromycin. If you have a critically ill patient, probably you have to go for third generation cephalosporins. So malaria, again, if you look at malaria, I will not be going into the life cycle. You have 4 species of malaria, and the most dreaded of which is falciparum, but of late we have been seeing lot of severe cases of even vivax malaria, and the severity is even further if you have a combined infection of falciparum with vivax also. This slide I had put to showcase the good healthcare or the good environmental practice which we are practicing for the past 2 decades actually. So if you look at it, the percentage reduction in malaria from 2016 to 2019 each year was nearly 17 to 21%, which is the highest in any of the endemic malaria countries. This includes your South America as well as your Southeast Asian countries. When you look at it, this was a data published in 2020, where you see from year on year 2016 to 2019 there was nearly 17 to 21% decrease in the incidence of malaria. So that's a good thing which is happening at the community level. So how does it cause the illness? We all know how does it cause it. The falciparum malaria, or what it does is it causes cytoadherence, rosette formation, sequestration, thereby causing infarct as well as cytokine release. So when do you call a patient as having severe malaria? When he has severe symptoms in the form of lactic acidosis or multi-organ involvement or a specific worsening of the particular organ involvement, particular organ. Or you have a parasite load of more than 10% in a endemic country and as well as more than 5% in a non-immune traveler. So how do you treat these patients? Okay. So the previously what we used to do is we treat them is quinine based therapy, which has gone out of favor, and what we treat now is with artemisinin based therapy. And artesunate, intra or parenteral artesunate, has revolutionized the treatment of malaria because it acts at every level of the life cycle of malaria except at gametocytes. Okay. So the other thing which you have to, when you have a patient who has suspicious malaria with seizure, you have to actively rule out cerebral malaria. The difference in cerebral malaria compared to other meningoencephalitis is that you will have predominantly neuroglycopenia without much of cells. And till the late stages of the disease, you won't have raised ICP also. Because the pathogenesis of cerebral malaria is also going to be microvascular obstruction and perfusion defect. When they did a autopsy study of patients with cerebral malaria, what they found was the cerebral venules and capillaries were sequestered or obstructed with these infected erythrocytes. That was the reason for the encephalopathy in these patients. So, and they have a typical form of retinopathy which can be picked up in your fundus examination. So again, diagnosis of malaria, if you have a good lab which can run 24 hours, which can look at thick smears and thin smears in a background patient who has a risk of malaria, nothing can replace it. But unfortunately, when a sick patient comes in the middle of the night, we don't have the lab support. So what we have to go to is your rapid diagnostic test. What do we do in the rapid diagnostic test? We look at histidine-rich protein and pan-specific aldolase or LDH. Your histidine-rich protein is specific for falciparum. So if it is there, you can diagnose it as falciparum. And if you don't have histidine-rich protein but LDH and pan aldolase, probably you are dealing with vivax or other malaria. So your RDT cannot diagnose your species. What it can diagnose is whether it is a falciparum malaria or a non-falciparum malaria. You have to look at your thick smear for identification and thin smear for species identification. So if you have a good microbiologist, that is the way to go. Otherwise, your RDT is going to be your saver in critically ill patient. And 2 negative RDT gives less than 5% of false negative predictive value, which is very, very important. You have high suspicion. If you do 2 RDTs which are negative, unlikely you are dealing with malaria. Okay, fine. So malaria PCR is predominantly for the research purposes. It has not been widely marketed. So treatment, again, it has been replaced by artemisinin based therapies. What you are going to do is, if you have a stable patient, you can go for artemisinin combination therapy. The most common one which I have used personally is only one, artemether plus lumefantrine. In adult, what we use is 480 mg plus 80 mg, BD 0.8 and then BD for 3 days. That is what we use. The other combinations, personally, I have not used it. In a critically ill patient, what we use is artesunate at the dose of 2.4 mg per kg at 0, 12, 24, followed by OD till the patient gets stabilized. Once the patient gets stabilized, switch over to artemisinin combination therapy for 3 days. If the patient is still critically ill and your parasite load is more than 5%, continue IV artesunate for 7 days OD till your parasite load decreases. And never forget if you have a non-falciparum malaria, check G6PD, because majority of the centers doesn't have it. Just check G6PD at the onset itself so that you can give radical cure with primaquine, especially for vivax and ovate. So this is the artemisinin combination therapy which we practice. So currently, previously what we used to practice was exchange transfusion. Those has become questionable and no recommendations are currently made about that. The other thing which we have to look at is anemia. IV artesunate, what it does is it even kills intra-erythrocytic malarias or parasites. So what it does is it deforms your RBCs. So patients who have received artesunate can have delayed hemolytic anemia or delayed anemia, which has to be actively sought for after cure from malaria at 7, 14 and 30 days. So the next comes the rickettsial disease, which has been in the limelight, scrub typhus. I will be discussing only about the scrub typhus, which is caused by Oruntia shutsugamisi, and it is spread by trombiculid mite. And this is the well-known black eschar. So if you have a black eschar with a typical tropical fever syndrome, it clinches the diagnosis, or it is pathognomonic in 30 to 40% of the patients, but actively look for it in the inguinal creases and axillary creases and in the genitalia, because it may be hidden. So this is the shutsugamisi triangle, where more than 80 to 90% of your scrub typhus happens, and it extends from Afghanistan in the west to Australia and New Zealand in the south, to northeast up to Japan and Vietnam. Yeah. So this is the shutsugamisi triangle, and if you can look at the entire India is within this triangle, and from north till south it has been there is incidence of scrub typhus. Okay. So these things I have already told. So the symptoms wise it will be more or less the same. Again, coming to the diagnosis, again you have a dearth of investigations and you have to rely on your serology. Your cultures can be from your black eschar in the first week of illness. It can show your bacteria, but other than that it doesn't help in diagnosing these patients, and what you rely on is immunofluorescence or ELISA based IgM studies. You look at the titers, and a single titer of IgG more than 1:128 or a IgM positivity with the clinical background which matches it may conclusively give you evidence that this is a scrub typhus is what we are dealing with. Traditionally what we use is Weil Felix test, but it is based on the cross reactivity with the protease antigens. It is neither specific nor sensitive, and better to not use it as a diagnostic modality. So the name typhus comes from a cloud named typhus. Why did they name typhoid and scrub typhus as typhus disease as typhus is? There is a cloud named typhus, and these patients a century ago, when they presented with the clouding of consciousness, they were labeled as typhus. That's why you label them as scrub typhus. So usually previously, when these lab facilities was not there, the scrub typhus was very endemic during the World War II across the Pacific region, when Japan and China had a huge outbreak of scrub typhus. So what they used to do at that time was, they used to do something called as doxycycline challenge test. That still holds good. So when they have a suspicion of scrub typhus, what they used to do is they used to give 2 days of doxycycline, and if the patient responds and if his sensorium and his clinical condition improves, they make a provisional diagnosis of scrub typhus based on that doxycycline challenge. That still holds good. In other words, that if you treat them with doxycycline, still they recover well. Only in the severe diseases, when they go for multi-organ failure, do they require long-term life support. There was a recent study which was published in 2022 from CMC Vellore, where they found that in critically ill patients, when you combine doxycycline with azithromycin, it was associated with earlier recovery from critically ill patients. It's only for severely ill patient. For all other patients, monotherapy with doxycycline holds good. So what did we know from all these slides is that if you have a patient who has tropical fever, suspicious tropical fever, your ceftriaxone holds good for all the diseases except your scrub typhus, and if you add doxycycline to that ceftriaxone, you will cover majority of the tropical fever. That is what we got from the slides which I come across. So that is what it is. And sorry if it is boring, but the thing is, the symptoms are more or less overlapping with majority of the diseases, and that's why Indian Society of Critical Care Medicine, along with infectious disease, came up with a syndromic approach, especially for resource limited setting, and how they classify tropical fever. If you have a patient who has a clinical feature which fits into tropical fever, you label them into these 5 broad categories and start empirical therapy. How do you classify them? Fever with thrombocytopenia, most likely you are dealing with dengue, you don't have any other organ dysfunction, you just resuscitate them with crystalloids and fluids. Fever with jaundice, probably you are dealing with lepto or scrub, you don't know until your reports come, you add on ceftriaxone and doxycycline. If you have obvious renal failure, then again you continue with that. And if you have a patient who comes from an area which is endemic for malaria, you start them on empirical anti-malarial also. If you have encephalopathy, which HSV being predominant, you have to cover HSV also, provided your LP is inconclusive. And if you have respiratory distress in a monsoon season, what we are coming across now, generally we add Tamiflu also. So this syndromic approach, if you use in a resource limited setting, majority of the time may salvage your patients. So this is a nutshell of how you proceed with that. And in all these patients, what we come across, when we come across, since we are in the intensive care unit, we come across a variety of presentations, and what I can tell you is uncommon clinical manifestation of common diseases are far more common than common manifestations of uncommon diseases. So you have to have a wider vision, high index of suspicion to pick up these rare conditions associated with the common diseases and treat it appropriately, and always rely on a good history and the environmental history of the patients to clinch the diagnosis. And always take ID specialists when in doubt. Thank you.
Thank you, doctor. That was a wonderful presentation and very, very important topic for clinicians, and the approach and all things were dealt with nice, and many take-home points were also available. Thank you.
Thank you, sir.
So, any question from audience? So it is very, very important nowadays, especially tropical.
So usually both in sepsis as well as in dengue or any tropical fever where we suspect capillary leak, the fluid resuscitation has to be based on certain dynamic endpoints. So the dynamic endpoints are increase in stroke volume rather than a blind volume replacement of say 10 to 20 ml per kg. So what are the dynamic indices which you can use is when you have a spontaneously breathing patient, the only index you have is your IVC. So you have to do a IVC measurement, and you cannot rely on a single measurement of IVC. What you have to look at is something called as IVC collapsibility index. There are recent studies which compares SVC collapsibility index also, but the more standardized one is IVC collapsibility index. If your IVC collapsibility index is more than 50%, probably your patient is fluid responsive, but it has its own caveats also. Your patient should not have right heart failure, he should not have significant TR. In those cases, this again becomes nullified. So if you have a patient on positive pressure ventilation who is on a ventilator, then you have multiple modalities. You have cardiac output monitor, you can do your echo, and you can look at VTI, velocity time integral. It's a indication of your stroke volume, and after giving a bolus, all these interventions are dynamic because this changes during your cardiac cycle. These are not static. You give 200 ml bolus, you look at the VTI. If your VTI remains the same or decreases, then probably you have already filled the patient. If it increases or if it remains the same, your patient is probably still fluid responsive. Similarly, your collapsibility. After 200 ml of bolus, look at the IVC. If it's still 50% collapsing, patient is probably fluid responsive, give it more. If the IVC gets distended or the collapsibility decreases, probably you have already filled the patient. The right way is to increase the ionotropism rather than filling the preload.
In leptospirosis, previously we did a MSAT and MAT. So is there any difference between MSAT and MAT?
I am not sure about it, sir, but the diagnostic test of choice is still MAT. Your microscopic agglutination test is the foolproof method. It is the test of choice.
DFM, dark field microscopy?
Dark field microscopy, if you have the facility, you can do it, sir. But majority of the time, labs don't have that facility. Microscopic agglutination test, it's not there in Madurai itself. So you have to send it to a specialized laboratory. So easily available within 1 day IgM.
So in a malaria patients, we can take a proper history. By history itself, we can think it may be a malaria. But how many percentage of patients you can get a malarial positivity in your practice?
Sir, malaria, that's what I highlighted. The malaria incidence, at least in my center, being a tertiary center, my incidence is very low, sir. Unless we have the last 4 malaria cases which I have seen, all were African travelers from India. These were all the patients which I come across as malaria in my practice in intensive care.
Have you practiced this? The entity is called clinical malaria.
No, sir.
Not
no.
only if there is a proof, then only.
No, sir. If it is a endemic area, even if you don't have, if you have very high suspicions, we do use empirical artesunate. But our ID people are very particular that not to use it unless your RDT is positive. So what we do is we do it instead of twice, we do thrice RDTs. And if all 3 RDTs, rapid diagnostic tests, are negative, generally we differ from using artesunate, sir. And if you have a good thick smear and thin smear study which can be done by a reliable person, then that is very good.
So in our department, so I am oncologist, so there is a immunocompromised state patients are there, and they most of the patients are taking repeated blood transfusions and everything. So in that time, we are suspecting a clinical malaria because it may be a transfusion-induced malaria. So on that time, we are treating with artesunate or anything, then the fever will respond.
Okay.
And we have to check this temperature chart and pattern of fever, and we can give.
Okay, sir. Okay.
So, okay, thank you.
Personally, I am not, I don't know about it, sir. Sorry.
So if there is no more question, we will conclude the session.
Regarding dark field microscopy, we no longer recommend, sir. Dark field microscopy is not recommended. There are so many false positives. Even for OPC patient, we check now they will be positive. So it's not recommended.
Okay. Thank you.
So once again, thank you, Dr. Ayyappan, for your excellent presentation. Please wait.
So that's what. That's why I told there is no blanket fluid resuscitation, sir. What we come across is whenever these patients go to this sort of multi-organ dysfunction syndrome, generally they have sort of septic cardiomyopathy sort of syndrome where your LV also goes into a dysfunctional state. Majority of them will have some amount of global hypokinesia where your EF comes down to say 30 or 40%. And what we have come across is overzealous administration of fluids have resulted in flooding of lungs and other organ systems that has caused more harm than resuscitating them, especially in our practice. So you use your dynamic indices. If you have a suspicious LV dysfunction, use your IVC collapsibility, use your, I think all the government medical colleges now has the facility of ultrasound in emergency, I think. So you can use your ultrasound, which the point of care ultrasound is the game changer. If you use that, these critically ill patients, the other thing which you can use is your capillary refill time. If you can look at it, there was something called as Andromeda shock trial which was published some 4 years back, where they compared lactate clearance with your capillary refill time, and they found capillary refill time was even superior to your lactate clearance in the laboratory. So you look at your capillary refill time, you look at your cardiac output, and you see there is increase in cardiac output secondary to your fluid challenge. If that happens, use your fluids. If your fluids are not helping, use your inotropes. If the patient remains anuric, support them with life support in the form of CRRT or SLED rather than pumping them with fluids and giving a diuretic to protect the kidneys. Give them time, give them life support. That is going to be the game changer.
Infectious disease is in fact one of the greatest adventures in diagnostic medicine. Man has lived for 5,000 years and still the simple microbe threatens his very existence. Thank you, sir, for your thrilling speech on tropical fevers. I now request our chairpersons to honor Dr. Ayyappan, sir, for his contribution today. request Professor Dr. Madhavan sir to honor our chairpersons today. I request Professor Dr. Madhavan sir to come forward and honor our chairpersons. Professor Dr. A.S. Mohan sir, retired professor and head of Department of Medicine, Tirunelneli Medical College. Professor Dr. Sharavanan sir, head of Department of Neurology, Tirunelneli Medical College. Followed by Professor Dr. Krishnamurthy sir, head of Department of Respiratory Medicine, Tirunelneli Medical College.
Thank you, sir. Our next and last session is titled Third Eye to See the Unseen in Investigations. In the ever-evolving field of medicine, the ability to uncover hidden clues in diagnostic investigations is a skill that often makes the difference in patient outcomes. This session promises to sharpen our clinical acumen and enhance our interpretive skills in complex diagnostic scenarios. We are honored to have as our speaker Professor Dr. Natarajan sir, a renowned clinician and head of the Department of Medicine at Madurai Medical College. With years of expertise and a reputation for meticulous diagnostic precision, Dr. Natarajan sir will guide us through the fascinating subject. Chairing this session, we have an esteemed panel of experts, Dr. Ramasubramaniam sir, Professor and HOD of Nephrology, Tirunelneli Medical College, Dr. Arumugam sir, Associate Professor of Oncology, Tirunelneli Medical College. I welcome the chairpersons to the stage.
Good afternoon, everybody. At the outset,
I invite Dr. Sulaiman sir, Senior Consultant, onto the stage.
At the outset, on behalf of myself and behalf of my coaches, I thank the organizers for giving us this opportunity. Though my professor Muthu Sethupathi sir used to tell, the treatment is for the patient, not for the investigations. As a nephrologist, we are always asked to opine on investigations only. Before, I am very eager to hear from sir what he is going to talk about the third eye. But in this, there is a journal of in nephrology called American Journal of Kidney Diseases. They used to have a section called Core Curriculum, in which they discuss about a particular topic. In the January issue, in this month issue, they have what is known as lab abnormalities in basic metabolic panel. So even before you interpret a particular investigation report, you have to look into the probable errors which would have happened during the pre-analytical, analytical and post-analytical phase of any investigation. So already everybody is hungry. Without much ado, we'll go to the topic straight. Over to sir. Thank you.
President, good morning all of you. I'd like to thank the organizers for giving me this wonderful opportunity to stand in front of you. And I also wish my colleague, my contemporary, Professor Mohamed Rafi, a happy retired life. With that, from blessings from and wishes and greetings from the Temple City, Madurai, I'll proceed with my presentation about this third eye to see the unseen investigations. Because this is I think I can call it as my brainchild, this word. Because nowadays, as sir has pointed out, many times we are flooded with investigations and we do not know how to interpret, or because of want of time, we are not interpreting. Even a simple investigation will give the greatest clue. That's what I have learned from my some 35 years of experience. So if you go through the investigations properly, or aptly said, if you go through in between lines, you need not spend much on investigations. So William Osler, he used to, in his statement, he said, the patient has to recover twice, one from his disease another from the side effects of medicine. But now if he is alive today, he will say, third is he has to recover from the debts incurred for the investigations. They spend lots and lots of money on investigations and ultimately end up in a back to square. So that is the status now about investigations in medicine. And for that we require a third eye. Third eye is, as all of us know, it's a cortex. So don't see the investigation only through your eyes. You use your cortex also. You spend some time on the investigation. It's a property of it's an astute property of a physician. But most of us, I won't say we lack it, but we don't apply it. So at the end of the session, I think you may start applying for all the investigations. So what are the problems we face when we see the investigation report? So error in patient details, very important, because the sex, the age, everything matters, which I'll enlighten in the few next slides. And error in processing the required test, because sometimes a delay in sending the sample, delay in the transit time may affect you, even your sugar level, your ammonia level, everything gets modified if you delay the transit. Or collecting the sample. Example, if you squeeze the muscle excessively, there's going to be traumatic hemolysis and potassium is going to get released and you'll have spurious hyperkalemia. And you will start treating the hyperkalemia unnecessarily. So you have to correlate clinically. But main thing is, today I'm going to highlight only on this, interpreting the result, missing the unit and the comorbid conditions. And the anxiety, all these things are. So this is what main thing as an investigation. So if you see, superficially it looks like only pillars. But if you see in between, there you can see two persons, they are facing each other. So investigations is like that. You have to see both the pillars and the two persons who face each other. And similarly, this will be seen just as a shade of card. But if you see carefully, there is a face in it. So it is Albert Einstein face. So this is investigation. So if we read carefully, most of the time with the simplest investigation, you can make most of the diagnosis. So with that, I'll go through some case scenarios. And so if possible, I'll take through all the scenarios, or if time doesn't permit, I'll stop short with some 4 or 5 case scenarios. So this is a story of I'll start with the basic complete hemogram. He was a 39-year-old male, EC fatigability anemia. He was going from pillar to post for this anemia for the past, you will not believe, 15 years. And the first physician has diagnosed as hemoglobin low. And all of us, the anemia, we think always iron deficiency anemia, but that's not always the case. But so he thought it is low hemoglobin and the MCV is low. So it is hypochromic microcytic anemia. And he started using iron for him and flooded with iron. Patient didn't improve at all. And when he asked, he has told that probably you're losing blood somewhere, so that your hemoglobin is not getting corrected. So he went for a CT abdomen. That was also normal. And 4-bit is the recent test for diagnosing occult blood. Previously used to do occult blood, now it's a fecal occult blood immunochemical test which can differentiate between human hemoglobin and animal hemoglobin. So meat as well as so if he has consumed meat, that will be positive in occult blood. So this is the most finest investigation. That was also done on him. But he didn't click. So again and again, he was even transfused once or twice. So that was the status. Now, if you again, when she came to us, if you carefully see, his hemoglobin is definitely no doubt. And when you see the RBC count, it is near normal. So this can never happen in iron deficiency anemia. So it should be reduced in the red cell mass and reduced in the hemoglobin of individual RBC. So if a simple complete hemogram, this is RBC count is normal. Second, in all iron deficiency anemia, you look at the platelet. Platelet should be increased. Thrombocytosis should be there. So hemoglobin should be low. MCV should be low. RDW. RDW is a marker for anisocytosis, poikilocytosis. Without that, you don't make a diagnosis of iron deficiency anemia. So all the other factors are against iron deficiency anemia. So it was very difficult for us to convince him that it is not iron deficiency anemia. So we took a ferritin, it was normal. So now we are seeing a patient who has got anemia with normal RBC count, with normal RDW, with normal ferritin, but low MCV. So he will boil down to hypochromic microcytic anemia. And in iron deficiency, it's hypochromic microcytic heterogeneous. That will have all populations of RBCs. Anisocytosis, poikilocytosis, pencil shaped. But here it is hypochromic microcytic homogeneous anemia. So the simple complete hemogram should have made the diagnosis of thalassemia trait. So this is most common in our city, Madurai. We have got very many Saurashtra population there. We have got seen thalassemia major, minor, trait, all these people. And only major present in the childhood. Trait, they will be having anemia right from the childhood till the geriatric age, and that doesn't require any treatment. But this patient has spent a lot of money on investigation, including CT abdomen, and he was asked to do nuclear scintigraphy, saying that he may be bleeding at any point of time in the GIT. Only with that investigation, he came to us. And we said, nuclear, it is not at all necessary. This is simple thalassemia trait, and you have been unnecessarily loaded with iron, because they will have hemosiderosis, and which you add iron, that will add fuel to the fire. So the moral of this particular case is, not all anemia are all iron deficiency anemia, and not all microcytic anemia are iron deficiency. There are other causes for hypochromic microcytic anemia, like thalassemia, like anemia of chronic disease, early stage, sideroblastic anemia, all these things, lead poisoning. But we have to interpret only with going by Menster index or looking at the MCV plus RDW. So a simple, so if at all, if you are equipped, you go for what's called as a 5-part complete hemogram. That will throw more light. So complete hemogram is going to, they are going to charge around 600, 700 rupees, that's all. Everything will be over in that. So don't go only with hemoglobin, diagnose anemia. You go for complete hemogram and you have to interpret. That is the message of the first case. And second case, Ayappan sir was discussing about dengue. So this is a classical dengue. Fever, leukopenia, and platelet of 9,000, no bleeding manifestation. And opinion was sought whether to transfuse platelet or not. We know there are umpteen number of causes for thrombocytopenia in dengue. It can be because of bone marrow suppression, main cause, splenomegaly, capillary leakage, antiplatelet antibody, umpteen number of causes are there. And the previous guidelines said that the patient is bleeding, transfuse. That still holds good. And the second is, if the count is less than 10,000, transfuse. But now we want to differ from that. If the patient is asymptomatic and even less than 10,000, you do certain platelet indices and then decide upon the transfusion. So first was about RBC indices. Now I will be discussing about platelet indices. So now the platelet indices, there are two important things. Though there are very many platelet indices, you go by mean platelet volume and IPF, immature platelet fraction. So normal mean platelet volume is around 8 to 12. But if the bone marrow is suppressed, the mean platelet volume is either normal or less than normal. If the bone marrow is adequately responding, it will throw fresh platelets. You will have more MPV. So if the mean platelet volume is more than 12, so we will be having high mean platelet volume plus ongoing thrombocytopenia. It is a peripheral destruction. So we can wait, no need of transfusion, platelet transfusion, because the patient is asymptomatic and the bone marrow is adequately responding. But if the mean platelet volume is low and the patient has got thrombocytopenia, it is bone marrow failure. So these patients require. So all bleeding patients are irrespective of the count. If it is less than 10,000, if the MPV is normal and the second investigation is IPF, this is equal to reti count. So you know reti count is a marker for production of RBCs. This is a marker for production of platelets. So normal IPF is around 6 to 9. So if the patient has got more than 9, that means bone marrow is adequately producing. So we need not transfuse. We can allow the natural bone marrow to produce these platelets. So then the important message of the second is, the investigation you have to read in between lines regarding platelet is, don't be happy seeing only the platelets. And very important thing is, don't go by complete hemogram platelets. It will misread. It will miss the large platelets. It will give a falsely low. So always go by manual platelet count. Or compare both manual and complete hemogram. Complete hemogram platelet may mislead you. So if the manual platelet is low, IPF is high, MPV is high, no need of transfusion. We can wait. So that is the message of the second case. And the third case is, this was a very interesting case. This case was managed in a corporate hospital, and she was a female who was 28 years old. She had paler icterus and normal RFT. Patient had anemia, elevated bilirubin, indirect bilirubin, LDH, all markers for hemolysis. And the direct Coombs test was positive. So on the face, it is striking the diagnosis autoimmune hemolytic anemia. So that was a diagnosis made by that particular hospital, and they have started the patient on steroids. And load steroids, she has developed all Cushingoid features, starting from prednisolone 40 milligram to up to 60 milligram, but anemia never responded. Instead, she developed steroid diabetes, steroid osteoporosis, all this. With that feature, she has landed up with us. And when she landed up to us, it was not pure anemia. It was some pancytopenia was there, and the MCV was 104. And this is again MCV in autoimmune hemolytic anemia. It will be spuriously high, more than 120, because of one is increased reticulocyte count, and there will be clogging or agglutination of the RBCs, and that agglutination will be measured as 1 RBC by the automated hemogram. So you'll be have around 120, 130 such MCV. So that's the point against autoimmune hemolytic anemia. And pancytopenia is not a feature of autoimmune hemolytic anemia unless it Zeeves. You can have platelet plus anemia. But this is a point against. And the peripherals measure hypersegmented neutrophils and leukopenia. So this was suggestive of megaloblastic anemia. And where the first physician went wrong in reading the investigations. Just because patient had jaundice, he thought anemia plus jaundice, young female, autoimmune hemolytic anemia. But need not be. Jaundice can happen even in B12 deficiency. That is because of ineffective erythropoiesis. And this homocysteine also, it has got some property. Ultimately, they'll have indirect bilirubin and elevated LDH. And this is part and parcel of severe B12 deficiency. So he must have interpreted at that juncture itself, it is not autoimmune hemolytic anemia. But what made him stamp the diagnosis was positive direct-Coombs test. But it is said that we can have false positive direct-Coombs test even in B12 deficiency. And it is late positivity in B12 and early positivity. So if agglutination happens after 2 to 3 minutes, it is B12 deficiency. If agglutination happens immediately, it is autoimmune hemolytic anemia. So ultimately, if he has gone through that and the MCV is not favoring and the bilirubin is not that much high, ESR is not that much high, and some amount of pancytopenia is there, and he must have examined for the neurological pattern also, B12 deficiency pattern, and then we had gradually withdrew steroids and started B12. She started responding very well. So again, the moral of the story is not all hemolytic anemia in a young female is autoimmune hemolytic anemia. B12 can also present, and direct Coombs test is not specific for autoimmune hemolytic anemia. It can be false positive in B12 deficiency also. Only the time of agglutination matters. And this is another case of 39 female, fever, low grade pancytopenia. Here the investigations which I want to highlight is ESR is 110 CRP3. So never interpret ESR without CRP. That is a message which I want to convey. And ESR is both of them are acute phase markers. And ESR will start rising from 24 to 48 hours after any infection and inflammation. CRP will start rising quite early. But both of them should go parallelly. Whenever there's a mismatch, discordance between ESR and CRP, almost always it is SLE. So when you got such a thing, you think in terms of SLE. In SLE, the CRP is low because of hyperfiltration, anti-CRP antibodies. And this is a new point which we learned during COVID period. So we had one patient, one VIP patient admitted for COVID pneumonia, treated with the dexamethasone and tocilizumab. He improved, but again developed distress. Then sputum showed Klebsiella pneumonia positivity, and ESR was around 90, but CRP was 0. Leukocytosis was 25,000. So at that point of time, we thought, why CRP is 0? We were not able to answer that. But when we referred at that point of time, it is said that when any patient is on IL-6 antagonist, particularly tocilizumab, that is going to inhibit the CRP formation. CRP can be even 0. So in such situation, don't go by CRP. CRP is the very good, important investigations, but it can mislead you in SLE, in patient of tocilizumab. And this is the common thing. When the ESR is more than 100, there are only 5 infections. Tuberculosis, urinary tract infection, osteomyelitis, infective endocarditis, abscess. Other things are rheumatic disease, rheumatological and malignancy. And now there's an advancement in CRP that's called as CRP velocity. So if and when you get a very stable febrile patient, on day 1 you measure the CRP. And after 24 hours, you measure the second CRP without exposing him to antibiotics. And the CRP, that is, you divide the second CRP, you subtract the second CRP and the first CRP and get the value, divided for 24 hours. And this is the value. It said that the lower the value, the more the chance for viral infection. The higher the value, the more the chance for bacterial infection. So you don't start an empirical antibiotic. That is very important rider if you want to calculate CRP velocity. So that is about CRP and ESR. The message is always combines ESR with CRP. And for follow-up, it is always CRP because the half-life of CRP is 16 to 18 hours. So daily it will come down. Don't follow up with ESR. Or you can follow up with procalcitonin in bacterial infection. That will also come. That has got a much more shortest half-life. But ESR will be persistent elevated for 2 to 3 weeks. So this is a study saying that the median CRP of around 63 and CRP velocity 3.61 in bacterial infection and 23 and 0.41 in non-bacterial infection. And the follow-up is always with CRP or Procal and not ESR. So that is about the message of... So this is again important thing. Procalcitonin. What is the role of procalcitonin now? So this was a middle-aged male admitted with high-grade fever, ESR 88 CRP. So naturally we attempted to make a diagnosis of some infection, Procal 44. So this patient was started on meropenem. Are we justified? Have we read the investigations properly? If you have read about Procal, we will not start because Procal is not only a marker for infection, it's also a marker for inflammation. Ultimately, this patient had a pancreatitis. So that is an important marker. So Procal is now, why do you want to place Procal? Procal, you don't place Procal for initiation of antibiotic, but once the patient is in sepsis, you do the Procal after second day or third day. If it is coming down, then you can de-escalate antibiotic. So the status of procalcitonin now is only for de-escalating antibiotic, not for diagnosing infection. It can be false positive in infection, inflammation, medullary carcinoma of thyroid. So not for diagnosis, only for de-escalation of antibiotic. And this is yet another case often we get in our OPD. A young male, abdominal pain, fever, jaundice, bilirubin is around 4.6, OT, PT, and OT is more than PT. And you could have stopped short with that level. But an over-enthusiastic young physician has done all the viral markers, surface antigen, HCV, everything was negative. And he has even told that because he is quite enthusiastic, there is an entity called mutant hepatitis B, wherein hepatitis B surface antigen will be negative, but hepatitis B DNA will be positive. So that was also done, everything was negative. But if for an experienced or a shrewd physician, what you will do is you just ask the attendants, particularly the wife, to go out of the cabin and ask the patient, have you consumed alcohol? Because most of them, they will not accept they have consumed alcohol. Because this is a classical thing of alcohol. So it is not viral hepatitis because it goes in thousands. And all alcoholics, it's around 400. Only exception is there's a country called foamy degeneration alcoholic hepatitis where it can go more than 1,000. Otherwise, it is less than 400. OT is always more than PT because to synthesize PT, we require pyridoxal phosphate with deficient in alcohol. So a simple interpretation of the investigation, OT more than PT in alcohol, that's all. No need of any other investigation, which was done unnecessarily. And all the infections which Sir has highlighted, we can go by the LFT. I have even talked on LFT infections. If it is isolated bilirubinemia and a fever, it is almost always lepto. If a subtle elevation of OT more than PT, it is either dengue or scrub. But in dengue hepatitis, what is called as expanded dengue syndrome, PT will be more than OT. So just that gives important clue, provided if you interpret the investigations properly. And this is the next small case. This patient was an elderly male, patient unconscious state. He's known CAD, BP 60, Cori. And we didn't know what was the cause for his unconscious state, what was the cause for his drop in BP. JVP collapsed and urea 176 and creatinine 0.6. So that gave the probable clue. So again, when I told about ESR and CRP, similarly, urea and creatinine should go parallelly. For every creatinine 1 milligram, urea should be 20. But there's a mismatch between urea and creatinine. So urea is this much high. Only few conditions produces such a combination. So the first cause could be prerenal uremia or UGA bleed or glucocorticoid therapy, tetracycline therapy. Only these produces a more urea, less creatinine. And so we thought patient crashed because of BP. We resuscitated and found that patient had an ulcer bleed that was probably induced by the dual antibiotic he was on. So interpreting urea and creatinine is always they should proportionately increase. If there is a disproportionate increase, these are the causes. And in the other way, if the patient has got more creatinine, less urea, think of rhabdomyolysis. Think of post-dialysis because urea is more dialysable. So other things, sometimes urea synthesizes in the liver. So cirrhosis, they can have less urea. So just comparing urea and creatinine, you can make lots of diagnosis with that simple. No need of going for other investigations. And this is again 80-year-old female. She was pale and she is a diabetic hypertensive, 46 and hemoglobin of 6 gram. She was unnecessarily investigated for all causes for anemia, including malignancy, about to do a bone marrow. But so here the important point is the creatinine of 1.1. So by oversight, this 1.1 was taken as normal. But this cannot be normal in an 80-year-old female. So only start reading the investigation right from the name, sex and age. As age advances, because of sarcopenia, your creatinine will come down. This 1.1 creatinine is equal to 30 ml eGFR in this lady. So now she is in a more or less in the stage 4 CKD. That is the cause for anemia. The erythropoietin deficiency is the cause for anemia. So now I have asked my lab and even in the GH to calculate the eGFR and give it to us, so that we can go by the eGFR, not by the creatinine level. In pregnancy, creatinine falls. So we have to go only by eGFR. Creatinine alone is not a marker. So ultrasound showed contracted kidney. It was because of erythropoietin deficiency in CKD, and that is the cause for anemia, not because of. And that I think this may one or two cases. Other this may be the last case with the chairperson permit, and because for want of time. So this was an interesting case. Again, this was my own classmate's daughter. She is working as a microbiologist in Canada, and she had a nocturnal itching. And when she went, no other symptom, when she went to the local consultant there at Canada, they have done all this investigation. They made a BMI was 29. By their standards, it is definitely overweight, and by our Indian standard, it is mild obesity. Everything was normal. And investigation done in Canada showed an elevated bilirubin, OTPT was elevated, and alkaline phosphatase, everything was elevated. But it was not alarmingly elevated. So with this, they made a diagnosis of what's called MASLD nowadays. So because she is mildly obese and altered LFT, otherwise not much symptomatic. But MASLD can progress to cirrhosis. Cryptogenic cirrhosis, once upon called as cryptogenic, is always almost to MASLD. She was not comfortable with the diagnosis of MASLD. She said that I was not very much obese. So again, they wanted to do all the markers, which was again negative. And they thought it could be in a female, altered SCOTP, TP, altered, so they thought it could be autoimmune hepatitis. So ANA was done there. Just to highlight that, physicians across the world are all same. So they did a ANA, and ANA was found to be positive. So they branded her as autoimmune hepatitis. And that started the story. Because we know the prognosis of autoimmune hepatitis, it can progress to cirrhosis, warranting even liver transplant. So she called her mother here in Madurai, in Tamil Nadu, and her mother booked a ticket, and she came down to Tamil Nadu for further. She was mentally made and to accept autoimmune hepatitis as a diagnosis. But the very important investigation is ANA should be taken with a pinch of salt. I have seen lots of ANAs positive. ANA can be positive in tuberculosis, in elderly, in pregnancy. So not only in autoimmune conditions. So you go with a pattern also. Sometimes pattern can also be positive. So we did a ANA profile. It was absolutely normal. And autoimmune profile for hepatitis, that was also absolutely normal. So tried to convince her, this is not autoimmune hepatitis. Wait for 2 to 3 months. It may probably settle by itself. But we did not go for further investigation. But since being doctors, both of the parents are doctors, they were very much worried. And they did all the investigation available under the sun, including MRCP, because one of the gastroenterologists told it could be progressive sclerosing cholangitis or primary biliary cirrhosis. I have seen cases personally like this. So that was also negative. And they were ending up even with biopsy of the liver. So you must have now understood how much the pain she must have incurred, how much amount she must have incurred for this. And biopsy also threw no light. Only some extracellular cholestasis, intracellular cholestasis, that's all. So she has spent around 2 to 3 months in all these investigations without any diagnosis. But so she was weeping, and suddenly I asked her, "You are a microbiologist in Canada, what are you doing?" Then she revealed the history. I am basically a virologist, and I am now doing research on Epstein-Barr virus. So then we got the clue. So we did Epstein-Barr virus. It was positive. And it fits in all the pattern. It will produce a protracted cholestatic pattern. And that's a protracted cholestatic pattern. And now we have to explain that. The LFT can be explained to Epstein-Barr virus, her occupation meddling with the Epstein-Barr virus. And how are we going to explain the ANA? So there is a reference that acute Epstein-Barr infection or even reactivation can have high ANA antibodies, which will give the notion that virus causes the dysregulation. So again, ANA, I think all of you are asking for ANA, and we are now signing because ANA we have now got some approval from the other medical labs. So, but be very careful, do ANA only for relevant case. All the cases, no case has come as negative. So though this ANA has spoiled some 2 to 3 months in her life. And now ultimately EBV doesn't require treatment. It's settled on her itself. So interpreting ANA, be very, 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 very careful. Don't brand anyone as autoimmune disease. They can even sue in the court of law. So I think I can end now because it's... so this way I'll tell a short of this story, a short summary of this story. And this was our own case. Patient was a known case of thrombocytopenia. Diagnosed in our IMCU, treated with the steroid, not responded, and then IV immunoglobulin was given. She responded. She was discharged from our IMCU. But after 4 or 5 days, she had headache and she had seizures. She was from Dindigul, so she got admitted in Dindigul Medical College there. And there they made a diagnosis of CVT, cortical venous thrombosis. And so they started the patient on mannitol, dexamethasone, heparin, and she was already on azathioprine. And again, she was referred back to our hospital for further management. And she had a consanguineous marriage, first child, IUD of 10 months. And with this history of known case of ITP, treated, going for remission with the steroids, initially treated with the immunoglobulin, now steroids and azathioprine, admitted for the CVT, and she came back to our GH for CVT management further. And this was her profile. So platelets were reasonably good, and all the viral markers are negative. And we routinely do still H. pylori for this ITP, because if you clear H. pylori, the ITP goes for remission. CT vein for CVT. MRI vein again confirmed CVT, no diagnosis. So one of our female PG, who was the best among that batch, and she was very much interested in the case. She took personal interest, and since the patient had history of first abortion, IUD, then thrombocytopenia, now CVT, so I am thinking in terms of applause. That was her statement. We appreciated her, and she has sent the sample for applause profile. And as expected, it became positive. It became positive. And so how to interpret? Whether are we dealing with the primary applause, because SLE was negative, or we dealing with primary applause, something else. So this was the discussion on that particular day. And then we found out reference that applause profile should not be sent for any patient who is already on heparin. If you send the applause profile in a patient who is on heparin, it will be false positive. So we are about to brand her as applause. Applause means a dreadful disease. You know, antiphospholipid syndrome, she cannot go for pregnancy, or else she should be on long-term anticoagulant. It can produce venous thrombosis, arterial thrombosis, thrombocytopenia, catastrophic applause. Anything is there. So if you had revealed this to the patient, again, the patient will be in a very depressed state. So the current guidelines for laboratory detection of lupus anticoagulants is recommended caution. While interpreting results, patient on heparin, you should not interpret. So this was repeated after stopping heparin. It became totally normal within 3 days or 4 days. So if you are not read that or in between lines that the patient was on heparin, the patient should have been diagnosed as APLAS and must have continued antiplatelets lifelong. That's a very important thing. And anticoagulants. If anyone starts any drug, the another physician finds it difficult to stop that drug because of very many reasons. Because if anything untoward happens, they will blame you. You have stopped the drug. So be doubly sure before initiating the drugs. And now coming to what was the cause for CVT, this is an interesting case because IVIG itself can produce CVT. There are very many mechanisms. Postgraduates can go and read. There are mechanisms for IVIG induced cerebral venous thrombosis. That was the cause. So it is not a plus. So it is basically a case of immune-mediated thrombocytopenic purpura treated with IV immunoglobulin, steroid, azathioprine, developed CVT, was put on heparin, and heparin has produced false positive lupus anticoagulant test. And once you withdraw heparin, that lupus anticoagulant became negative, and the cause for CVT is immunoglobulin, IVIG. So that was the moral of the story. So again, I thank you for your sincere patience of hearing this, though it's lunchtime. So again, I thank the organizer and I wish Rafiq sir, really I think the happiest person today will be Rafiq sir, if I am correct. Because we had mixed feelings when we are about to get retired. It was in those days. But nowadays, I think we are eager to wait, eager for retirement because of all the meetings, administrative clutches, all other things. So I'm also eagerly waiting for my retirement. So the times have changed. The only reason we were attached to the institution was because of teaching. And now we are not allowed to teach much. Most of the time is spent somewhere else. And now are we justified in calling us professor? Sometimes we used to think. Because we are attending all sorts of unnecessary meetings, which I don't mind saying, insurance meeting, other meeting, in the meeting, and most of the time is gone in there, and we are drained. So I think Madam has pointed out retirement is not a sorrowful function. In the current era, it is the happiest function. Thank you, sir.
Thank you, Professor Natarajan sir. My association with him was in 95-98. I was a PG student of him, my teacher. I'm really happy, and you have nailed it. What I have seen 35 years back, the same zealous and vigor is there, and you have clinched everything in a very elaborative way. And it is an eye-opener for many of us, even for practitioners, senior practitioners, and it is going to be very useful for the postgraduates who are going to be the budding doctors now. It's open for discussion. Is there any question?
It's a very nice discussion, sir. We also learned a lot of things from your presentation. So, and the postgraduates also should know how to interpret. You can order for the so many fancy investigations, but you should know how to interpret an investigation, and always you have to order the investigation depending upon your clinical examination, and relevant investigation is mandatory. So with this and another thing, investigations can mislead our diagnosis also, especially for the imaging like CT or MRI. They will give the pathological diagnosis by the CT or MRI. That may lead our diagnosis as in a wrong way. So we have to be always go along with our clinical examination and history, and then we have to order for the investigation. Thank you very much, sir. So if there is no more discussion, we can conclude the session, sir. Thank you very much, sir.
It takes sheer will. It takes sheer skill to be able to read between the lines of investigations and superior clinical acumen to clinch diagnoses. Thank you, sir, for your enrapturing talk on how investigations are more than what meets the eye. I now request our esteemed chairpersons to honor Professor Dr. Natarajan sir for his session today. Professor Dr. Rajesh sir, Chief of Medicine, to honor chairpersons today. I request Dr. Rajesh sir to honor Dr. Sulaiman sir. Request Dr. Rajesh sir to honor Professor Dr. Mohamed sir, Head of Nephrology. Head of Department of Nephrology. I request Professor Dr. Rajesh sir to honor Dr. Arumugam sir, Associate Professor of Department of Medical Oncology. With this, we come to the conclusion of our final session for the day. On behalf of the organizing committee, I would like to express our heartfelt gratitude to all our distinguished speakers for the enlightening presentations and for sharing such valuable insights. Your expertise has truly added immense value to our program. I also extend my sincere thanks to our chairpersons for their guidance and thoughtful contributions during the session. A big thank you to all the delegates and participants, both in person and virtual, for your engagement, enthusiasm, and dedication throughout the event. Your presence made this CME a true success. As we wrap up the scientific sessions of Rejumed 25, let us carry forward the knowledge we have gained today into our practice, ensuring better care for our patients. Thank you all once again, and good wishes to our beloved Professor Dr. Rafi sir as you step into this new chapter of life. May it be filled with joy, good health, and cherished moments. Your legacy will continue to inspire us all for years to come. Thank you.